keep that spirit up. And so, it is my privilege to introduce the president of the University of Southern California, Dr. Carol Folt. And when it's said that success leaves clues, one could take a look at her leadership style and her achievements, her accomplishments, and say amen. From Dartmouth and the Ivy League to the chancellorship of the University of North Carolina at Chapel Hill, arguably one of the best public institutions in higher education, to the presidency of USC, arguably one of the best private institutions in higher education. Through her leadership style, compassion, and courage. Thank you, Dr. Folt. So let's please give a warm welcome to the president of USC, Dr. Carol Folt, bringing greetings.
Thank you, Dr. Stroman. Thank you, Debbie. It is it's really a privilege to be here. I am so excited about this event. And I'm going to start by just saying a few things about Dr. Stroman, because we met when I came to UNC. And when I met her, she was a professor there teaching, doing all that, but she was also the head of the Black Caucus, which was the faculty and staff caucus. And, you know, I get goosebumps when I think about it, but she taught me to dance, line dancing. I was never very good. But more importantly, I watched the way she developed that leadership in that community, and I learned so much from her about that, and I learned poetry that has stayed with me, and I've learned how when someone deeply, deeply cares as a leader, that really has the transformative power that we're all seeking. I also learned about brain health from her. You've been working on this since I first met you, and she was trying so hard to bring data into these conversations. So we've been in touch just a little bit since I left UNC, and I got a note from her, and she said, we're doing this brain conference, and it sounded so great, but I couldn't actually realize that it was actually happening here at SC. I thought, oh, she's just telling me how cool this is, and then it's here. So anyway, my thought was, what a great privilege that you would have your first meeting here. And you have amazing leadership, and you are working on something that is so important, Black men's brain health. You know, I was thinking if I would say to students, it's great to be strong, it's great to be fast, it's great to be all those things, but your brain is so precious. And in education, in sports, in life, we have to do what we can to protect people's precious brain. So having this work here, having you all here who clearly care deeply about this issue, just matters a lot. So I'm pleased to be able to welcome you. I know you've been having these amazing opportunities to talk. I know you could have had triple the number if we weren't quarantined, but we're getting out of it. I have optimism. I did read that LA might be the last city in the world that ever lets anyone get away with masking, but you know, it's been serving us pretty well so far, and I hope we'll treat the pandemic with the intelligence that we need, and I hope that we'll learn to teach our young men's brains with the intelligence and the power that you all bring to it. So, you know, you've got this amazing set of people here. I know you're going to other great institutions. I love the consortial nature of this, because no university, no Alzheimer's center, no single hospital, nobody's gonna do this alone. We don't have right now a great set of leadership even at the NCAA level. There is so much happening in sports that makes it hard to do things, but when you have a consortium that really cares, I do think that passion will help us make real progress here. And you do need your universities, you need your presidents, you need your FARs. We have amazing FAR. Alan Green is fabulous, but you need your athletic directors. Everybody has to be committed to this. And I think that you're getting out to those campuses and getting the students to also be understanding it is important. It will help us accelerate clinical trials. Turns out SC, which I'm sure you know, is a major player in Alzheimer's research. So I see there's a method to the madness that would bring you here, but they are so committed to it, and I think that gives us a chance to make sure that that is included in our focus. And you know, it isn't, of course, just Alzheimer's. There's all sorts of other aspects of people's lives that are affected when their brain is injured. We have our great doctors here. We have the dean of our School of Social Work here. I mean, people will care, and if the universities care as a whole, and we work together as a consortium, it will be important. But we can't be afraid to say that this disproportionately is affecting Black Americans. And as far as I understand, that's true for Alzheimer's too. We know that there are health disparities in America, and we have to be unafraid to say it, as you are doing, to realize that by saying it, we can understand that every solution is complicated, and it needs to address specific populations in specific areas in ways that can be really effective. And I really appreciate that about how you call this initiative out. You make it very clear, and that is something that's really important. And I think, the NIH, that Unite initiative, all the things that have been coming together are really going to be powerful. And I think we really want to do that. So as I talk to Dr. Stroman and Dr. Turner and all of you who are here, I understand you're going to be introducing a new initiative to create a men's brain health registry. That is worth 1 million fight-ons. Since you're at SC, we'll fight on that. That is wonderful. And I guess I'm pretty slow to the picture to understand that, of course, this is taking place in the week before the Super Bowl, which, by the way, is happening here. I'm running in place like all presidents are these days because we have got 1 million things. But, of course, the timing is perfect. The issue is important. It doesn't miss my mind that it's, of course, also happening in the time of the Olympics. And you may know that our commencement speaker is Allison Felix, who is wonderful. An SC graduate in the School of Education. Her story is magnificent. And we all know that brain health can affect all athletes. These are things that are really wonderful. So the convergence is very important. And aligning that with the NFL, with our college sports, and all the things that you're trying to do for students is just amazing. So I really just was pleased to be invited, get to see my friend again, see all of you, and know that we are here and we're with you. And as this develops, I'm going to make sure that I get to hear about it. I'm sure I will. A president doesn't say that once and not get to hear about it. So I will definitely get to hear about it and do what I can. But thank you, and I just wish you a wonderful second day, because the first one sounded really amazing. Thank you. Thanks.
So at this time, it is, I guess a little pause, and I thank you again to Dr. Folt. Thank you. So we are going to start day 2 with welcome and opening remarks from Dr. Aranda and Dr. Burton. Thank you. And if I'm not mistaken, don't we have a celebratory clap? She is a full professor now.
Yes, thank you, thank you. Thank you, Debbie, I appreciate that. Thank you. Life is good, isn't it? All the time, exactly. Good morning to everyone, bienvenidos. This is really a momentous occasion. I'm so thrilled to be here. First of all, have the president of USC, Dr. Carol Folt, to be here. My dean, Dean of Social Work, Dr. Sarah Gellert. The dean of the School of Social Welfare at Berkeley, Cal, Dr. Linda Burton. So social work is represented in the House today, and that gives me a lot of joy, a lot of joy. But I'd like to thank the PIs, the principal investigators of the grant that they had to write. They had to hold their breath and hope that it got funded to be able to do what we're doing today. So, Doctora Rivera-Mindt, Dr. Robert, gracias por todo, Turner, and where is Carl? Where is Carl Hill? He's on his way, the other doctor, right? I want to give them all a round of applause right now. because without them, we would not be here today. And so we really are embarking on a momentous occasion. And look at the beautiful weather that we have now. Mother Nature showed up, and she's showing off. And we're here in a week that I'm telling you, you could turn on the TV, the radio, social media. We have the Super Bowl this Sunday in Los Angeles. And I'm thrilled about that. Because Los Angeles is an interesting town, right? Los Angeles County, where we have the good, the bad, the ugly, and everything in between. But when we have the celebrations that we have this week, we really should be celebratory. And I'm going to say a little bit about myself. I'm a trained social worker in geriatrics and gerontology, and I'm also a psychotherapist. So many of the comments and the discussion that we had yesterday really resonated with me. But I have a confession. You may have noticed I'm not an athlete. I never was, and I probably won't be an athlete, though I did hear the saying yesterday that if you have a body, you're an athlete. We'll see about that. But the other thing I wanted to say is that although I'm not an athlete, and as I said, never have been, I used to be on the sidelines at all the school games. And partly, that's where I developed my analytic skills, right? I would sit there, I'd be the informal cheerleader, not a formal cheerleader, because I couldn't even do that. But I cheered on the team, whether it was on the field or on the court. And I developed the skill of observing patterns, right? Because you have to have a game plan, you have to have a strategy, and you have to execute that. And so I observed that. I observed the patterns. That's what epidemiologists do, right? We observe patterns. But I also observed the social interactions that occurred, right? Who was friends with whom, the dynamics, the group dynamics, and that's what social workers do, right? We identify group dynamics, we foment group cohesion. And lastly, I looked at that raw grit, the persistence, that narrow focus of the players, and really that heart that they put into the game. And so as a sideliner, somebody who was on the sideline during the games, those are the kind of analytic skills that I brought to the table later on in my life to be able to make those observations. Who would have known? And today I'd like to share with you two observations that I made yesterday as I was on the sideline, listening intently, and really appreciating the knowledge that came out yesterday. And the knowledge that came out in different methods. It wasn't dry knowledge where you were being talked at, right? It was knowledge where people were interacting. At some point, I thought I was church. And when you opened up, Debbie, the fact that giving testimony, I said, I am in church. So thank you for that. But two observations I'd like to make is, it's incumbent upon us to change the narrative. And it's hard for scholars to do that, right? Because when we write a grant, we have to show significance and impact. And what do we get carried away with? Statistic number one, statistic number two, we use the word epidemic, we say a public health burden, and what we do is we start forming a narrative that suits the needs of the NIH funders, of other funders as well. But it really steeps us into a negative narrative about our communities. So we find ourselves teeter-tottering between that significance and impact, and at the same time, understanding is that narrative has to change. And we have to be more positive about that narrative and really uplifting the people that we advocate for. The other observation I wanted to make is that we did something yesterday that was really interesting, and as a social worker, we understand systems. We understand that individuals and families are nested within institutions, societies, groups, etc. And those institutions and those groups and societies influence individual and family behavior. And they can make or break a person's ability, a family's ability to thrive. So as social workers, we look at those systems and systems of care. So on one side, we were looking at what happens when the pro athlete, male or female, receives a multi-million-dollar contract, and all of a sudden they don't know how to manage that money. We could easily just put the blame on the individual, but we have to look beyond that and look at the systems that may be encouraging certain behaviors and certain normative ideas about what it means to be successful. So I'm going to talk about just a few examples of some of the systems change we have to make. Is number one, the labor market. We have to change those structures in the labor market that, well, yesterday was a good example, how our women athletes are receiving abysmal salaries and incomes, even when they're out on the field or the court. So we have to change that. And we have to change that occupational segregation that occurs, that we have the gladiators on the field, gladiators on the court, but the coaches and other administrative staff in the big house. So that has to change. The other thing is how our school systems are set up. If we look at schools that have large or high minority enrollment, their teachers are not as prepared, don't have the certifications and the training and that expertise as you would see in other communities. That has to change as well. The mortgage market and lending practices. Our communities need to have low interest loans to buy that first house and to guard the wealth that they acquire over life and transmit it across generations. And lastly, the healthcare system. We cannot no longer afford jails and prisons to be the de facto mental health system for our communities. And second, we know that implicit bias and health stereotype threat is in the healthcare system. I could give you a whole Bible of interactions that I and my family have had in that regard. And those types of biases and threats, what do? They make sure that individuals and families in our communities don't partake of health and wellness, including brain health. So with that, I'd like to end just as a acknowledgement of the emerging scholars that are in the back. Emerging scholars. As I said to you this morning, you have a lot ahead of you, but you have great people behind you. And they're all here, and we will not forget you. And I'm going to end with a Spanish language proverb. Haz bien y no mires a quién. Loosely speaking is, do good, do what's right, and don't care about what other people are saying. With that, muchísimas gracias. Thank you so much, and enjoy your day. Thank you.
Dean Burton.
Well, start out by saying good morning, good morning, good morning, everyone. It's really, really great to see you. My team and I are representing Bear Country. We're right over there. But more importantly, we are here representing the intersection of social justice, sports, and social welfare, and how we think and pay attention to identifying the challenges that exist in that area, but also how we can harness the strengths of athletes and bring those strengths to the table in a way that invests in long-term sustained social change at this pivotal point in historical time. At our table over there, you're going to see Veronica, Katrina, Rolanda, and Brian McGee. They're my on-the-ground Delta Force because they understand the urgency of this charge. Central to what we focus on has been a primary emphasis of this conference on Black male athletes. We are very clear in our purpose that we want to increase the presence of men of color and athletes in particular in social work as agents of social change in community. Brian McGee, can you stand up for just a minute? Brian McGee, as you heard yesterday, leads with love. We can vouch for you that that is his authentic self. We want to produce more Brian McGees because we see Brian changing lives every minute of the day in the process of his work, every single day. Seated next to him is his wonderful partner, Rolanda McGee. Rolanda, could you stand up for just a minute? Okay. Now, we know we're focusing on men in this conference, but men don't do it all by themselves. Right. And I want to make sure that we celebrate Rolanda's contribution because on this team, they're an incredible married couple who model to all of us what a good relationship looks like, and more importantly, they model that for the kids in the high school and in the communities within which they work. So I want us to give them a round of applause because they're doing the hard work on the ground. Thank you so much. Now, as I said, we need more Brian McGees, but we also need more Rolanda McGees. We, as a team, Team Berkeley Social Welfare, want to thank you so much for inviting us here and to also let you know that Berkeley Social Welfare is rolling up their sleeves and ready to partnership with you all the way until we reach the successes that we're looking for in our communities going forward. So thank you so much.
So at this time, I have the wonderful, wonderful opportunity to introduce two superstars that you met yesterday. And I want to start off by introducing Tia Delaney. She's a registered nurse and current founder, president of Eyes of Love Nursing and Wellness. With over 28 years in the healthcare industry, she's overseen the various facets required to deliver quality and competent clinical care to thousands and thousands of people. You mentioned the Black Nurses Rock yesterday, so we thank you for that, and the way she expressed how they do things differently and they make things happen. But in addition to her delivery of clinical services, she oversees the community-based health and wellness seminars. We talked about the importance of education in our communities. And these focus on providing insight and resources that empower others in areas. So welcome, Tia. Please join. Thank you. Edie Yao. I met her online probably about 6-7 months ago. She is one of those quiet storms. And I think every team needs a person like that. She quietly gets things done, and she makes things happen. Thank you. She is the Director of Diversity and Inclusion for the Alzheimer's Association. In her tenure, she's led innovative programs such as the Asian Dementia Care Network and the San Francisco LGBT Dementia Care Project, to raise concern and awareness in diverse communities. She serves on the California Task Force on Family Caregiving and currently serves on the California AARP Executive Council. She's been in this field of aging for more than 25 years and has an MA in gerontology. Edie, thank you. Please.
Good morning, everyone. It's great to be with you. Well, I think Dr. Folt really shared the spirit of what we're going to talk about today, which is all about collaboration. And so happy to have NorCal well represented here. So next slide, please. I just want to give a pause to and think about the Alzheimer's Association and how far we've come. It was founded in 1980 and around a kitchen table probably. But one of the significant milestones in our lifetime of understanding Alzheimer's and the awareness of Alzheimer's, one of the milestones was when Ronald Reagan had announced his diagnosis of Alzheimer's. It was a letter to the American people in the newspapers and acknowledging he was told he had this diagnosis, and we never saw him again. He was not in the public eye. And so when we talk about the stigma around this disease, and then fast forward to this year, or last year, we had Toni Bennett perform, and his family is eyes wide open talking about Alzheimer's disease. And so that's progress. That is tremendous progress to raise that level of awareness of Alzheimer's. And so our work, People in Science, you heard a lot about the science, the health disparities work, how important that is in our movement. And we need all of you to be involved in this. The conversations we're having today is so important. And Tia and I, the work we do is really about engaging our communities and our people. Next slide. You can't get more sports than this week. We've got the Olympics, we've got the Super Bowl coming, and I want to highlight a couple champions of ours, Jeff Henderson, Olympic athlete, and Quinn Early, professional athlete as well, playing NFL 12 seasons. But we need their stories, and we need more people like them to share their stories about Alzheimer's and how we can do something together to change the course of this disease. Next slide. So the Alzheimer's Association, we put on a facts and figures report every year, and you heard quite a bit about the special report yesterday from Dr. Hill, but I do want to just highlight in terms of the numbers. There are over 6 million people in the United States with Alzheimer's, and it continues to grow every year. And you can see the cost. You can see 1 in 3 people, seniors, will die of Alzheimer's. And so it is a very serious issue that we're all coming together on. Next slide. But I want to focus on California. And in California, the great state of California, we also see a projection of a 22% increase by 2025, which is only 3 years away. And it is also the most racially, ethnically diverse state. And we're seeing a tripling of people of color impacted by Alzheimer's. And so that stigma of, I've never seen anyone, I don't know anyone with Alzheimer's, is really not true anymore. It's changing, and pretty soon, if we don't see some changes, everyone will have someone impacted in their family in some shape or form. And so Black Americans with Alzheimer's will triple by 2040 to 91,000. Next slide. So I want to highlight some things that California has been doing to address Alzheimer's. And one of the things is our governor had issued and initiated an Alzheimer's prevention and preparedness task force. And this was a group led by Maria Shriver to really think about and come up with some recommendations for how we deal with Alzheimer's. And they came up with 10 recommendations. In addition to that, the governor also initiated a master plan for aging, and we are celebrating the first year of having had that in place. So the master plan for aging has 5 bold goals. Alzheimer's disease is very much woven throughout that plan, as is equity. It's providing systemic solutions to systemic problems, isms, if you will, racism, sexism, ableism, and ageism. Additionally, the Alzheimer's Association has partnered with the CDC to create a Healthy Brain Initiative. And in that roadmap, we had identified ways that the state and local entities can partner around public health to address Alzheimer's in a public health space. And so California in 2020, the California Department of Public Health actually issued grants to local health jurisdictions to start to do some of this work. And so we have 6 local jurisdictions that have actually done something around Healthy Brain Initiative. Several of those have covered and made sure that African Americans are one of the target populations that they look at to think about how we start to raise that awareness and how we address brain health. The Alzheimer's Association has also sponsored a bill recently, AB 1618, led by Assemblymember Aguiar Curry, to create some of this momentum and to have the CDPH house and be the office of the Healthy Brain Initiative so that we can continue that work that has already started. You heard Dr. Folt say that USC is one of the places of Alzheimer's disease centers. We have 10 in the state, which is pretty phenomenal. 10 Alzheimer's disease centers. Next slide. So national partnerships, local partnerships, these are all really important for how we engage people in communities. And you heard some examples. Yesterday, AME, we are hosting a Purple Sunday event again this year in March to really bring together congregants, anyone connected with AME to learn more about Alzheimer's and how to get involved. I also want to welcome our one of our newer partners, American Association for Men in Nursing, who's been here and helping out, so thank you very much for being here. Next slide. Other examples of how we've partnered in communities. So NFL Alumni Association has been a love of mine for the last year, working together with Dr. Turner and others. But we have actually started doing a number of webinars for the members of NFL Alumni Association to start to talk about what is it and how do you actually deal with it? And the questions that we get asked are, how do we reduce our risk? You know, where do we go for help? How do you talk about this? And we also had American Association for Men in Nursing talk about, from a male perspective, how do you actually deal with Alzheimer's or caregiving issues? These are the important conversations that people are really looking for actually in communities. Other types of programs that we've offered are Black Men and Dementia. Let's really talk about this in a safe space. This is much better, it's in person, but also virtual. So that was something that was done locally. And in addition, we also had one that talked about addressing the health equity issues around the research, so the recruitment and retention issue. And that was in partnership with, in addition, NFL Alumni Association, Black Nurses Rock, and Association of Black Women Physicians. Are there any more slides? Maybe that's it. And now I will turn it over to Tia Delaney, but I do want to also give some acknowledgement to Gloria Brown, who's in the room, a partner that we have worked with locally in Northern California in the Bay Area. And so, you know, if anyone is interested in learning more about from a community perspective, you know, what are the needs and what do they want from partners and from organizations like us, she is a great contact to talk with. Thank you.
Thank you so much, Edie. As previously introduced, my name is Tia Delaney, and for many years I was a volunteer community educator for the Alzheimer's Association. But now, full circle, I am the new Director of Diversity, Equity, and Inclusion for the Alzheimer's Association California Southland Chapter. And so today I'd like to speak to you for a few moments to discuss how the Alzheimer's Association is being intentional about their commitment in ensuring diversity, equity, and inclusion are weaved throughout all pillars of the association. Oh, go ahead, sure. I'm a little taller than Edie. Systemic racism and social injustice permeate all aspects of society and are intertwined with the causes of health and healthcare disparities for African Americans, Hispanics, and other diverse communities. However, here at the Alzheimer's Association, although challenging, we know it is essential that we create a society in which all people feel safe, cared for, and valued. Our goal of addressing health disparities are ongoing and always expanding, and with each strive to deliver equitable services and resources, we must ensure that we maintain our 5 areas of focus: agility, integrity, responsibility, community, and inclusivity. So how are we implementing these areas of focus within the Black community? Well, for one, we are identifying and addressing barriers that are prohibiting education and resources from reaching the community. And how are we doing this? Well, with me here now. We at the California Southland Chapter in 2022, we plan to be boots on the ground by going out into the community instead of waiting for those in the community to reach out to us when they are in need, because by then it is often too late. In other words, we want to be proactive instead of reactive. And we as a team are strategically identifying community leaders of organizations which not only serve the Black community, but are trusted by the communities in which they serve, which is very important. And we are then setting up discovery meetings to begin building trust with those community leaders and really listening and being culturally sensitive to their perspectives, concerns, and ideas. And then armed with this valuable information, we are going back to our chapter to collaborate with other departments and share what we have learned. We then plan to have community forums in which we engage directly with the community members themselves to obtain further information related to gaps in resources, education, and support, and to really identify what they believe they need instead of telling them what we have to give them. Because we know that cookie-cutter planning results in poor outcomes, and therefore our goal is to be less focused on our intent and more focused on our impact. Number 2, we are increasing our reach and mission engagement levels. Our mission engagement is to ensure that our products are developed in new and innovative ways, but always with our mission of supporting all those facing Alzheimer's and other dementia, those providing or influencing their care, and those accelerating science. So at the Southland Chapter, we have begun the process of reviewing all of our educational videos and presentations to identify what changes are necessary to ensure the diverse population we serve are reflected in the materials we utilize. It is unacceptable and actually contradictory to go into a Black community and preach about your pledge to DEI, yet distribute materials and resources in which they do not see themselves represented. And 3, improving physician awareness. Our association nationally has developed and implemented the Alzheimer's and Dementia Care ECHO program. And this is an amazing 6-month program that connects dementia care experts with clinicians and provides free continuing education sessions and case-based learning that enables these clinicians to better understand Alzheimer's and other forms of dementia, along with the high-quality person-centered care that these patients require. And after participation in this program, 94% of surveyed primary care providers stated that they made changes to the ways that they care for patients with dementia. We are all aware that Alzheimer's disease disproportionately affects the Black community, and that Black men are 2 times more likely to develop this disease compared to their white counterparts. The Alzheimer's Association understands the significance of educating physicians on the importance of early detection and diagnosis in the Black community, and the value that it will provide to the quality of that person's life in all of those who care for them. Next slide. So here is a listing of just some of the organizations we are planning to or already have reached out to. See, the AME Church, which we have a national partnership with, however, our chapter is reaching out to California-based church leaders in order to begin those local community engagements. The Center for Health African American Men through Partnerships, or CHAMP, 100 Black Men of Los Angeles and Long Beach, and I know someone from 100 Black Men of Long Beach was here yesterday, so thank you so much for attending. A Mega Sci-Fi Fraternity, which we have national partnerships with and have begun the process of reaching out to their locally based chapters, and the National Action Network Los Angeles and Orange County chapters. Next slide. So I want to stop here and share a little story with you. So as a nurse during this pandemic, I often volunteer within pharmacies providing COVID vaccines. And so I was working in a store, and I won't release the name of the store, but one of those stores that have a pharmacy within them. And I'm in the bag, in the vaccine prepared, and I hear some commotion in the front, and it was our pharmacy tech, and she was probably about between 25, 28, young Hispanic woman, and she's talking to a gentleman, and I can hear it escalating, but I continue to mind my business. And then I heard our pharmacist, and he was a Japanese gentleman, and I know this because we've had conversations, and now he's talking, and so I begin to perk up in the back, and I could tell the gentleman they were speaking to was a Black man. So I said, oh, let me go on out there and see what's going on, right? So I come on from behind the back, and on this side of the counter is our pharmacy tech and our pharmacist, and on the other side of the counter was a Black man. And he appeared to be probably about 65, 70 years old. And he was disheveled. He wasn't dirty or unclean, just disheveled. And I could see he had his COVID card in his hand. And so he's really talking to them. He's saying COVID and booster. And they're talking to him and saying something about an appointment. But all I could really gather from standing on the side was that they were all speaking English, but no one was understanding or listening to each other. And so I looked at the man, and I realized that he looked really confused and almost dazed. He wasn't hearing them. And it automatically triggered me to think something is going on with him. And so I said, hey, do you guys mind if I intervene? And actually the pharmacy tech was relieved. She's like, oh yeah, come on in. So I said to him, hi sir, my name is Tia. And I think that's the first thing you have to do to diffuse a situation. And I said, what is your name? And let's just say John Johnson. And I said, okay, Mr. Johnson, how can I help you today? And still with that COVID card in his hand, he said, I want to get my COVID booster. And I said, okay, well, do you have an appointment? He said, no. So then I say, well, do you mind if I come from around the counter to the outside and speak with you? Because I wanted him to know what my actions were going to entail. And he says, okay. He wasn't happy, but he said, okay. So I go around, and now we got a little crowd gathering, in the store, and I'm like, okay. So I go around, and as I'm talking to him and looking at his card, I realize he had his other COVID shots. And I'm looking, and I'm like, this man could not have driven to this store. So I say, sir, how did you get your other COVID shots? Who took you? And he says, my mama. Now again, this man looked like he was about 70 years old. So I said, oh, okay, well, who brought you here today? And he said, my mama. And a few women in the back began to laugh, like, his mama. But you know what? I'm a black mama. And something in my spirit told me there was a black woman in this store looking for her son. And so I said, well, can you go get your mom? And he said, okay. And he walked on away, and then the crowd kind of dispersed, but some people hung around to see if this woman was coming back. And lo and behold, a few minutes later, pushing her cart in some beautiful pale blue pants and her little black purse on the cart, came his mama and him. I knew it. And she looked so afraid and anxious, and I made eye contact with her and went towards her, and I said, hey, my name is Tia, I'm a nurse, and kind of told her what happened. And she was so apologetic, you know. There was no need to apologize, but then I said to her, you know, may I ask if your son has any mental health issues, realizing that he probably wasn't really even 70, he probably was about 50-something years old. And she said, yes, and we've been told he has something like cognitive impairments, which really burned my soul. I hate that when it comes to a diagnosis. So I told her I was a volunteer with the Alzheimer's Association, gave her the phone number, and advised her to really call and get some information, and also to follow up with the physician, because I really felt her son might be dealing with some type of Alzheimer's disease or other dementia. And then they walked away, and I asked if I could go to my car, because I was filled with so much emotion. I was so grateful that I was there, but I was angry that I had to be grateful to be there, and wondered if I had not been there, what the outcome would have been in that situation. Can you put that slide up, please? And that is why this program here, the Mental Health Intervention Training, is so important. This is not a program designed by the Alzheimer's Association. It's actually a requirement of LAPD first responders to go through 4 days and 40 hours of mental health intervention training. But what we have done at the Southland chapter is obtain a grant to go in twice a month with these officers and provide additional training about Alzheimer's disease and other dementia to educate them on signs and symptoms, on triggers, and on interventions and tactics to perhaps diffuse a situation. Now, there is a book by former Eagles linebacker Emmanuel Echo entitled Uncomfortable Conversations with a Black Man, which discusses the importance of removing barriers surrounding conversations on topics considered taboo or stigmatized in the Black community. And although he doesn't specifically mention Alzheimer's disease, he does talk about mental health and what not having a diagnosis or treatment can manifest into. So we need to start having these uncomfortable conversations with our first responders. And to those who state, well, they're police officers, not social workers, I simply say, yes, I agree. They are officers, but their motto is to protect and to serve. And it is our hope that these programs and others like them will enhance their continuing efforts to better protect the communities that they serve. First responders are doing an amazing job and have a hard job to do. But we have all seen far too many examples of the shoot first, ask questions last response that happens to a Black man when their behaviors cause confusion with some Black officers, with some police officers. So our goal is to create an environment in which there is less shooting and more asking. Next slide. So here's a brief summary of the valuable services our organization provides. And like Edie said earlier, really at the backbone of all that we do are our volunteers. So I'm so happy that Ms. Gloria Brown is here. I'd also like to point out the bottom bullet that we have a page that was designed by our national home office, and it's the Black Americans and Alzheimer's resource page. And this is where you can go. It's a site launched that is designed specifically for the Black community to find statistical data, resources, education, and other items directly related to them. Next slide. And that is our 24-hour helpline number where you can find someone to answer your questions 24 hours a day, 7 days a week, in almost any language available. So on behalf of Edie, myself, and the Alzheimer's Association, I thank you. And I hope, no, I know you're going to enjoy the rest of this conference. Thank you.
Hello and good morning, Black Men's Brain Health Conference. How are we doing today? All right. Okay. How are we doing today? Let me hear you. Let Zoom hear you. Here we go. Hey, good morning. So welcome again. My name is Dr. Monica Rivera-Mindt, and I'm the fearless co-leader of this program with Drs. Robert Turner and Dr. Maria Carrillo and our whole Black Men's Brain Health team. And I have the incredible honor today to introduce a fellow Los Angelino. I am a daughter of this beautiful city as well. I live in Harlem now, but I'm from Los Angeles. And I have a great person to introduce to you today, a fellow Los Angelino, a fellow neuropsychologist, Dr. April Thames. Now let me tell you a little bit about April Thames. Dr. Thames is an associate professor in residence in psychiatry and biobehavioral sciences at Semel Institute for Neuroscience and Human Behavior at UCLA. That's a lot of words. And she is an incredible leader in the field of neuropsychology, neuroscience, and cultural neuroscience, and has been making a tremendous difference for years and years in terms of advancing brain health and equity for diverse communities all over the country. And I have found her to be a true sister in getting through this field together, where there are not many people who look like us and do what we do. And it has been an honor and a privilege to serve, to lead with her, and I am so delighted to have her be our keynote speaker today for our inaugural Black Men's Brain Health to discuss sociocultural factors in dementia and Alzheimer's. And please take it away, Dr. Thames. We're so grateful to have you here today.
I'm going to take this off. Thank you so much, Dr. Rivera-Mindt. That was a really nice introduction. It's kind of funny because when they first, I received the email to do this keynote, and I thought, are you guys making a mistake? So thank you, Dr. Turner. Thank you, Dr. Rivera-Mindt. This is really an honor to be here, and this is such a fun conference. I have to say, most conferences are not this fun, so thank you all for really making this happen. So let's go ahead and go to the next slide. So I just have some objectives here listed because that's typically what we do, but really what I want to talk about today is, to really look at sort of the history of health disparities and looking at, in particular, how do we look at the science that's been done and how do we change it? Because I think this is important for our emerging scholars to hear about, where you're at now is actually such a critical turning point that I think we can sort of get out of some of the boxes that we've been, pigeonholed to over the years and really think about transformative ways to look at brain health, particularly Black men's brain health. So next slide. Okay, so, there is a disconnect, I think, between, as academics, what we call theoretical frameworks, as well as the way that clinical care is actually executed. Next slide. And here are two models. The model on the left, I know you probably can't see it, and that's okay, because really the model on the left is from the 70s, and this is a model that is talking about health disparities, health well-being, and the model on the right is our current model that was proposed in 2018 from the National Institute of Minority Health and Health Disparities. Now, what I can tell you is that there's lots of similarity across these frameworks, so I don't think that there's been a change in terms of what people think. Health disparities frameworks and thinking about how to study this, I don't think that there's been a ton of change in that, but what I do see is that unfortunately, even though we're all on the same page about what are some of the factors that go into health disparities, we're not on the same page in terms of clinical care. Next slide. So I want to talk about a patient who I saw a while back, and I'm going to call him Mr. J, although that's not his name. And so this was a patient I saw that was referred actually for a neuropsychological assessment, but this was after many, many years of being sort of shuffled through the healthcare system, which is often what tends to happen. So his daughter had noticed that his behaviors had changed, and she had attributed it to increased anxiety. And so she was referred to a psychiatrist. Mr. J went to the psychiatrist. Mr. J was prescribed antidepressant medication, but Mr. J's problems didn't necessarily go away. Next slide. So what happened was that Mr. J, I evaluated him, talked to him for about 2 hours. And when I talked to Mr. J for 2 hours, what I learned is that not only had Mr. J had a number of head injuries as a child playing sports, Mr. J also had lots of medical conditions that were untreated. So he had hypertension, diabetes, and it was so bad that he needed to take insulin. What I also learned was that Mr. J had a stroke, and it was kind of like, oh yeah, I had this happen. And so I thought, my goodness, well, I think I might know what could possibly be going on here. I don't think it's just anxiety. So sure enough, I did an evaluation of him, and he really showed the profile pattern of vascular dementia. And what's sad about this case is that this could have been taken care of much earlier on than it actually was. By the time I saw him, there had been a significant course of neurodegeneration. And this is what happens all the time in our healthcare systems. And as a researcher, I'm thinking about the health disparities frameworks that we have. It sounds great. But then as the clinician, I see a whole different side. So we really need to bridge this gap. And I'm really happy to be here because I actually see this as a real opportunity and not just lip service to do that. So I'm excited to be here today. Next slide. So I want to talk about this concept now that we talk about with regard to brain health. Before, brain health is actually a relatively new concept because we always talked about brain injury. We've been talking about brain injury back since 1849 when the most famous patient of Phineas Gage, who worked in a railroad, was hitting a tamping iron that shot up through his cheek, his left cheek, and pierced through his right frontal lobe. So Phineas Gage, which is shown with the diagram on the left, he had significantly, he was a very reserved fellow, and then after this injury, he exhibited a number of behavioral sort of inappropriate behaviors, and people said, what happened to Phineas? He is not acting the way he used to act. And that's how we started learning about brain injury, and the field evolved through several lesion studies. We had to look at injury to understand how the brain works. Now it's different. Now we're talking about this concept of brain health that's actually very dynamic. And if you look into the literature, it's really not until the last few years, starting in 2017, that people started talking about brain health. Next slide. And there's all these models, and you don't need to know them all. But I can tell you that there's a lot of different proposed models for looking at brain health. And out of these models, I see lots of limitations to some of them, but the ones that I actually like are the dynamic life course process model, as well as trying to think of ways that we actually can quantify brain health, because I think that we do need the data to show what works for optimizing brain health. Next slide. So we all know that there are several factors that influence brain health. These are by no means an exhaustive list, but as a neuropsychologist, I have to really have a detailed account of what that person's life course has been, just like I did with Mr. J, to discover that there had been myriad of factors that had contributed to his current level of cognitive functioning. And we can't ignore that social factors actually play a very big role in brain health and well-being. Next slide. And obviously, we all know about the social determinants of health model, and what we try to measure, or what we've tried to measure neuropsychologists, is the social position. So looking at things like education, occupation, income, etc., and ethnicity and race, and I'm going to talk about that. Next slide. So as we think about sort of what is brain health, there has been a theory of what's called cognitive reserve. And initially, this is sort of depicted theoretically on this graph. So you have two people, you have patient 1, patient 2, they both have similar degree of neuropathology, which is represented by the black slanted lines, but they each have different what's called brain reserve or sort of brain capacity. Patient 1 has more than patient 2. So if you think about sort of this arbitrary cutoff where a certain amount of pathology is going to result in neurobehavioral problems or cognitive problems, you can see that patient 2 is going to show the degree of pathology much more quickly than patient 1. So this model has actually been around for years, but it was problematic because it was static. It was almost like, oh, well, you just have to have the right brain or else you're going to exhibit some impairments if you have anything happen. And this has actually changed, this theory over time has changed, that it's really a dynamic life course. It's not that, oh, if you don't get a certain amount of education, or oh, if you don't have a certain experience earlier on, that all is done for you. It's actually that we can learn across the life course. Next slide. And I want to show sort of some of the problems that happen in science when we just assume these sort of relationships that we don't really account for the whys. So this is a study that was conducted in 2003. Now, granted, they were really looking at this concept of cognitive reserve and education being one of the vehicles by which brain capacity develops. And this slide is showing on the bottom scale is going from left to right, sort of the degree of neuropathology, so like the number of plaques within brains of Alzheimer's disease, and what's on the vertical axis is showing cognitive performance. So this is showing 3 people with different years of education, 22 years, 18 years, and 15 years. And what this graph is essentially showing is that theoretical model that I showed you earlier with the cognitive reserve, that the person with 22 years of education, it's going to take them longer to start to show, or more neuropathology before they actually show a cognitive decline. So it makes you think, oh, well, I should have 22 years of education if I want my brain to be healthy. And that is not the case. These are proxies, keep in mind. But this is how people were talking about it. So it made people with less education feel like, oh no, I'm screwed. So, and that's absolutely not true. So I want to say we need to stop with the education piece, let's please, because this is really a proxy, and that's what we have to understand when we present these kind of research findings. Next slide. Okay, so what I do want to talk about, and it was mentioned yesterday, so I'm not going to belabor it, but about the quality of education. This is an area that's very passionate for me because I went to a high poverty school throughout my elementary, middle, and high school education. I was not encouraged to go to college. I was the first person in my family to go to college. And when I went to the community college, I took an assessment, and I had graduated high school, but I was reading at the 8th grade level. And I had to take a lot of remedial courses just to kind of catch up to speed. Now, am I a dumb person? No. But I went to a school that didn't have a lot of resources, didn't really care whether or not we read stuff. But that doesn't mean that it's the end all be all. But we know that this is an unfortunate reality, that ethnic, racial, minority kids tend to be disproportionately represented in high poverty schools. Next slide. And what that, as Dr. Aranda already talked about, we know that the teachers' experience, their sort of level of, training also is worse in those schools that are high poverty schools. So this is a reality. I don't know that it's going to change. I know it should change, but I don't know that it's going to, because this has been going on for years. So what do we do? Do we just say, oh, well, if you went to a poor quality school, too bad for you? No, I think what we need to encourage across the lifespan is lifelong learning. There's so many things that I retaught myself that wasn't based upon formal education. And so I think it's important to instill in our community, you're not screwed just because you didn't go to some, high quality school. Next slide. But what happened is that, we like to measure cognition, and the test that we give often is reflective of how much educational quality did you have. And this is a slide that shows on the vertical axis is the percentage of people who are misclassified as having cognitive impairment based upon their performance on an IQ test. And the graph on the left shows based upon race and ethnicity. You can see that African Americans and Hispanics were more likely to be misclassified with cognitive impairment even when accounting for age. On the right, we see that, okay, let's look at years of education. Doesn't change very much. The misclassification rates are still problematic. So now, so people would go on for years and just say, blacks and Hispanics underperform on cognitive tests, and that's just a problem. And we have to accept that. They just perform lower. They perform about 1 standard deviation. And this had been written about for years in the literature. Next slide. And so then we got into the concept of race norming, that maybe there's a way to account for the fact that blacks and Hispanics perform lower on these cognitive tests. So if we look at the bell curve, this is a bell curve of performance, most people theoretically fall in the middle. And then, but however, what they were showing is that for African American and Hispanics, they were performing about 1 standard deviation below. So the solution was, well, we'll just apply a different correction. So any black person that comes in, no matter what school they went to, who they are, we don't care. If you're black, we're going to assume you perform 1 standard deviation below the average across the board. I think the intention was good, to be honest. I think it was good, initially because there, people were being misclassified as having cognitive impairment, so there was a push to want to correct that, but in correcting that, you're actually now missing people who might really need help. And so next slide, this was brought up by the NFL, and this is why the NFL said, oh no, we can't be doing this race norming because there are athletes who need to be, who have had concussions and who have had their lives affected, and it affected a lot of settlements. Next slide. Another issue that I see with a lot of the ways we try to measure cognitive ability is the process, because there have been studies that show, even with kids who come from low socioeconomic backgrounds, in comparison with those who have high socioeconomic backgrounds. These are 3 different studies. The bars on the left show what happens when you give kids a math problem, but you give them some physical objects to work with to solve the problem. You can see that the high SES and the low SES kids performed identical pretty much on these tasks. But if you don't give the kids any physical objects, those kids with a higher SES perform better. So you tell me, does that mean they can't do the problem? Solve it? They're deficient? No, it's the process. And so next slide. So I really want to ask this question, is the problem related to how we measure brain function? Next slide. So thank goodness with Dr. Desiree Bird and Dr. Rivera-Mindt, Dr. Jennifer Manley, came together because there's been this test around for many, many years called the Boston Naming Test, often used in the diagnosis of Alzheimer's disease. This is a test where you show people some pictures, some objects, and you say, name it. And so item number 43 was a picture of a noose. And so we started noticing, like, wait a minute, this is, I would feel kind of like I would turn the page and in my training and kind of feel anxiety about showing this picture when I had an African American patient because I knew the history behind the noose. And nobody did, and this had been talked about, other people raised the issue. It's a problematic, but nothing had been done about this for years. Finally, they're doing something about it because now we've called it out. This is clearly a problem with the test stimuli. So some people were like, I'm not going to name that. And it builds up anxiety to even see the noose, because then how is that going to affect your performance on subsequent cognitive testing? Next slide. Another study that I think is important to highlight by Dr. Desiree Burt is what happens when you fail to account for cultural style. So, the way many of our tests are developed, it's the assumption that speed means you have better cognitive ability. The faster you are, the better you are. That's not necessarily true. So with this, this is an example of what we call a shape cancellation task. So you look at the symbol on the top, and then you ask the examinee to go through and cross out. And if you do 3 clicks, I think the animations will show up. But yeah, you ask them to go through and cross out, and you look at how long does it take them to complete this task. Next slide. So what was found was that African Americans and Hispanics, they took longer to complete this task. And this test is scored based upon time. The higher your time of completion, the worse your performance is considered. So, but if you look at the number of errors, all 3 groups did the same amount of errors. So now the question becomes, is this really the correct way to score it? Next slide. So here I think we need to start thinking about the tests that we're using, because we just sort of use these tests blindly without a real intentional look at what the heck is this measuring. And I think one of the solutions for doing this is to involve community partners, stakeholders, people of the community to look at the tests that we give and to say, would this work for your community? Is there some problems that you see here? We don't do that with cognitive testing. We haven't done that. And the model on the right is a really nice collaborative model of how you can form partnerships and sort of extend that out to the community and have the bidirectional exchange. Because obviously we want tests that are measuring what we intend for it to measure and not be measuring something else or confounded by some other variable. And I think the best people to really be involved in that process are the people who we plan to be giving these tests to. Next slide. So those are my issues with cognitive testing, but now I want to get into a little bit around social threats, because I think this is really important. This has been discussed earlier, but we are social animals, and we really value bonding and networking. Obviously, all of us here are networking, we're meeting people, and the whole purpose of that really, if you think about it, is your professional survival. So if you think about the different things that pose a threat to our social being, these are factors that disproportionately affect Black people, Black men, and inevitably there is going to be a response. Next slide. So if we look at the brain, and I'm not going to go too much into this, but I just want to show, this is when you're as a neuropsychologist, you got to learn about these different parts of the brain and what they do. And what I've noticed is that there's a lot of shared systems. The brain has 10 billion cells, and they're all networked and interconnected. But we have a lot of these systems in terms of how we think. Next slide. And if we think about the stress response, the brain on the left is showing the areas that are implicated in the stress response, which is right within here, what we call the limbic system. And interestingly, the brain on the right is the brain that's implicated in Alzheimer's disease. And we see the same areas of the brain affected. So in the stress trauma response, as well as Alzheimer's disease, we have very similar systems at play. Next slide. So how could we disentangle the trauma aspects from brain degeneration? I don't know. There's very similar systems are involved, and I don't think that's just a coincidence. So here I want to talk about this. It's a concept called the conserved transcriptional response to adversity, because I think it really is a nice model to explain perhaps how these social factors actually have an influence on biology. So what this is showing here is that this diagram is showing these social threats, whether they're real or imagined, whether you have a bear chasing you or whether you think somebody is negatively evaluating you. It's going to trigger the same system that I just showed in the last slide. That limbic system is going to be activated. What then happens, what we know, is that that response actually turns on genes and turns off other genes that are involved in maintaining a healthy, robust immune response. So we know that there are three major genes involved in the conserved transcriptional response to adversity. And people who have been marginalized, marginalized social threats show that genes that would code for the inflammatory response is turned up, and genes that would code for the antiviral response are reduced. So what does that mean in terms of health and disease? It means that you are not fighting off infections as effectively as you would be without, with the proper response. Next slide. So we wanted to look at this CTRA, and so, the question wasn't really that novel. At first it was, are there black-white differences in this conserved transcriptional response to adversity? So if we looked at gene expression, would we see this pattern that is involved in a immune response? And what we saw was that, yes, we saw, not surprising, the genes that were upregulated for inflammation and downregulated for antiviral responses were higher among African Americans. But that wasn't the interesting question. I didn't want to just publish that, because that's just doing the same thing we've been doing. I wanted to know why. Why did we see this differential pattern? So then we looked at socioeconomic status. That didn't explain it. We looked at general forms of stress. That didn't explain the black-white differences. But then we looked at gene expression. We looked at discrimination. Next slide. And so what the top graph shows, you can click. Okay, sorry. Yeah, there we go, the results. Okay, so what the top graph shows is that this is before we accounted for experiences of perceived discrimination. It's holding into account pretty much every other variable that we could possibly think of that might explain. But when we accounted for experiences with perceived discrimination, we found that it accounted for more than 40% of the black-white differences across differential gene expression in both genes that are involved in the inflammatory response as well as genes that are involved in the antiviral response and the stress signaling genes. I was pretty shocked. And I thought, everybody said, it's a small study, so you got to replicate. I know that. That's fine. But this is a real window to really get at the why and not just saying, there's these, differences. But it also does explain the health disparities, potentially. Next slide. Another issue that arises, and it's related to this social threat, and it's been discussed here, and this actually relates to athletes too, is this idea of performance stereotype with regard to stereotype threat. So many of you may have not heard what stereotype threat is. It's just a theory that says that stereotype threat is when a person is placed in a situation where they are at risk of confirming a negative stereotype about their group. So it could be any stereotype, and they've done these studies across men and women, blacks versus white, athletes versus non-athletes, age, etc. But we know from all the stereotype threat studies, what's consistent is that it produces a stress response. When people think they are in a situation where they can potentially be judged or negatively evaluated, we know that the brain starts to activate the limbic system, and there's a lot of what we call sort of cognitive control centers that go into play, that they're trying to control the anxiety around confirming the threat such that the resources that we would normally use to perform the task are allocated to managing the anxiety, which results in lower performance. Next slide. So, and you can click again. So this was the original study done at Stanford, looking at black versus white students. They all had very similar GPAs, all very bright students. But there were 3 conditions, and in one condition, the diagnostic condition, they told students, you know, you're gonna be taking some tests, it's important to do well. Some people don't do as well on these tests. They didn't say who, they just said some people do not, which was enough to activate the stereotype. In the challenge group and the non-diagnostic group, they did not give those threat instructions. They just said, oh, we're experimenting with these, do your best. So notice that African Americans underperformed in the diagnostic group, the group where the instructions that were said elicited the stereotype. Next slide. So then, you know, lo and behold, I'm thinking, well, I wonder if this impacts neuropsychological testing. Duh, it wasn't really a brilliant question. Of course it would, but I just, you know, you have to have some data to show that what you're thinking might actually, you know, be right. And so we basically demonstrated that even across a longer battery of cognitive tests, if we gave those instructions, it elicited the stereotype. Next slide. But what I thought was interesting was not just replicating what had already been known, but we wanted to know, well, what would happen if we looked at people's level of perceived discrimination and then we placed them with an opposite race examiner? So this is just among our African American participants, but what we see here is that for African Americans who reported high levels of perceived discrimination, if they were in the room with a white examiner, their performance dropped on learning and memory. As compared to, it didn't matter. If they were with a black examiner, it didn't matter about their level of perceived discrimination. So think about it. Learning and memory, that's a big key area that we often look at in Alzheimer's disease. Next slide. So, you know, there are some protections against stereotype threat. One is just educating people about it, and then also people who come in with a strong, positive ethnic identity tend to be robust to the effects of stereotype threat, and also with rapport building. So I think it's very important that we talk to people, as Tia mentioned, you know, up here when she was, you know, going to the, wanting to talk to the man, ask him his name to diffuse the situation. Next slide. So now we're going to get to, just want to check how much time I have. Perfect. Okay, so I just wanted, so I want to talk about the next component of the social determinants of health, and we'll run through this pretty quickly because I think most of my Okay, all right, so I get an extra couple seconds on my talk. Just kidding. If we look at the other factors of social determinants of health, we know that healthcare is a big component of that. So I'm not going to belabor it, but next slide. We know that chronic disease affects brain health. I think that it's important to consider vascular risk factors because inflammation and vascular risk tend to be really common across these conditions. Next slide. And it's not surprising that blacks and Hispanics have higher rates of diabetes, hypertension, and stroke. These are all vascular based. And when I say vascular, what I'm talking about is that our brain is full of rich blood vessels. When those blood vessels lose oxygenation, we have what are called these ischemic attacks. It just means lack of oxygen. And over time, when there's lack of oxygen or lack of blood flow in the brain, that can result in stroke. Next slide. So if we look at the reality of medical care, we know that people don't all have the same baseline. And even all the way from primary to all tertiary intervention, there are disparities. So that's no big surprise. The reality is we would like to get here to health equity, and I think there's a few ways we can think about going about to achieve that. Next slide. So what I would propose is that one is what we're doing here. We're building partnerships that are authentic, genuine, and bidirectional. I think that building capacity within these communities, because we can't just expect everyone to go to the hospital or go to their local clinic. And what I always try to tell people is keep in mind that health may not be everybody's first priority. It might be just having a roof over the head, having food on the table. So we have to think about what are the social determinants that are very basic that we take for granted, all of us in this room, because when we look at nutrition and we're telling people to eat healthy and to exercise, think about the context of where they live and if that's really possible, and then work with them to develop a solution around that. Next slide. So here's some, I think these are sort of getting outside the box of healthcare. The picture on the left, top left, is showing a doctor providing medical care on the street. So there's this concept of street medicine, which is really great. It's doctors going out on the street and providing care. What I also think is important are peer navigators. They use this a lot in mental health, they use it in HIV, but helping people to get through the system, helping caregivers to navigate through the system. We know that the system of medical care is complicated and it gets even more complicated with insurance. And then we have other venues such as podcasts, et cetera. Next slide. Okay, so finally we get to the distribution of health and well-being. Next slide. And so what I want to kind of propose is that we shift our lens. We've been talking so much about vulnerable populations. I really don't like that word. I use it though because I'm in this, academic space where that's the only thing my colleagues understand is for me to say vulnerable populations. Blacks, Hispanics are vulnerable populations. Yes, I don't like that because it's really, I don't really like it. I like to think about resiliency. Next slide. And I think this is a way that we can start thinking about how we shift our lens. So this is a study that was done. I thought it was nice because they did these qualitative interviews with black men as part of a larger study on health and sexual experience. And one of the themes that came up was that black men talked about, the microaggressions they experienced, how, there were certain challenges. But there was a consistent theme that they all said that how they cope and what they do is they keep going. And so this concept of a grit, was emerging from this. So we actually kind of borrowed this to look at some of our data where we've tried to assess it. It's not great, but we try to get an idea of people's level of perseverance through challenges. And what we have seen with our data, I'm just going to show, next slide, is that in terms of looking at one's course of lifetime stress and adversity over the lifespan, we know that these adversities have effects on functional outcomes, and everybody's shown that already. But we actually see that this is moderated by grit, meaning that the course of the adverse course actually can change slightly if we factor in one's level of perseverance and grit. So it's not great because we don't have great measures for resilience, but I think at least this is a step in the right direction to start thinking about, because we can't get rid of what someone's had in their lifetime of adversity. We can't change if someone has had abuse in childhood. But what we can change is maybe the frameworks by which people have a narrative of themselves and their identities. And I really appreciated the athletes talking yesterday about how this, sort of abrupt end to the career leaves them in a state of, well, who am I now? And that is a narrative that we have to build with all of our people, whether you're retiring from, older age, whatever it is. We have to, have people understand that they are forming new identities. Next slide. So I'm going to just say really quick, I think action-oriented science is needed. What this is it's an approach to science that is non-traditional. You are thinking along the way as a continuous process of change, so you don't go in with your own assumptions. You have to, each step, evaluate what is your intention from your approach that you're using, and you have to be really self-reflective in this type of research. It's not that popular. Next slide. So I leave this with saying, what Get Out can teach us about exploitation science. So how many have seen the movie Get Out? Okay, thank goodness, because this could have gone real bad if nobody saw the movie. But what I noticed with Get Out, and we saw with the character, is that, we know, for those of you that don't know the movie, this is a movie in a town where white people are abducting black people, and they're hypnotizing them to a state to where they then perform a lobotomy to transplant the brain of the white person to the black body. And so this character here, he's already been transformed, and he's a shell of himself. And this is what happens in our scientific studies, if you think about it. We recruit people in, but you gotta follow our protocol. You better be real good. So you're no longer Andre Hayward, you are Logan King. And we have a shell of the people that we recruit, and this is why they get out of the studies and they aren't retained. So I really think that we have to think about this moving forward so we don't have this happen. Thank you.
Don't go anywhere. Yes, indeed, a very, very strong presentation. So much science, so much of your personal stories and your touch, so thank you. So we're going to do Q&A right now. Can we get that mobile mic back, please? Oh, she has it. Go.
Okay, thank you.
Good morning, everybody. Thank you so much, Dr. April, for your presentation. I love that you incorporated Get Out, because I love that movie. What I will say is, I think that the incorporation of psychological grit is something that I haven't seen in my practice, or with organizations that I've been a part of. I think that having that strength-based mentality and that strength-based focus serves our participants better, especially in the research perspective, because a lot of times it is solely focused on, what the researchers need or what the researchers are looking for.
Thank you. I'm sorry, what is your name? I just want to...
Latoya.
Okay, I remember from yesterday, you were asking, I think, about the recruitment and retention, and I think that that's one of the things is that we come in with such a pathologizing framework. Why would anyone want to participate in these studies? You're going to tell me what's wrong with me. You're going to tell me I'm about to die. Well, why would I want to hear that? So I think that using a strength-based approach and realizing that many of the people who you're seeing, they are highly resilient. They've been through a lot. They went through a lot of life challenges that you can actually learn from, and I think that's the bi-directional relationship we need to build. So what that might mean is that you don't get to follow the study protocol that you got approved, by the funding agency and the IRB. Maybe you have to think about changing it, and maybe there has to be more flexibility in terms of how we go about certain things. And I think that the strength space is really one that we haven't been used to using.
You know I loved your presentation. It was just wonderful. You talked so much about things that I think about, like the trauma response and how that relates to when we talk about the disproportionate numbers of African Americans with this disease and Hispanics with this disease. We don't really talk about how trauma relates to that and the studies being done for that. And so that's one of my questions, because I know you speak a lot about innovative new ways to do things and innovative new ways we need to take science. What have you found to be some significant barriers in getting people or other scientists to get on board, or other programs to get on board and changing the way that you and others in your field do things?
So one of the barriers is that with a lot of the funding agencies, there seems to be this focus on biology, and if it's not if it's not hard science, quote hard science, then it's not valuable. If it's just, because then it becomes, oh, this is soft, you know. And so it really, the discrimination work that I showed got a lot of attention because we looked at gene expression and people were like, wow. And I was like, it's not that like surprising. Like if you looked at the research and you've been paying attention to the literature for several years, this should not be surprising. But it's because it's almost like you have to have this biological data behind it. And I think that's such a barrier, because we can't negate people's real life experiences. But the way our science works, if it's not quantifiable and we're not showing a change in biological systems, and I'm trained in neuroimaging and to do immune markers, and I get it, the biology is, you know, important. So I'm not saying it's not. But one of the biggest barriers in this work is that if it's not connected to something biological, it's not real.
Thank you, Dr. Thames. I always enjoy hearing you talk, and especially as a neuropsychologist. I have a couple of questions. So how do we help PCPs better screen for cognitive impairment, giving everything else they have to do in their kind of 15 to 20 minutes that they get with the patient? How do we incentivize researchers to do more norming, because we are using norms that are 20, 30, 40 years old, and does there need to be some state policy change? And then lastly, if I hear you correctly, are you proposing that there needs to be a racial discrimination factor taken into account when we're looking at cognitive impairment?
Yeah, those are good questions. I'm going to try to remember each one. So the first one about primary care physicians incorporating cognitive screenings. I see this happen a lot in practice, where neurologists will do like a MOCA or an MMSE. And I have a lot of, this could be a whole other talk, but I have a lot of issues with that, because I think it's good that people should get cognitive screening, but I think that we need to make sure that the screening tools we have are appropriate for the population that we're screening, and I have reason to believe that I don't think they are, but that's a whole other story. So I think that we need to come up with better screening tools, but then, okay, let's say you do screen someone and they show to have cognitive problems. Now what? You know, now you gotta hope that their insurance is going to cover further evaluation, which most time it does not. And then even if you get a longer evaluation that shows that yes, they have impairments, then what? So I feel like there needs to be a transformation to either rehabilitation, particularly in instances of brain injury, or in the case of Alzheimer's disease and related dementias. I know everyone's searching for that cure and that pill that's eventually going to clear everything and make everything better. But until then, because it's not happened yet, we need to think about how do we optimize people's lives while they're still here and give them a purpose and give them a sense of self-respect. Because we can't just be like, oh, well, you have Alzheimer's disease and, you know, sorry, it's just downhill for you. And that's what happens in the medical care setting. This is why I think it really needs to be dealt with delicately, and we don't have the systems in place because doctors are, you know, they're doing all this other stuff, they're on time constraints, insurances won't cover a lot of things. So we as a community probably need to step up and think about, are there ways to fund these efforts to, you know, optimize one's life quality for the remaining years that they have versus waiting for the cure. Because the cure may be just making sure the rest of your life is as optimal as it can be. And, oh, thank you. And in terms of the norms, you know, I don't know. I don't even know that, I'm not even sure. I think that we need to know what is actually most important for performance on these tests. And I think that, I mean, everyone wants to develop norms for a specific population. I don't really know where I stand on that. A lot of my neuropsychologist colleagues probably will hate me now, but I really don't know that that's the answer. I think that we need to either think about cognitive abilities differently, think about what is it that we're using to assess the process, what are some universal things that are most important that we should capture. You know, in terms of discrimination, stress response, I think we need to know that information, but I think we need to know, you know, how is that affecting them now? Are they being triggered in the setting of which they're being evaluated? And if that's the case, maybe the way we do it is not right. Sitting directly across from somebody and giving them tests, that may be the wrong way. So I wish I could answer that.
All right, we have a question from one of our virtual attendees, so I will share that. But before, we received a lovely comment that says, Dr. Thames is a major example of what she's studying, having shared with us her school experiences and how she used grit and resilience to get to where she is.
Oh, that's so sweet to whoever said that. I appreciate it.
And we received another question asking, how can mental health therapists best make inroads into the faith-based community? We often encounter mass stigmatism and fear.
Right, because the way mental health is designed, you know, psychotherapy, traditional psychotherapy is not working with our communities. That's not what they want. They don't want to sit there with somebody and talk about and rehash traumas and then have to reframe, well, let's think about this a different way. That doesn't work. So, you know, I think that what does work is some of the methods that people talked about here. The body, getting in touch with your bodily sensations and really relaxing the sympathetic nervous system, doing yoga, doing deep breathing, meditation. Maybe that works for some people a lot more effectively than let's talk about your problems and try to figure out a solution together, because some of the problems can't be solved. So it's not about that, it's about how do I live with what I have and how do I find an intrinsic joy as to who I am in order to get through it. All right, thank you.
We're actually going to need you to run. So we are about, 20 minutes away from a nice break, but if you're following along in your conference program, we'd like to introduce the registry and tell you more about that. So Dr. Turner?
All right. We figured we tag team this together for lots of different reasons. Hopefully it'll become apparent in a little bit. But we're going to talk a little bit, as you can see, kind of, hopefully you can see the vision of how this is all starting to come together. We have amazing partners, and we started to think about this. And one was really important to be able to work within the community, this community-based organization, community-based kind of comprehensive kind of approach. And that is, how do we disseminate information about these topics to people who live in the community? How do we take it out there, right? So we've been talking about some of that stuff today. Then the other part is, you know, how do we get people involved in research? And so we decided to come up with a brain registry, and we're going to talk about that. But then also we needed to, and we've heard other people say, we need to have scholars from the community who understand the community, are culturally competent in the community. We need to train them up so that way they can go back into the community and do this kind of work. So a real key component of this is, how do you recruit black men and retain black men in what we say, you know, that will participate in biomedical research, and particularly around brain health. And so what we thought was, well, we need to have a registry. We need to put a registry together, which was somewhat of a big challenge, right? Because once we all got into the room, we realized that nobody in the room really had ever run a registry before. We're like, okay, so how do we put this registry together? So one of the things we did was we reached out to our partners at UCSF that actually have the brain registry. And so they started talking to us about how do you build a registry. We also have these really good partners at the Michigan Center for Urban African American Aging Research, and they have a registry for the Black People's Registry, right? So we thought, okay, they told us about some platforms, how to use some software and all this other stuff, and which we'll share with you in a little bit. So we had some general knowledge about how you put a registry together, but then the question was, how do you run a Black man's brain health registry? And all of us said, I don't know, we never did it before, right? And that's really what we're really undertaking that right now. How do you recruit Black men to sign up for a registry that says, you know, yes, I am interested, I'm making myself available for biomedical brain health research, right? And then, of course, once we get them in, we've got to figure out how to get them in. How do we retain them? How do we make sure that we don't have them drop off like April just said? How do we make sure that they don't just give us their names and then say, yes, contact us, and then we don't contact them for years later and say, all of a sudden, oh, we found something that might be interesting. So we've got some of the mechanics that we're going to put all together, but ultimately, we need your help, right? We need you to help us get out into the community. So that way we can talk to people. We can talk to these community-based organizations. We can talk to the faith-based organizations. We have the Alzheimer's Association. We have our partners with Cal Berkeley, UC Berkeley, Brian, Dr. Burton, that, you know, they're training scholars, and then they're giving us access to the community. We need to go out and really understand, what do people understand about a registry, right? You know, how do we tailor something for this specific population where they feel real comfortable that they can be our agents and go out and recruit people for us? And so that's really what we're trying to undertake here, is that these conferences, as you see, they're really for us like that three-legged stool. We want to disseminate information, right? We want to train scholars, and we feel as though our Emerging Scholars Program is, and you'll hear more about them, but they're essential to all of this because we, over the 3 years, we're developing scholars, 30 scholars to be able to do this work. But ultimately, we need to engage in the community, get people involved with this, and we need to be able to have those people who are saying, yes, we will participate in research. And as part of that, as you've heard, it's really those people helping us design what questions are important to their community. And for, as I mentioned to you before, my community, in part, are the former football players, the NFL Alumni Association. That's why that partnership is so important to what we're hoping to do, right? Both, you saw these men up on here and the women that were up here yesterday, and how engaging they are, and their stories, and how they have, and they're willing to be able to talk about their situation. We're hoping they're gonna go out and find other athletes as well. Right, but we need people from across all different parts of society to be able to say, yes, we will partner with you to get people involved in this registry, and that we can learn from them on the questions to ask from our community and how to do the research that's necessary. So that's kind of like the backdrop of everything that we're asking you to be our partners for the next 3 years and beyond, building this all together. And then I'm going to ask my sister here to kind of share some of the nuts and bolts of what that's all about.
Thank you. So this is the call to action, the call to action. And in my race and racism work, I often share the difference between mobilizing and organizing. Mobilizing is challenging power. So it might be marching, it might be having a letter campaign. Organizing is building power. And we're organizing, we're building power. I opened up yesterday talking about the importance of creating a community. And so we have a community here. But there's a big part of our community that's not in this room. And so that's why we want to build power with the people that many of the people in this room work with and serve. And so we have to do that on the ground and be where they are, whether that's meeting people at the barbershop, whether it's in our faith centers, whether it's in school, whether it's at the ball game, but we also have to do it in an academic way, which means a survey. That means technology. And so there needs to be translation there. And I'm really, really hoping that everybody in this room, when we talk about we need to talk to the community, we need to reach out to the community, I hope that there was a shift, that we start saying that we need to be the community. Now, it doesn't mean that you have to move from your beautiful home and go live in some area that you do research with, no, but it does mean showing up. So that might mean being at the PTA meeting, it might mean being at the community center, it might mean going to the Little League game, the football game. It means be the community. But far too often what happens is when we get all these wonderful degrees and certificates, we move away from the community. And now we're not the community anymore. Well, you know, I know somebody who sings on the church choir. I know somebody who's a part of the NAACP, so I'll contact them and ask them to be a part of my research. Or who do you know? Be the community, whether you're white, brown, black, or whatever, all right? So let's be mindful of that. You know, we wouldn't have to dress down a certain way or change our clothing or our apparel if we were the community. So people are used to seeing you in a three-piece suit, or they're used to seeing you, you know, with your Chucks on. I'm dating myself, okay? Right?
I had one yesterday.
You had one yesterday, yeah. So let's be the community versus let's, you know, try to connect with the community. But, you know, I was also thinking about, in fact, Dr. Folt took me back to Carolina when I was the chair of the caucus, the black faculty and staff there, and having meetings with my colleagues about how do we get our university to be better? And there's two strains of thought here, and maybe you've thought about this as well. When you have bad outcomes happening in an organization, in an institution, is it better to incentivize those who are doing it well, or is it better to shame them? I've seen both, I've heard both. Some people feel that, so for example, we're talking about a registry, do we need to give out a $25 gift card? Do we need to put people's pictures up on posters? Do we want to post more on social media that this is great and such person is participating? We've got influencers, we've got, you know, professional athletes. Provide incentives to draw people in. Or do we shame people? As in, your organization has X number of historically marginalized people, brown and black people, and you aren't doing anything about it. Call them out. Put their name, you know, out there. When you have the microphone, speak about it. Like, why isn't your organization doing this or that? So I don't know where you are on that. And maybe some people feel that you have to do both. We need to shame people and we need to incentivize others. In terms of our registry, we are using a call to action to community to say, come join us. One thing that I found, and I'm sure most people know in this room, that in particular in the black community, it's about a sense of belonging. And a great deal of the pain and the harm that we've suffered when that first ship arrived in 1619, Point Comfort, Virginia, is a sense of disconnect from Africa. Our language, right? Our apparel, our dance, our movements, our science. And so we want to create that sense of belonging. We also think that we're pretty cool, right? Right? People want to belong to fun things, to cool things, and that's what we want to display in this registry. Even though it's an academic setting, but you know, if you look at our photos that we're selecting, the influencers that we want to engage with, we want people who are warm and want inclusion and want belonging, as in you all. So in terms of the how it was done over the past 4 months, myself and another staff member with Dr. Turner's lab, we've been working with Ripple. How many of you have heard of Ripple? Okay, if you haven't, they're a wonderful, wonderful tech company. It was really started by a professor who found that he wanted to build a registry. He wanted to have a database platform that was more customized to his work as an academic. And some of the other platforms that were out there just weren't very friendly. So we partner with Ripple, and we've been building this question by question, demographic information and ways to speak to the soul, to the humanity of people. So hopefully that will come forth. And if it doesn't, let us know, because we want feedback. We appreciate feedback. Jose has been so kind to put the landing page up on the big screens, but you can go there now. We are doing some beta testing still, but our official launch is going to be March 1st. We are going to launch this. And we want to make sure that everybody in this room understands that this is about collaboration and not about competition. We need many registries, right? We want so many people to know that it's important to not only be interested in this work, but to also participate in a study. So if you're thinking about building a registry, or if you already have one or a database, please don't see this as competition. We want more people to know, right? Let's throw out that old law we learned in Econ 101, the law of scarcity, that there's only so much. No, there is more than enough for everyone. So at this time, we have a few minutes if there are any questions for us.
Yeah, and while she's going to pass the mic around, I want to share a story from my own research, an experience that I've learned that we need to do a good job, or a much better job, in incorporating within the registry, and it's a real challenge. So I run I was very fortunate to have funding from the National Institute on Aging to do a black male caregiver study to look at stress, physiological and neurocognitive stress of being a caregiver. And so with COVID, first we were going to go out into the highways and the byways and go out and give lots of talks and meet people and try to recruit them to get involved with the project. But of course, with COVID came, that means we couldn't go out in the public and start doing recruiting. So we had to do things either virtually, using social media, and then doing all of the actual assessment, neurocognitive assessments and health surveys, doing them online. And so we thought, all right, well, that's how we'll start to do that. And it worked at first. We started getting a number of people. Then the participation started to slow down a little bit. So we figured out we'd make some postcard size flyers, and we would go out to, I live in Washington, D.C. area. So we'd go to the metro stations, and we'd hand out cards, and we'd talk to the men about getting involved in our project and say, all you have to do is call this number or use Zoom. Well, we found out very, very quickly that, because we wanted to be able to get all demographics, we're not, monolithic group in the black males, we're getting everything, right? But we started working with a lot of men who were kind of living on the street, or, spending, housing insecurity and all of those kinds of things. We want them involved in our project too, but we realized that we developed a mechanism that didn't accommodate for their specific situation. And so we thought to ourselves, how in the world, how do we get this other cross-section of people that we want in our study? It's going to be the same challenge with the registry, right? We don't want just, college-educated, men who, got the degrees and got suits on and doing everything else. Joanne Pugh, I call her my sister, she's had some challenges with talking to her son about different types of things. He playing in the NFL. How do we get him involved in some things, right? So that's a whole nother population. He's a young man in his 30s, early 30s, 20s, whatever. And they're not looking at health in the same way that, we are when we get a little bit older and we look at all these other things. How do we get them? If you notice, our the name of the conference is Black Men's Brain Health. And for us, we wanted it to be across the life course. So we're recruiting men as young as 18, right? We want them in our registry, and we want them all the way through. So our challenge is to learn from you, and with your help is, how do we recruit men all across the spectrum, right? How do we, I have another brother that was really is dear to me when I was in graduate school, Dr. Juan Battle. He said, if you start doing work on black men's health, do you have black men from the LGBTQ kind of community? Are they working with you to help design all of this stuff? We need all of that stuff. The thing we found out real early is once we started designing it, there's a whole bunch of things we don't really know. And we're like, how do we work through those? And the only way it's going to happen is if we roll up our sleeves and we work with people from diverse communities that are helping us get this. So it's a big task, but the great thing is what this conference has shown me through the people who have registered online and come in person, that there is a huge interest in this. And if we work together, we can actually figure it out.
Thank you. Are there any questions? Yes, Brian.
Yes, my question is, I just want to give some advice where, in terms of doing studies. You know, I canvassed the communities in Oakland where you talked about, Dr. Turner, places where people would not go. I did a study on black men in the community in terms of around housing and education. What we did, we created an app. So we weren't carrying clipboards and other paperwork. They created an app with families' addresses on it, where they were able to have names, addresses, and a survey of questions. So as we're talking with these families, we put in information right there on the spot. And it goes to the particular database, and everything is collected there. That was one thing. And then the other thing, I've participated since high school, the cardia study with Kaiser Permanente. Cardia, they looked at cardiovascular. They just pretty much used me as a guinea pig, you know? But it was a great resource because I was able to follow my health since the age of 18, 35 years later. So I'm still doing that study around black male health. I think if you look at the data there, call Kaiser Permanente and say, what is this cardia study all about? Because they have several great questions, and it was related to black men health. So I just wanted to just suggest that.
Thank you.
Thank you. My question is, once a person signs up for the registry, what should they expect next? Are there any next steps that would be required for them? Or is there anything, or what in particular would you all's next steps be after that registration is complete?
I'm going to let Dr. Stroman take that, but one is that we're working through those very questions now.
Absolutely. So there are two parts. One is your interest in this field. And that might mean coming back with more information to them. Like some of the terms that we say, we roll off the back of our tongues, people might not be familiar with. Cognitive aging, brain health, what is all that? So the first part is the interest level in terms of information, so we'll respond to them. The next is interest in being in a research study. And so we're going to be able to identify what particular research studies would you be interested in, filter that out, and then respond back to them. And it might be something happening in Washington, D.C. It might be something happening here in Los Angeles or Texas or Minnesota. So that's the two parts.
Yeah, and I just want to reemphasize that when they register in the registry, they're not signing up for a particular study. They're letting us know what types of studies they may be interested in, or how can we engage them. Kind of also going back to what I believe Roland Thorpe said yesterday is some people might really want to just date us for a little while before they get really deeply engaged. And so it might take a year to provide them the information that they need before they feel comfortable and say, yes, we want to get involved.
Okay. Thank you. Thank you so much. Thank you for great work you're doing. My question is this: have you guys considered doing this globally? I spent a lot of time in Africa. I've been doing it for 20 years from my pharmaceutical background and just going on my own and just doing it because connecting, like you guys said, there's a disconnect between Africa and the United States, but I meet brothers over there so frequently. I started with HIV work with Gilead and then branched out and started doing some other things. But I met a young brother when I was in London for the Alzheimer's Association International Conference. He was the only one that showed up from Africa, and what I told the brother, I said, I'm going to keep my word, and I'm going to continue to work with you, and we're going to get to Kenya. But the Alzheimer's Association at that conference, he was the only one representative. I did a lot of work on HIV/AIDS, and I see the healthcare disparities on a global basis. So I work with a lot of brothers and sisters in Africa. I take an HIV test. I would pray that you would take this registry back to our motherland, whether it's in Ghana with Ambassador Erica Bennett that I've worked with for years. She's from the United States. She's at the W. Du Bois Center. But I pray that you don't even keep it just the brothers and sisters in the United States, that you look at that bridge, because that's what I do as a bridge builder for the Rose and Raymond Parks Institute for Self-Development in Detroit. So please don't limit it to here. I'm going to continue to partner with the brothers and sisters there because we got to build that connection there as well. So I pray that you don't continue to keep it in-house in the United States. Look at this from brothers and sisters in Brazil. As I travel globally through my job and my work, there's a huge opportunity and a huge network to go beyond this stage where you guys are at right now, and I pray that you'll do that. And I would love to partner with you all if you're interested in doing something like that. God bless you.
Thank you.
Well, I will say this, and I'm going to point to my partner over there, Dr. Monica Rivera-Mindt. We realized that as we started putting together, Dr. Stroman, she was in charge, she's a task force. She put this together, and then she said, she hit us with a bunch of questions, and we looked at each other and said, whoa, we need infrastructure, because like everybody's doing this and volunteering right now. So I would say, these types of things are on the table, but we have to build the foundation first, and we have to get the funders in place. We have to get the administrative support. It's a big undertaking on this, but we're committed to being here. And you can see by what's going on here that we're going to live this commitment through.
And there's nothing, well, there's a lot, there are other things, but to bring somebody in and then not be able to deliver, we want to avoid that. Because you're talking about now breaking trust. So if we do this, we want to do it correct. I think there's a question down here. We'll come back.
Hi, Brett Naskin from UCSF and also former Tar Heel. This is more of a practical question.
Wait, former Tar Heel?
Born, bred, and dead. It's still there. More practical, you mentioned some of the other registries that exist, some of them that are specific to Black participants, other registries that are broader than that. I'm wondering about co-enrollment across these different registries, plans to go to existing participants in these registries and say, hey, you would be a good candidate for our registry, or is the goal really prospectively recruiting people who are not doing anything yet, and then this is their entryway into maybe other projects? And I guess related to that, harmonizing the elements of this registry with other, either whether it's the ADRC network or other registries. Just curious what the thoughts are about this in the broader landscape of the other registries.
No, thank you for that. And that's a part of Dr. Turner's response in terms of infrastructure. So when we collaborate, we need to know who else is out there. And so we're in that process of learning. So our decision to select Ripple came from people recommending Ripple. So we're making those contacts with people who have other databases and registries. So absolutely. When we know about you, we want to talk and see what makes sense. How can we build this so that people aren't confused out there? Right? Thank you.
And I'm just going to add on to that. It goes back to trust, right? If people entrust us in our registry, right, we get to know them. We're not trying to say that we need to have the corner on Black men's brain health and only people who register with us. But we also do need to make sure that, through IRB and everything else, that we are really protecting people, we're engaging on them, and they will let us know, how do we need to interact with them specifically across these different registries.
And one of the questions is do you have experience, with another registry or another project? I think we saw another hand here.
Yeah, I just want to thank you again. I'm really enjoying the conference, and I want to thank the Alzheimer's Association, and particularly Tia for inviting me. But, and I think that's one of the things, because I also network. And I think one of the things that we have to do is network more. I'm with the Alpha Phi Alpha Fraternity Incorporated, and Tia was kind enough to mention that when she invited me, that I should contact one of our brothers who's highly sophisticated. And I know we just don't want sophistication, but what I do realize in life, it's like going to church. Most people go to church as they get older because they fear death. And I think more people fear strokes and heart attacks as they get older. As I mentioned earlier, I'm about to turn 63, so I'm more involved. But the thing is that we have to learn how to reach out to the younger people. We have to be more creative. And by inviting, one of the things that you talked about is a double standard, whereas we can offer a gift card or something, well, I believe in both ways, but I believe that we have to reach out to the younger community in a way that they can see this viable. And because they're huge with technology, they're huge with TikTok and all these different things. So I think we have to learn how to reach out to them, not wait until, we get close to death or we get older to stroke or anything like that. So I don't know the answer, but I'm willing to participate to do that.
Thank you. And when we think about our design, youth are a big part of this. But again, COVID, protocol, USC, we actually had an entire I guess you could say, session devoted to youth and having them here with us. So that's definitely in the works. So I'm glad GTMA. In the back, Michael? One more? Okay. Right here. Okay.
Hi, thank you very much. So I'm real grassroots. On March 1st, you said there's going to be a launch. How do I tell my connection in Madison, Wisconsin, who has a very active men's program, to take a look at what you all are doing?
I'm hopeful that your energy and your passion from this conference will go back and they'll say, whoa, okay. We're excited about that. And then when we launch, we're going to have a marketing campaign so that everybody in this room, people will know about it and how to actually engage your community. Whether that's a script, as in all I need to do is read the script, or whether or not you just click on the link and it will be apparent.
Thank you. I will give him a call this weekend.
Thank
Tell
you.
him.
Hello, everybody. My name is Michael Tapman. I brief talked yesterday, and I was talking about the good life. These are the people I'm with, Dr. Johnson, Shanette, heading the program, and we actually do a virtual online class, workouts, and our age range is like 50 to like almost 90. I think we got somebody like 93. So we started 2 years ago. It was supposed to be a program. We were supposed to be in person, but COVID happened, so we had to go online. When we first started off, it started off rough. It was basically me and Shanette, our program manager, doing all the pushing. We had like 5 participants. But then as time kept going on and they kept feeding off of us, and we just kept throwing different energy at them and, doing things to show them that we appreciate them, the word of mouth started kicking in. So we went from being in like Oakland, the Bay Area, to being globally now. So at our max point, and I'm one of the fitness trainers, I do classes on Wednesdays and Fridays, but at our max point, we got up to like 75 participants. So I gotta, I'm working out 75 people on the screen and engaging with them. We got 500 total in our registry, but as far as classes, we had like 70. So we had to kind of shift back and recalculate how we was doing our program so we could register and, get all these people so we could, get all that access. But it was a slow process, but now we moving. So now we trying to figure out how we could convert that into doing a man's program and work it the same way. Like we got classes on Monday, we got like a Zumba type class. Tuesdays we do a Pilates. Wednesdays I do my class. Thursday Shanette do cooking. So we got a cooking class for nutrition. Friday, I do my class, and we range from Monday through Friday, anywhere from 20 to 50 participants every time. So anybody looking for some extra help and support and collaboration, the good life is here, and you're welcome to come collaborate with us and, get some networking in. Appreciate everybody.
Well, for us, you're exactly the kind of partner that we want in this whole initiative. So we appreciate you sharing that with us, and we really hope that we can, build a collaborative partnership so that way we can get people involved with what we're doing as well.
That's it. Oh, one more.
Brian from Oakland, California, School of Social Welfare, UC Berkeley. Just want to put that plug in. As I was sitting here, I thought about black men having access to black men. Gentleman, my classmate, one of my classmates from my high school, McClymonds High School in Oakland, Alonzo Carter, is a head coach, or assistant coach at San Jose State. He started doing Zoom calls with minority black coaches throughout the nation. And so he has there's a website now. I just sent it to you. Okay. I just texted it to you. It is the National Coalition of Minority Football Coaches. Okay. So
Very
these brothers
familiar
been
with
getting
them.
together during COVID, having conversations, how to better themselves as coaches, how do we rise up to be head coaches, athletic directors, be in positions of decision making. So if you guys want to click on that link It'd be a great opportunity as we talk about creating registry and getting access to all these black men down as HBCUs and the communities as well. So I just want to share that.
Thank you. Okay,
Let me
let's.
say one more thing. I just wanted to, I mean, it's kind of a natural, hopefully, you know, we're talking about men in the registry, but, you know, women and other people play a very prominent role in black men's health. And so we're going to figure out, like, again, networks, families, and all these things, how the role that they play in helping us build this all out through with the registry. So there's a lot to be done. There's a lot of thinking to be done. And so comments that you can offer us is going to be really important, too.
Important. Thank you, Dr. Turner. So I want to recognize someone who's been making this conference work really well. Jose, would you please stand up? Let's give Jose. How about if we take a 15-minute break and then we'll come back with our next session?
Thank you much.
Thank you.
All right. Wait a minute. You need something? You want? No. Because all of the stuff we have for breakfast and everything, you just peek your head inside there. They may give it to you. Okay. No, we paid for it. Go for it. If you want it, go for it. And do they have some of that food sitting up on the counter still?
I've been wanting to do that for a while. So with that, I'm going to invite everybody to come back to their seats for the next session. Okay, I hope everybody had a nice break, and now we are going to be going into the workshop session of the day, and we're going to be providing a workshop on community-based participatory workshop. So let me briefly talk about our workshop panelists today. So first of all, we have wonderful Dr. Roland Thorpe, who presented yesterday. For those of you who might not have been here with us yesterday, Dr. Thorpe is the co-director of the DRPH concentration in health, equity, and social justice, and a professor and an associate vice provost of faculty diversity at Johns Hopkins University. He is a gerontologist, a social epidemiologist, a leading national scholar in health disparities and Alzheimer's and related dementias. And we also share something. We have a fun fact, something that we both share. We both come from a long line of preachers. So I am the daughter and also granddaughter of evangelical preachers, and he is a child from a long line of Baptist ministers, I believe. So please join me in welcoming Dr. Thorpe. Next up, I have the great privilege and honor to introduce the Reverend Dr. Kelvin Lamont Williams. Dr. Williams is a community liaison and outreach specialist in the great and beautiful state of North Carolina at Wake Forest University. He is a community leader, and he has also served as a pastor since 2009. His work focuses on social, health, and economic advancement issues to affect change and to improve community health. His experience is focused on divinity, education, and mentoring young adults, and connecting nonprofits within communities, again, to better serve the health and wellness of communities. And with that, I want you to join me in providing a very warm community welcome for Dr. Williams. Okay, so with that, and I'll be joining this panel as well, so I get to have the great good fortune to present with these folks as well. So Jose, if you could, yes, put up the lights. Hello, can you hear me okay? Very good. So we're going to be talking about CBPR, or sometimes it's called community engaged research, and we're going to be talking about how it can impact and improve research engagement and outcomes in Alzheimer's disease and related dementias. Next slide. So for just an overview of today's discussion, we're going to provide a very synergistic, synthetic overview of community engaged research, and then we're going to follow up with some key points on how we can utilize CER, community engaged research, in action, and Dr. Williams and Dr. Thorpe are going to be providing us some wonderful examples of that. And then we want to hear from you. Again, we're trying to make this meeting as engaged and as interactive as possible. So we'd like to hear your thoughts on how this work, any questions you have to answer about doing this work, and how we might all be able to do it better. So with that, could we have the next slide? Okay. So I'm going to start with a little story. So I have this slide up that provides an overview of community engaged research in action. But let me tell you how I came to this work. So if you see me, you might recognize somebody who's Afro-Latinx or indigenous, cisgender woman, and put me in all kinds of boxes. But when it comes to my identity as a researcher and an academic, I was very traditionally trained. And that training, which I'm so grateful for, really came from a traditional perspective, and I call it, with a little tongue-in-cheek, I call it conquistador research. And what I mean by that is the way I was trained was to really focus on that hard science, and that it was okay to go into communities that have been made vulnerable, marginalized communities, get the gold, which for us researchers is data, right? So get that gold, put it over on our backs, and then take it back up to the ivory tower. And once those sweet, sweet data were up in the ivory tower, researchers get their papers, they get more grants, they get the glory, they get to go to the conferences and share, all their brilliance and all of their wonderful findings. But there was a real lack of positive feedback between the researchers and the communities. And that didn't feel right to me, and I know I wanted to work in diverse communities, but I wasn't trained on how to do that well. So cut to my leaving UC San Diego, where I was doing my postdoc, and I moved to New York City. I moved to Harlem back in 2002. It's been a minute. And so we got to Harlem. A couple years later, I was working where I continue to work today, so Fordham University in the Icahn School of Medicine at Mount Sinai. And working very hard, really, my hustle is hard. And I was writing lots of grants, and I finally got a grant to look at medication adherence in HIV-positive adults in diverse communities. And I was so excited. Mount Sinai is situated in Spanish Harlem, in El Barrio. And I thought, this is great. I've got this wonderful grant. I'm situated in this wonderful community. Those participants are going to be beating down the door to come to my study and to help me, a sister, an hermana, do this research. I was so excited and a little bit naive. And so what actually happened, you hear that? That's right. That's what happened. That's what happened. It was real quiet. And I was so hurt, shocked, couldn't believe that my people didn't want to come to, support me in this study. And I couldn't figure out what was going on. But luckily for me, so my preacher father tells me never to say that it's luck, to remember that it's a blessing or, a bendición. But what happened for me in this moment, a really dark moment in my career, when I wasn't able to recruit, things were not working out well. I had money, finally, after getting lots of grants denied. I finally got a grant funded. And there was nobody to do the research with. And I got picked up as a faculty scholar in Mount Sinai's faculty scholar program at their Center for Multicultural and Community Affairs with Dr. Angel Palermo and Dr. Gary Butts and their group. And they were doing community-based participatory research. And it was an actual formal training program. So they took me under their wing. I got didactic training, I took coursework, and I got mentored experience doing community-based participatory research to become a true practitioner in CBPR, or community engaged research. This took years. And one thing that I learned through that process, first I had somebody to vouch for me, somebody trusted in the community to go to these different community-based organizations in East Harlem. And what I was told, my first lesson was to go to the CBO, to the Harlem Community Academic Partnership, was my first organization I went to. Now I'm actually a member. 15 years later, I'm a board member. But at that time, I was told to go, sit down, shut my mouth, open my ears, and just listen. So to Dr. Thorpe's point, and I did that for over a year. At least a year and a half. And I started just giving of myself, because in research, a lot of times, the way we're trained as research is to get the data, to get all the things we want. We're not taught about the give, right? But in research, if you want to do research with these populations, black men and other marginalized populations, you need to be ready with the give first. And so for me, what I was trained, I learned what the community needs were, how they did or did not align with my goals, my study, and the work of my collaborators. And then after that, eventually, people started asking me, so tell me, Doctora, what's your research about? What are you up to? And then we together started actually collaborating on the research, and the floodgates opened. And through that work, I started doing presentations all over Harlem, all over the city, started connecting and started doing research capacity building at community organizations that didn't have to do with my work, Dr. Rivera-Mindt's work or Dr. Palermo's work. We would go to these organizations to help CBOs become good, educated researchers themselves and learn how to do this work so that they could guide their own research agendas. And then if they wanted to, we could collaborate together or not, but we were there for them. And this was this to me is transformative science. And what we're talking about in this session, and I think this whole conference, is about how we can do transformative science to advance black men's brain health through inclusion and through engaged, valid research. And so I guess this is my testimony. So this is my testimony about what brought me to this work. And with that, I want to share this slide with you. So Jose, perfect timing. Thank you very much. Right on point. And so you see on this slide, the red bar on the far right, there's traditional research approach on the bottom, which is reflected in those white boxes. And then above is a community engaged research approach. So let's just focus on the bottom first. So this is our CBPR 101. Just one slide. That's all I'm going to ask you to indulge me in. But this is the usual way that research gets done. So first, researchers have a health concern that they identify as important. And then those same researchers go on and they put together a study design, they pursue funding for it themselves, okay? Next, they go out into communities or wherever to recruit participants and do their own, recruitment plan. They come up with their own measures that are standardized in the field and often not validated in the populations that they want to study. And then they do the data intervention, they collect their data, and eventually they analyze the data, and then they disseminate it through the ways that scientists usually disseminate data, which includes conferences, right, like this. It includes papers, symposia, those kinds of things, and they share it with other scientists typically, right? So that's all fine and well, and it has a place, but that is really this conquistador approach to research that I was taught, that I have engaged in. But on the other side, what I have learned about doing community engaged research that I've found so meaningful is not only has it helped engage me meaningfully with the community in my own science, my own research, it's made my work better. And it's made my work more meaningful. Listen, I live in Harlem. I sent my kids to school, public school in Harlem, and this work that I do, linked arms with my community members, has made my experience as a scientist so much richer and deeper because we are in this work together. And what that looks like, and I'll just talk about a research application that we put in. It's not done yet, but I'll use this as a proof of concept. It's called the Beyond Study that's being reviewed right now. And in that study, we want to look at early onset dementia in Black and Latinx individuals who develop dementia before the age of 64. And in order to do that study, I thought it was important, a good idea. But before I went ahead and engaged and started doing this project, I reached out to my board members, my community members at the Harlem Community Academic Partnership, at the East Harlem Community Health Committee, and we talked about it. And I made sure that we felt like this was an important project, that there was buy-in. And then from there, we decided, yes, this is an important thing. We want to follow up. And so together, we came to agreement that this was an important topic, and it definitely increased the interest and the desire of those community members to engage and be part of this process. And not only that, when we talk about study design, they helped me and my other collaborators figure out the best strategies to recruit, because this is a very, I think Dr. Maria Carrillo, who's the CSO of the Alzheimer's Association, she talked about trying to recruit and engage this population like looking for a needle within a haystack within a haystack. And so how do you do that? How do you write a convincing application when you're going to seek individuals with such with such an important but relatively rare condition? And together with their help, we came up with some really exciting strategies that we've piloted before, and we thought this is could be a really good project to implement them in. And so they had a hand in developing the design, developing the application, the measures. We talked about the measures. Again, we were linked arms in that process. So by the time we submitted that application to the National Institute of Aging, we got letters of support from those community-based organizations, but they weren't pro forma, like, I support this study, go. Those were deep letters about all the process that we had gone through together to put together that study. And then so on, so that study's not funded yet, but in other work that I've done, the community members that I work with have worked closely with me on guiding recruitment and engagement strategies, and this has enhanced my recruitment and engagement in my own work. All of my work, I have over 50% people from these hard-to-reach populations, and I use bunny ears because I also do not like that term. So these are populations that we haven't reached out to. They want to engage in research, but with trusted partners is what I think, or at least they want to learn more. And then from there, we have in other studies engaged them also in terms of the measures that we use, so that the measures, we pay attention that they're validated in the populations that we want to work in. And lastly, after we've collected the data, we disseminate the data to those scientific channels as well. So we still write papers, we still present at scientific conferences, but that's not where it ends. I go to the community-based organizations who have partnered with us, and I present the findings. We talk about it, and I don't talk about it just in terms of t-tests, f-tests, r-squares, and all those things. I talk about it in lay terms that my community members, my constituents can understand. We with them have co-authored posters together. We have presented at in other venues together, and together trying to get the word out in ways that are meaningful to them so that we can create change. And for me, this is transformative science. I think Dr. Thames called it action science. And it can be a really meaningful way to engage with communities. It's more meaningful, but not only that. Dr. Andrea Gilmore-Vygotsky, excuse me, she recently published, her and her colleagues recently published a wonderful review article that looked at community-based participatory research and its efficacy with regard to retention and recruitment. And what it turns out is that there is an evidence-based approach, because as scientists and as providers, we like evidence-based approaches. There is an approach that is evidence-based to be successful in recruiting and engaging participants from marginalized and vulnerable populations who've been made vulnerable and who've been marginalized, and it's community-based participatory research. So there are not a lot of studies out there. This inclusion science is a new and emerging area, but the research that's there, that is available to us, shows us that this is an evidence-based approach to doing this work. So if we want to make change and include Black men in research, this is an approach that already has scientific findings to support it. So with that, I want to go to the next slide and open it up to see other examples and discuss other examples of community engaged research in action. And I'd like Dr. Williams to start us off in this.
Thank you. Let me say good afternoon. I am delighted to be here representing the faith engagement community. And I want to just piggyback on what has already been shared. I bring 4 decades of faith engagement experience to this conversation. I can also tell you that as a senior pastor in the city of Winston-Salem, I have used those lessons learned to inform the work of recruitment and retention. I can also tell you that I've been very fortunate at the Wake Forest School of Medicine. Dr. Laura Baker as my senior manager, and Dr. Goldie S. Berg. Let me put that in lest I get back to Winston-Salem and have another conversation. So I've covered that. Dr. Goldie S. Berg with the Maya Angelou Center for Health Equity. I have been fortunate to also, when I started at Wake Forest, I was charged with trying to raise participation for people of color. It was real clear that there was a disproportionate representation of the community that was most adversely impacted by an Alzheimer's study. And then it began to plague me, how do you begin to move the conversation to have those people most impacted to get involved? But what I found out unapologetically was there were a lot of whys why they had not gotten involved. And so what I'd like to do is use my few moments today to just talk about some of those whys, because those whys ultimately became the game changers in Winston-Salem. I started there with around 10% people of color in this study. And I began to use this model that I had been working on, and Today, it's over 33% during COVID. Let me tell you, that represents some very honest and robust conversation. And what I wanted to try to do is just help anybody trying to engage in research around people of color. I am a person of color, and I can certainly speak to that. I framed this around three basic theoretical frameworks. This model has three basic frameworks. Number one, it is acknowledgement. That is simply to say that if you're going to have any robust conversation in the space of recruiting favorable responses for African Americans and those other subgroups that are marginalized, the first lesson, thank God it did not happen to me, but I saw a researcher come to a faith-engaged event, and they immediately said that, well, you know, African Americans are historically less educated than whites. What an atrocity. So there was someone in the audience that raised their hand and said, well, would you speak about the 400-year disadvantage that they have had by being in slavery? What a profound moment. I took my pen out, I began to try to write, because what I found out is there are so many things that govern our community. For example, how do you as a school of medicine who participated in eugenics and then turn around and go to that same community and ask them for your trust? It is the first profound principle that I have learned in this model. It is acknowledgement. For example, many people are not familiar with a gentleman named Jesse Washington. I would that you would just look him up. He paints a very dark stain on the fabric of the state of Texas. This gentleman was publicly lynched. And as a result, pictures were placed. And what the scholar says, it wasn't so much that they were around, but it was the expression on their face while he was being lynched. Yes, if we're going to have authentic recruitment, the first step is acknowledgement. And then I was in a recent faith engagement meeting, and someone says, well, why are you bringing up all those old historical situations? Well, someone in the audience said, have you heard about Beulah May McDonald? I took my pen out and wrote down again. She was the lady that dismantled the KKK because the KKK publicly lynched her son. And now South Carolina has a stain on their fabric as well. And so I say, make the connection, I'll be glad to. Because we have public lynchings in 2020 in the form of George Floyd, who publicly loses his life. It's a hard conversation, but I'm telling you that one of the most basic principles is when you're trying to recruit marginalized communities is to first make an acknowledgement. It happened. Cannot dismiss that it happened. And then how about we have, the list goes on and on and on. But what I want to leave in my short time today is the lesson learned. I spoke with that researcher and I said to them, my prayer is that you have no more aha moments, because that was a painful aha moment. That you cannot go into a community that has been already atrocitized and then act like it does not exist. Acknowledge it. And then number two is to have what I like to call awareness. One of my great readers, I've been reading Harriet Washington in her book, Medical Apartheid. If you do not have it, I tell you, you probably should get on Amazon just after I get through talking. Don't do it while I'm talking, but this is my partner, Dr. Thorpe. Harriet Washington says, if you're going to examine the true problem, you must first familiarize yourself with its history. She says to not do that is like going into a medical room without eliciting a full medical history for the patient. How can you give a true assessment without a true, authentic history? But then she says, after the history, to the group that has been ostracized, that you must get involved in research. She said to not do that is to traumatize yourself all over again. Dr. Laura Baker made this statement. I want to make it publicly. She says, the first person to get treated for Alzheimer's will be someone in an Alzheimer's study. Isn't that amazing? So I say that in our communities, when you educate, it's bidirectional. And this is the one thing I want to say to anyone trying to work with faith communities, because it's a big sticking point. That I use the term asset-based partnerships. That is simply to say, when you come to my local church, your PhD doesn't mean anything once you come through the doors, because I'm the pastor there. And to not understand that is already a misstep. And what I say is, how do we try to stop stepping on minefields? And one way is to meet everybody at ground zero. So I say to all those persons who are trying to raise the awareness on these marginalized communities, particularly in the faith community, can I give you some more education? This is 4 decades worth. What I have found is that at the end of the day, that the faith leader has the leverage. Somebody should write that one down because it's a big takeaway. In the end, when you come to the faith leader's congregation, I have been in sessions, this is the honest truth, where the presenter was presenting and the faith leader was disengaged, and guess what happened? The congregants became disengaged. Because it was as if the leader was speaking through their body language. And then let me give you another example. I had a pastor with thousands of members. And he went on a campaign, invited me in to do an awareness seminar. And over 300 participants in one session. What's the takeaway? Was maximizing the leverage of the faith leader. But here's the challenge. They're the gatekeepers to their congregations. Whether we accept it or not, they are the gatekeepers. And to leverage that, what a wonderful place that will be. And then finally, the third construct is this: access and availability. Because I've been speaking to faith leaders on this model. It's worked very well in Winston-Salem. We've now rolled it out into Providence, Rhode Island. And within 3 months, we're already seeing major trajectory increases. It is something to be said when you educate people about opportunities that are in their front door. Can I tell you the number of people that said they didn't even know that it exists? And they took advantage of it, and we're seeing some major changes. So those are 3 things I certainly wanted to just raise awareness on. If you're going to engage with faith communities, first of all, acknowledgement. Second of all, some level of awareness. And then thirdly, just amplifying the message of access and availability. Thank you.
Wonderful, thank you. And before we move on, Harriet Washington was one of my mentors coming up early in my career. I have so much love for her. I love that you brought her up. She's going to be so pleased.
Thank you.
And so now, good Dr. Thorpe, tell us about your experiences with community-based participatory research, community-engaged research, and what researchers need to know to do this work, and what you think are some of the most important points.
Okay. So, first of all, don't put me behind him ever again. You cannot go behind a preacher. That's number one. So you cannot follow a preacher. So this was a setup. I'm gonna tell you, Robert, it was a setup, Robert.
I'm sorry.
No, first of all, I really appreciate the comments, because as you were saying those comments, I was thinking a lot of that I need to know the model. I want the information about the model. I know we talked in Denver about it, but as you were saying those things, those are exactly the things that I've run into when engaging, particularly black men. A quick story, experience that I had. We were designing the survey for the Black Men's Health Study. The cities we picked were the Metro Atlanta area, then Raleigh, Durham, then LA, and St. Louis, and then the Detroit metro area. And those areas were picked largely because there was a high concentration of black men there. And then I knew some black men that were interested in black men research, and we could leverage our resources to move this forward. So I was struggling to get black men when I was down in the Raleigh area. I was like, 2 weeks to go, got 3 people. I'm gonna go, but 2 weeks and 3 people. So I talked to Thomas Levis. I said, man, I ain't got but 2 people. I said, last time we were in Detroit, we were oversold, and Baltimore we were oversold. He says, all right, let me call some people. All right, he gonna call some people. I've been telling them, look, we sputter, it ain't working. I didn't know what else to say to him. This is not working. I don't know how more direct to be. So he makes a phone call to this woman, and he says, I gotta go to class, but you need to talk to Roland. I talked to her. She said, baby, that's how I knew I was in the South then. I was back home. She addressed me. She said, baby. I said, yes, ma'am. She said, sounds like you're in a bit of a pinch. I said, pinch is an understatement, ma'am. I need about, she said, how many men do you need? I said, 20. She said, do you need 20 more, or do you need 18 more? I said, I need 20 more. She said, I'm gonna call you at 3 o'clock. Give me your number. Gave her the number, hung up the phone. She ain't gonna call. I'm gonna go down here. We're gonna have a blast with the 3 people. She calls me at 2:45. She said, I got 40 people. I said, hold on, wait a minute. I need, this is a teachable moment for me. What did you do that I didn't do, right? And the one thing she did that I didn't do, she knew the faith-based leader, and she had that entree that I didn't have. So now I got a good problem. I got to figure out how to get 22 more of these gift cards now. That's a different problem, but that's a better problem than to have to go down there with extra in my pocket, right? So I ended up going down there, and I said, man, I said, listen, I want to meet you. She said, I don't want to be a part of it, because I think it's important y'all going to have some conversation, and I don't want to be there. I said, I understand, but I need to look in your eye and tell you thank you, because I need to understand what you did. And she told me that she said that because she knew Thomas Levis, she said, I knew him because we had a relationship. We done studies together, and he introduced me to you, and I went, and she literally put her name on the line for a person named Roland. We just met the first time. That was very powerful. So that was a teachable moment around the awareness. Here's the real moment, the acknowledgement moment. So I'm a quick learner. That's the acknowledgement moment. I'm consenting to people. This older gentleman comes in. He walks in, and it's about 10 people in there now. And he walks in, he says, I don't want to be a part of this. And my initial reaction, Brian, I went Macon, Georgia in my mind. I said, well, why are you here? That was my first thought, right? And I said, well, can you share with us why you don't want to be a part of it? I can't lose these 10 people because, you know, it only take one to destroy. So I said to him, so sir, can you share with us what your name is and why you don't want to be here? And he didn't want to be there because he thought this was going to be another Tuskegee study. And he went directly, he said that. And so I stopped consenting folks immediately. I said, let's sit down. And we had to acknowledge that. And we had to reckon with just what that was about and all of it. We had to deal with it at that moment. And as I told him about it, we went through it and we answered questions. So once we got to the end of it, he said, oh, okay. And so he had some misinformation. Once we got to the end of it, then he gets ready to go. I said, well, sir, I would love for you to stay and participate because I would love to learn more, and I would love for the group of us to learn from you and the knowledge that you bring. He sat there and he consented, he got in the study, and we couldn't get him to stop talking. I mean, I should have just done an individual structured interview with him, right? But we couldn't get it. But the point is, if I wouldn't have taken that opportunity to acknowledge that, I would have lost everybody in the whole room because when it unraveled, he was a big known person in the community. And so he comes in, if I lose him, it was, you know, it could have been very detrimental. And it happened to turn out very fine. And he was very vocal and very involved all along the way with creating the survey. So I really appreciated that. That was an experience that they don't teach you that in the school. Now, I don't know no textbook they're gonna give you that. But but these are some of the things that you have to be prepared for and be able to deal with, and particularly when you're dealing with group dynamics, because it could have gone sideways fast and easily. And so from that point on, he's always been a champion for it. He passed, I think, during COVID. I forget, yeah, the lady called me and shared with me that he passed. And so I would never, when we finish this baseline data, I'm trying to find out a way to honor him through the study moving forward, because he was very pivotal. But that moment, if I wouldn't have dealt with it immediately and acknowledged it, and if I would have tried to sideswipe it, I don't think I would have gotten anything out of that visit with that group. So that was the one of my very, very telling moments. The other thing that I want to say about this, because I really want this to be a workshop, the other thing I'll say is that there's a lot of stuff they have in textbooks. There's a lot of stuff when you go into the community, you're going to learn by working with the community person, whoever it is. You're going to learn that. So I know they tell us we got to get in the classroom, we got to do all this, we got to do that didactics. But the real learning occurs when you come outside of those four walls and go into that community. That's when you really learn, and that's when the rubber meets the road. And real quick, particularly for the emerging scholars, those people who have been through it, if there's one thing I will tell you, you remember anything I said this whole time, except the thing I said to the brothers, take yo to the doctor. Beyond that, you need to be able, when you engage in this research, you got to be able to you got to strike a nice balance between what you learn in that classroom and the flexibility that you're going to have to bring your research and the partnership, to the community engaged partnership together. And I'll just stop there.
Thank you very much, Dr. Thorpe. So I know we want to open it up to QA and answer any questions you might have, because we are aware that we're about 10 minutes from lunch. We want to be respectful of time. But I just want to highlight some of the themes that seem to be coming out about bidirectional learning, right? Putting in the time, being an authentic partner, acknowledgement, really connecting with those community leaders. And one thing that we haven't explicitly said, but it's coming through everything underneath, this idea of cultural humility. You might have all the years of education, you might have all the papers, all the grants, all the money, whatever it is, but you have to come correct into these communities with that sense of cultural humility, because you're going to be learning from ground zero, right? And it's a process together, an equitable process if we're going to do this work. So everybody's voice is equal, no matter who you are, where you come from. So with that, I want to open it up to questions, answers. Happy to provide anything. Yeah.
I just want to make a comment on what Dr. Thorpe just said. Make a comment on and I thought about this yesterday. Sometime when they were discussing, I can't remember exactly what it was, but I also have a marketing and advertising company, And one of the things I learned prior to that in multi-level marketing, because I still believe in multi-level marketing, the infrastructure of multi-level marketing, is that there's a famous quote that I always remember for the rest of my life. And it's, when you sit down with someone, the first thing you're supposed to do is say, what was the quote? People don't care how much you know until they know how much you care. So piggyback on acknowledgement,
Yep.
that's a strong quote, so I just wanted to say that. Thank you.
Thank you so much for sharing that. Brian?
Question for both of you. I grew up in the hood, so it's a hood question. Okay.
I did too.
Okay. And that's why I want you guys to answer this. What has been your script, your message when you got the brothers on the corner and you're trying to get them to learn about their health, or you're trying to recruit them from the faith-based side and also from the street side? So what has been your message when you approach these young brothers on the corner doing what they do, and they had bad experiences with the church and with education? So what has been your script, a message when you approach these brothers?
Well, for me, let me just say real quickly that most people are gifted, whether you know it or not, with the sense of detecting authenticity. It doesn't matter whether you're a faith leader or PhD or whomever. The reality is, within that first 10 seconds, most people can attest to whether or not you're really genuine. And so in those 10 seconds, I'm really just trying to establish a baseline. For me, I meet every person with this mantra that when you have done it to the least of these, you have done it unto me. It is a humbling message to let me know, but by a higher power, I could be in the very state that they're in. And I say to them, who is it that you love enough to create a legacy for? It is a powerful, challenging statement. For some of them, it's their mom who just passed away. And I said, wouldn't it be a great legacy lever for you to contribute into science on the behalf of someone you love?
That's good. So I'm not from the hood, I'm from the country, Macon, Georgia. So I'm not on a corner, I'm meeting them at a tree, most from where I come. But nevertheless, I get your point. Is taken very well. When I approach the brothers, what I've approached them for was I immediately try to find out what they prioritize, and then once what they prioritize, then that's the point. Most of the time when I'm meeting a brother on the corner or I'm talking to him, I'll say, if I'm going to recruit him, I'll say, hey, who is the person that you idol the most in your family? And once I get that, then I got a script. And most of the time is if they got a daughter and it's a baby girl, is she married? No. Don't you want to take her down the aisle? Oh, ain't nobody else gonna take her down the aisle with me. Well, nah, I mean, I get that and I understand that and I think it's important. I want to introduce you to something that can be helpful for you and for her. That's how I typically bring it up with them. But you gotta make it where it's important for them and not for you. Because if it's for them, if it's for me, and they don't know me from Adam, and they could probably care less because I'm probably interrupting something they're trying to get done, right? Whatever they're going somewhere, or whatever the case may be. So yeah, that's what I typically do.
Those are a great question, thank you, and great response. And one thing that's coming up here, it is the issue of trust in coming in authentically and coming, again, correct. Because when people talk about how black folks don't trust and it's an issue of trust, that puts the blame on them and not what you're talking about with this acknowledgement as well, that we as researchers, we have to earn that trust. We have to earn it. It doesn't come free. We got to earn it, and for good reason. And so coming to the corner or to the tree, wherever it is, but coming with that sense of, what can I do for you? That's very powerful, and why it matters. Having that message of why it matters, I think, is very powerful. Other questions or comments? Oh, yes.
Yeah, so speaking about the notion of making it important to the participants, can you talk about some of your examples of circling back as you're finishing your projects and teaching what we learn to people who are participating to make it feel like they contributed something and they understand what's going on.
Right, absolutely. I'll take this and then maybe y'all can jump in. But one thing I didn't really talk too much about in the dissemination of findings, so that's critical, is to share the results of the findings because they contributed to that study, and sharing it with them in a way that's understandable. Like we've done pamphlets and other things, you know, community presentations, in a way that they can take it in. But the other thing we have done, again, from this more action-oriented perspective, is that once they've gone through the study, as soon as we can, we share all the results that we can for that individual person. So we, in my studies, we're doing neuropsychological evaluations, we're doing neuroimaging, we're doing laboratory tests, blood tests, and that's really important clinical information. And not only that, if they were to go to the, to get all that done, that's thousands and thousands of dollars. So when we're done, we provide that information either to the person directly or to their healthcare provider, depending on who is their choice, with some kind of context for it, so that they can use the information as well. We think that that's really important, and there is research to suggest that that is an important motivator for folks as well. I don't know if others want to jump in here.
Yeah, so real quick, a study before we did the Black Men's Health Study, we were in the field, we were working in a community, and of course, not everybody in the community decided to participate in the study. We held a town hall meeting to disseminate the findings, and we put together a booklet with aggregate findings in list of different resources based on what we learned from the study. So there was a unusually high prevalence of prostate cancer in this area. Blood pressure is usually high in Baltimore, most inner city areas. Blood pressure is usually high. We gave resources for those, and then what we did when we produced the book, we actually worked with one of the students that lived in the community to help do the graphic design for the front of the cover. So we paid them for the graphic design, and on top of that, we mailed the findings out to everybody, every address in the community, whether you participated in the study or not. What we do now in the Black Men's Health Study, at the end, when you click to finish, they're based on key questions, and I think one is about physician diagnosed hypertension and a couple of things. We have a chart, an algorithm that produces where you are versus where Black men in your age, Black men in the United States, and we give that information to you immediately. It can be saved as a PDF. We've done that, and then we're thinking about taking from there and moving forward and to keep engaging them.
That is so great, and those are great examples of the give, right? Yes.
And I want to just share with you, in this model, I recently went to Providence and I interviewed a participant, to your point exactly, and he wanted to know what happens to my data once this study is over. And believe it or not, I've been interviewing over 100 Black men, and that question was in the top 10, because the gentleman says, I have the right to determine what happens to my data, and if you can't demonstrate to me, I don't want to be in your study. Very good question, sir.
Excellent question. Thank you so much for that. And unfortunately, I think we're out of time. Yeah, I think it's 12:30. So maybe if we have another question, we can individually. Should we individually take it, or do we have time for just this last one? Okay, last one. This is the very last question. Okay.
This is
Quickly,
a really quick
we'll answer
question. First, I want to say thank you all for sharing the framework. I think that is extremely profound for the work in this field. My question is, what advice would you give to a researcher who's scared to enter the community? Because a lot of times these researchers hide behind the agency instead of being actively a part of what's happening in the community. And I'm sorry if that's a long question, but I need an answer.
Thank you, LaToya. Dr. Thorpe or Dr. Williams, would you quickly like to give a?
Yeah, quickly. So for me, a part of the model that I have drafted is this one question. It is going to the community. For example, it is an embarrassment for you to be talking to a faith leader who has a very large footprint and you don't even know that. So the truth of the matter is there is a responsibility on the researcher to research the place and then go to the community.
Dr. Thorpe, anything to add? Thank you, Dr. Williams.
No, I don't have anything to add to that. Thank you.
That was excellent. So with that, I'm going to close out this session. Thank you very much, everybody, for your excellent questions and time. Enjoy lunch. And remember, we have a space outside to eat outside. Yeah. Oh, yeah. So we're going to have a raffle for these beautiful signed USC footballs. They have been signed by the NFL players who graced us with their presence yesterday, as well as some team members. Want to take?
So if you could take out your raffle tickets. If you don't have a ticket, can you give those? If you need a ticket, please raise your hand. You should only have one, though. Okay. Mhm.
Yeah, I'll get them. 1 second.
If you don't have your ticket, raise your hand, and we're going to have another one given to you. Now, you should only have one honor code. So after the raffle, we are going to enjoy our lunch. Again, please use the patio, beautiful outside.
Thank you. Bye.
You can take it again with your mask on.
Okay.
Yep, 1 second.
Okay, so she just wants to do impromptu. That's a good question. But we could get Donaldson to do it. He's one of these guys. I mean, one of the trainers.
Okay. No, it doesn't matter.
Okay, go ahead. Donaldson.
Donaldson, can you please come up, please? Mr. Donaldson here is going to draw the raffle. So let's welcome him. And if your name is selected, please come up to the stage. We want to take a picture and then figure out how we're going to put it on eBay. No, I'm just kidding. No. Last three numbers.
Well, first of all, does anyone want anyone? Maybe go in here. Go in here. Right here. One hand. Last three numbers?
The numbers are 3, 7, 8. Oh, wow. Eddie.
Excellent. Come on down. And what a deserving person. Ah, yes, thank you. Picture. One more football.
The numbers are 3, 6, 9. Okay, we have a winner.
Thank you. Dr. Aranda, happy. So appropriate. Thank you. Enjoy lunch. Oh, wait. She wants one more picture. Yes. Enjoy lunch, and then we're going to have a session right after lunch. We'll let you know.
There we go.
Can I get an individual view of it? There you go. Now we need to go around Okay, so you know what we're doing? about getting them in. Yeah. And, you got this stuff for you, right? Hello, hello. I'm going to ask everybody to take your seats. We're going to start the program again now. Okay, everyone. Well, as we get started with our last few sessions of the afternoon, I want to thank you so very much for, I hope you had a really good lunch, enjoyed yourself, and we're really excited for our next couple of speakers. Right now, it's really my pleasure to introduce Dean Linda Burton, who is the Dean of the School of Social Welfare at UC Berkeley. We were able to get some Berkeley Bears to come on down, take on the Trojans, show them how it's done, I guess, right? And I'm not going to go over Dr. Burton's impressive resume because you can see her bio. She's just a really incredible scholar. I'm going to just say that I count her as a very dear friend. She has been involved with me in my career in so many different phases of my career. As I was trying to learn how to turn my dissertation into a book, she was the first person that gave me an opportunity to teach with her at Duke, and so just on and on and on. And so I thought, would you give us the honor to really speak at the conference? And she said unequivocally, absolutely, just tell me what you want me to talk about. I'll share whatever knowledge I can. So I'm just going to tell you, it's a real treat that we get to learn from her today. So I just want to say thank you very much, and I'm going to turn over and introduce you to Dr. Dean Dr. Dean Linda Burton. How about that? Thank you.
Well, good afternoon, everyone. Really glad to have the opportunity to share some insights with you. And in doing so, we're going to mix things up a little bit. Okay, thank you. We're going to mix things up just a little bit more in the topics that we, both myself and Toni, cover this afternoon. Essentially, what I'd like to do is I want to extend the very important discussions that we had yesterday, which talked a lot about health disparities, also talked a bit about trauma and its impact on health disparities. I want to take that a little bit further and broaden the discussion to be more inclusive and more deeply embedded in a discussion about social networks and specifically issues around racism, discrimination, and the other types of isms. So what you're going to see from me today and also from Toni again is that we're going to shift focuses a little bit from the broader demographic kinds of factors that we talk about that affect health disparities, particularly with athletes. And now we're going to get into relationships. And you might say, well, what does that have to do with brain health? Well, it probably has a lot more to do with brain health than you might think. Next slide, please. Just wanted to share with you the research that I'm talking about today is research that I started when I was at Duke University. There, as such, you see among the research team that worked on this particular topic. I had a group at Duke University, but also from the University of North Carolina at Chapel Hill. Okay, yes. Next slide, please. This work comes very intentionally from the work that I've done with the William T. Grant Foundation in New York City with respect to their program that focuses on how do we reduce inequalities in the United States and globally. And what I brought to that discussion, as I pointed out, is a focus on relationships, and specifically how what we do inside of relationships actually contribute to reproducing inequalities over and over and over and over again. And part of what you see in relationships that actually produces those particular outcomes is when people are engaging in processes that lead to social exclusion, or, for example, many assaults or microaggressions in the course of a day in interacting with other with individuals. And what we see is when we look at those particular factors, that they do raise the impact of trauma, or I would call it, if we all had a trauma score. As an athlete, one of the ways you can look at your trauma score if you're playing in the NFL is how often you've been hit by, what did the guy say yesterday, 55? Yeah, 55, exactly. But in addition to those particular hits, you would be surprised at how social exclusion and behaviors that are reinforced around those and microaggressions add to that trauma. And actually, we are going to argue here, it doesn't change your brain, but it changes the way your brain responds to certain cues. And these cues are important to understand because it has an impact for the kinds of relationships that you actually engage in or even have the capacity to engage in. So in presenting this work, what we did here is we brought together ethnographic studies. And when I talk about ethnographic studies, this is primarily the way as a researcher that I've gathered data for, gosh, almost 40 years at this point in time. I've done very small ethnographies, and these are ethnographies maybe of 40 to 50 families, where you're really kind of up close and personal and very intentional with families for a very, very long time. So in some of the families I've studied, I've been with them for 7 years or so, had been with them for 7 years or so. So I get to see them in their everyday life. I get to see how they respond to certain situations. Most importantly, I get to see how what they say either does or does not match up with what they do. And that's a key element you just want to be able to understand in life. It tells you a lot about a person when there's a mismatch. And that's part of what I will talk about today. So in taking in that kind of ethnographic data, I teamed up with neuroscientists at Duke University. And they said, wow, you have all of this information on these families. I mean, I know everything about them, and some things I wish I really didn't know, but it's hard when you develop those kinds of relationships not to know that. So I really know their trauma profiles. I know their, the daily experiences they have with trauma, as well as the bigger experiences as well. They said, with that kind of data, you can do a lot. If, one of the things you might want to do is look at it from a neuroscience perspective and, test out some ideas with giving your respondents some probes, or cues, in terms of reacting to certain words, while they're also getting an MRI. And through this process, we are able to tell how they're responding to certain cues. And we can tell whether the right side of the brain is, when I say the right side, the side of the brain that is going to render a positive outcome is operating in that case, or whether the reaction is coming in on another side that doesn't render the outcome that you might expect that it will. So, next slide, please. And next slide. Okay, so let's talk for a little bit about these generic processes in the reproduction of inequality and exclusion, and what that means for the kinds of traumatic events that you might have in your life, or the kinds of inequalities that are created. And also, please know with that it's not only that reaction that I'm interested in, because as a sociologist, I'm also interested in social mobility. So I'm very interested in how all of this plays out in terms of how you build social networks and social support that can allow you to build social capital. So as some of our football players were talking about yesterday about lining their pockets with money, I'm essentially talking about that today. Because you need oftentimes social capital to build those kinds of relationships that will lead to positive outcomes with respect to building your social mobility. So what are the kinds of things that probably all of us in this room experience every day that might compromise those generic processes in relationships that might compromise that experience? As I talk about these things, I do want to tell you, and I'm doing this from the perspective of a scholar and not from the perspective of my political leanings, but Donald Trump is the poster child for generic processes in the reproduction of inequality and exclusion. And I offer him to you as an example of that. It is because, again, looking at his behavior as a sociologist, every time I see him open his mouth, he engages in one of these things. Okay. So the first thing that we think about here that has an impact on these outcomes is a process called othering. And that's when individuals within a dominant group actually put people into a status where, or they actually create an inferior group or put that into existence. So, there's at least three types of othering. There's oppressive othering, implicit othering, and defensive othering. And essentially what people do in this context is they dominate by using lots of terminology and engaging in lots of behaviors that are meant to make others feel morally or intellectually inferior. So it's one group that's actually defining that about another group. So as I was looking at our athletes yesterday, I thought about the fact that, gosh, I bet you they experience a lot of oppressive othering and maybe not even are aware of the fact that they do that. While they may be in these especially the professional athletes might be in their high status situations, people can tell them how much they love them out of one side of their mouth, and at the other side of the mouth, they can talk about them as being urban predators. That's something that I heard a lot yesterday. And so, what do you do with that? The other thing that's oppressive othering is when you, in terms of what the sociological literature has to say about this, is when you become a commodity, which is something that I heard from athletes, from our men and our women athletes yesterday. That's also a way that you are oppressed. Whenever you become a commodity, you are. The thing that probably gets me the most in the day-to-day is this notion of implicit othering. And that's when, people really try to create the image of them being powerful and very moral. And that when they look at you, they kind of pick at you. They want to fix you morally. So it's like, no, you're not doing that right. Well, that's not exactly the way to think about it. Or I wouldn't do it that way if I were you. But in everything that they're saying, it's not in a supportive way, but it's in a way to elevate themselves as the moral high ground and to demean you as the moral low ground. And then when we have defensive othering, I've seen this across the board in families that I've studied. An example of defensive othering is that, and I've seen this sometimes with families that I work with. I've worked with a lot of families that have been on welfare for a long time. And in and of itself, it's like, you know, what's the big deal about that in terms of not registering any judgment? But in particular enclaves, what you will find is when you talk to neighbors and the like, everybody can be on welfare, but people will say, well, you know, she's on welfare, but we're not the same kind of people. So when you're starting to differentiate yourself, all that stuff enters into how you engage in relationships. Then there's something called subordinate adaptation. And that's when you develop coping strategies as a member of a subordinate group to accept the practices that demean you for a degree of approval or protection. Like when somebody pats you on your head and says, oh, you're a good boy, and you found yourself behaving in that way, and you've allowed yourself to be subordinated because you want that approval or protection. I always tell my mentees, for example, you need to be very careful who you allow to validate you. Be very careful who you allow to validate you, because if you're not, you can find yourself in a position of subordinate adaptation. People who really care about you are not gonna do that to you. If you're doing something that needs to be changed up, they're gonna advise you in a different way, and they're gonna offer you options to be able to work through that. But when somebody's patting you on the head and they're using these sort of loose compliments about how wonderful you are, you need to be aware. And you need to, you know, kind of check yourself and saying, oh, am I really the good boy, or am I doing something that's allowing them to actually dominate me? Boundary maintenance. And when you go back to Trump, he engages in all of this, all of it. He reproduces inequalities big time. So let's go to boundary maintenance. This is when individuals really, the way they preserve inequality, by what they do is they limit access to valued resources. And in doing this, they usually control networks. And another way that people maintain boundary maintenance, and folks might not think about this way, when people hold back information from you that you need to move forward, that is a way to create inequality in the relationship. So another thing to be important, another important matter. The next one is emotion regulation. And this is when a person in charge regulates the discourse and really provides you with a script for how you should feel and how you should react. And that's exactly what we saw on January 6th of 2021, I guess it was now. And all of that leads to dehumanization. So the things that I just laid out for you are the kinds of things that I study in particular, but I think they're these things that we take for granted, and we're actually navigating them in relationships every day. especially in a position, in positions where the power dynamics are off. 9 times out of 10, you're navigating those kinds of issues, and those issues bring with them a level of stress that you don't necessarily pay attention to because you compartmentalize it. You said you don't have the time or the energy necessarily to address each one of those kinds of factors. And I've been in situations where I've watched my families deal with these issues I call them my families. These are individuals that I study, but I watch how they deal with them, and I've even taken notes on myself in the day and say, okay, that was this, that was this, that was this. And by the end of the day, I said, oh my God, I know why I'm so tired, because I was navigating all these particular things during the day. And when you add those up, that leads to trauma that, especially if it's prolonged, that can have an effect on how your brain responds to certain things. So next slide, please. Okay. And next one. All right. There we go. So what do I mean when I talk about trauma? Well, in my research, persistent poverty is a main factor is a major elicitor of trauma, but also, again, the issues of inequality that I just spelled out for you. So what does trauma look like then if we want to say, well, how does trauma then affect or shape the way you respond to certain things in the context of what it means for building relationships that might lead to you building social capital in order to have upward mobility? So what we see in the myriad studies that we have done about this is that what inequality can do is it affects at least 4 internal resources for individuals and families. One of the things it challenges is one of the things that gets, as we call it, knocked out of whack is that your security from being with and connection to others. When you are really traumatized, that is oftentimes, it gets knocked out of whack. So you're making decisions, but not from a point of being centered, but actually decentered. Secondly, your ability to own your own feelings are compromised. So even if you're in a situation where you're trying to negotiate things and trying to talk through things, if you can't own your own feelings in that context, it has an effect on the relationship, and it creates inequality in that relationship as well. The other thing that gets knocked out of whack when you're under a lot of trauma is your intellectual creativity, which has a lot to do with things like spontaneity and in relationship. And the fourth thing you see that gets knocked out of whack, believe it or not, is your verbal fluency. So sometimes you might not be able to find those words that you need to negotiate or to resolve issues in that relationship. So what do you see as the derivatives then? When a person is experiencing persistent trauma, oftentimes you see the characteristics of loneliness prevailing. There's a numbness about that person in terms of, they can talk to you, but you can tell that they're not present. Oftentimes when people are not present with you, it's not just because they're busy. They might be traumatized about some other things that really knocks them out of whack that way. There's a sense in being in a situation of experiencing something called ambiguous loss. You feel like you've lost something, almost like a person has died, but they haven't, but you don't know what that loss is because it's ambiguous. You just have this emptiness and this loss around you as a function of the trauma. that there's a brittleness to you. You're not all smiles when people come and talk to you. You cut things short, and you're very brittle in how you respond. And oftentimes, there's long periods of silence where you just don't have those words. So that's an example of the verbal fluency issue. So let's see the next slide, please. So what exactly am I asking with all of these? This sociological ideas and brains and MRIs and, trauma. What am I trying to look for in this particular work? Well, essentially, I'm trying to put 4 kinds of variables together. First of all, I want to be able to define trauma, and not based on the literature and also empirical work. We know, first and foremost, that trauma does affect brain function. Here, I just want to underscore again, when I start talking about brain function and the like, I'm not talking about trauma from the perspective of changing the structure of your brain, but rather how your brain responds. The difference in talking about it that way and in looking at these relationships that way is because when you know how our brain responds, you have a greater likelihood of being able to intervene. And that's why this research becomes more important. When your brain structure changes, we're talking about a whole different situation there. So we want to know how trauma might affect the brain. And in the context of that, we are looking at brain response patterns, things like emotion regulation. And the primary way we've been able to assess that in the work that we do is to look at how people think about themselves, how people think about who they think they are and who they should be, and if there's any discrepancy between those two things. And the discrepancy that you see is a proxy for a lot of actual factors that can tell you about how they're responding to certain situations and what it means for particular outcomes. So then in looking at that relationship, I want to know how trauma might affect brain responses and whether those brain responses tell us anything about someone's propensity to develop social capital. Do they have a propensity, or they have a probability in how they move through the world to engage with people, to look for opportunities in networks that might lead them to be able to develop social capital. And as a function of that, the dependent variable then is whether or not that social capital and those who find it are able to use it in ways that provide them, one, mental health, good mental health as an outlet for, as an outcome, but also social mobility. Okay, so next slide, please. Some of these, in the slides that come after this, I'm going to skip through them really quickly because in my usual OCD way in trying to explain things sometimes, I got a little deep in the methodology, and my thought is, well, I don't know if they need that level of detail. I'm happy to offer that level of detail to you. We could talk individually afterwards, but it would keep us mired in discussions for a long time. At any rate, again, what I want to know is, the long-term goal is to understand the link between brain responses and the capacity to develop social capital and how trauma plays a role in that. Next slide, please. So there's a number of theoretical perspectives that play a role in this. I'm not going to focus on them in great detail. Just to say, as a sociologist, symbolic interactionism plays a role. I can send you papers, talk about that. Social capital, there's a vast literature on that. The main thing I want you to really understand is this notion of the theory of self-discrepancy, where we're able to identify emotional vulnerabilities and strengths that are related to how people think about themselves and the actual ideal and ought selves. And when I'm talking about that, this is our indicator for potential trauma. If we're seeing a lot of discrepancy in what we see on the MRI and brain functioning, when we give them cues that get at these particular issues, that we know something, or at least we're going to hypothesize right now that something is going on there. Next slide, please. So in the theory of self-discrepancy, there's 3 aspects of who you are that you can look at: the ideal, the actual, and the ought. Next slide, please. For the purposes of this work, we are only focusing on the ideal self and the ought self. And so we're asking essentially 2 questions. With respect to the ideal self, what the questions we are asking, or the cues that we gave our respondents before they went into the MRI, had to do with what kind of person would they ideally like to be. And essentially, we wanted to be able to determine from what their responses were, did they have the propensity to think about positive outcomes occurring in their lives and making good things happen? So do they have the internal power? Do they have that power to actually make good things happen? In the ought self, we're asking them, what kind of person do you believe you ought to be? So who do you ideally think you would like to be? And that's about hopes, aspirations, and achievements, and who are you in terms of who you ought to be. That's about responsibilities and obligations and keeping bad things from happening for you. So, you know, we spent years on these measures. Again, I'm not going to go in a whole lot of detail with you about them, but they proved to be really good indicators of what we were trying to get at, how trauma was affecting how they were responding to things. So let's move to the next slide. All righty. Okay. So in this study, we're focusing particularly on the women in the study, but as I've talked to my colleagues, we've talked about the fact that the same things that we are doing with this work definitely applies to men as well. And I couldn't help, and I just couldn't resist the fact when Robert asked me to make this particular presentation, to really explore and think about what it might mean for, athletes, and particularly from the perspective of looking at their brain and bringing to the fore the fact that it's not only what happens to you in the process of doing your job as an athlete, going back to the NFL, for example, tackling people and so on and so forth, but what are the other things that are going on in your life that are adding to the trauma experience for you? That's where social workers come in, and that's where that help is needed. So even though this, this data is about mothers and their children, there's an important message that I want to be able to say about that. We think these very same questions should be probably asked of athletes, because it's just not only about their performance in the sport, it's about all the other things that might be causing trauma, that might exacerbate those kinds of situations. So the methods, again, for this study were really they're very detailed and very well thought out, but we did essentially a pilot study using 2 data sets. where we had families, primarily in rural settings in North Carolina, that we had been following ethnographically for a really long time, like decades, and where we had already gathered a whole bunch of data on what goes on in their family lives every single day. What does their trauma profile look like? What does their personality look like? What does their health look like? And we had essentially a control group and what we would call an experimental group. So, and we really involved in this pilot work only 16 families because we just wanted to explore if we could even find a relationship among the variables here. And just so you know that the respondents in both the experimental group and the control group were matched in terms of, their economic situation, the mean age of mothers. And as I said, we also included their children here because in terms of being an intergenerational researcher, I'm never satisfied with just knowing what the individual has done, especially when I think of parenting. I'm always thinking about legacies. And I'm always thinking about what are you doing that will go to the next generation and the next generation and the next generation. And as a function of that, that's where my interest comes in reproducing inequalities. Okay, so let's move to the next slide. Okay, that one's, and the next one. Okay, and the next one. So, in addition to all of those isms that we talked about in the kinds of behaviors that are generated in the kinds of behaviors like othering, where you'll experience racism and other kinds of things, these are the kinds of traumas that our mothers were experiencing. And I'm gonna just give you an example of one. This is an example of one mother in particular. I would have to, and she was one that I followed, so I spent a whole lot of time with her. She daily re-traumatized herself through perseverations. So all of the traumas that she had in life, she repeated them verbatim every day. She was in a cycle, a loop. And she would repeat every day, this happened to me, this happened to me, this happened to me. Every time she did that, she re-traumatized herself. So what are some of the factors that affected her trauma? Chronic poverty. She was sexually abused by her female cousin over a decade, starting at age 3. The perpetrator was the one who abused her had actually been abused by the uncles. She found her mother dead when she was 5 and then was accused of killing her mother and other relatives in the family with her evil mind. Her aunties, who she ended up living with after her mother died, would punish her on a daily basis. And how they would punish her is every day she came home from school, they had taken all of the dishes and pots and pans out of the cabinets and had her wash them and put them away every day, even though they hadn't been used. So that was the form of punishment that, she had as a child. Domestic violence, her first marriage, DPS takes her children when she is arrested for drug possession. She gave birth to twin boys, had to put them up for adoption, and then she's considered overall the black sheep in her family. She also has chronic homelessness. She, in addition to her sons, she had 3 other kids who remained with her. And so we looked at the trauma profile of all of her kids because we did MRIs on them as well. And what you see with one of the children in particularly is that this child experiences vicarious trauma through her mother every single day. So one day I'm, at the house just hanging out with her mom, and her mom is going through this perseveration process where she's daily re-traumatizing herself. And so her daughter gets behind her, and as her mother is saying, when I was 5, this happened, when I was 10, this happened, and this is how I felt. Her daughter was standing behind her, mouthing the same words and doing the same kinds of bodily, actions as well. So in a way, her daughter is vicariously being traumatized by her mother's perseveration. These are things that people missed. Sometimes when you don't do ethnographic research and get a chance to see how these things play out on a daily basis. So even as you're talking about athletes, all of these things can be compounded on those brain effects that you talk about. She had also experienced chronic homelessness and the children and foster care experiences. With families like her, and there were several of them, I talked about it jokingly with my team at one day, but I think these families started making me believe in something I would call the Jesus variable. And the reason why I call it the Jesus variable, because remember I told you about the reproduction of inequality and that higher moral ground that people developed? That's what you start to see in this family, where they are really involved in replicating inequalities in the relationships that they're building with other people. And you see when they're engaging in those interactions, they're probably compromising their ability to develop social capital with others. Okay, so next slide, please. All right, so as I said, what we did in terms of collecting information is we already had all this extensive information about families and how they what their experiences were, their health since the day they were born, and so on and so forth. But we also administered these, the ideal self and ought self instruments to them. Well, we came up with cue words that we could give to them when they went into the MRI that would let us know if their ideal self and their ought self came to bear or were non-discrepant about how they felt about responsibilities and obligations and hopes and aspirations. And again, these are the variables that we thought would help us understand the level of trauma that they were under. Next slide, please. Okay. All righty, I think that's right. All right, so just to give you an example of what some of the word cues were, so you won't think that we're giving these word cues that are psyching people out or making them feel uncomfortable in the MRI. For the moms, some of the cues that we gave, we use adjectives, and we'd see how her brain responded when the word loving was given to her: caring, protection, available, patient, strict, happy, wise. For the child's cues, the word choices we had, and how we watched in terms of how, when they recited the word, what part of their brain lit up. Some of those words were smart, athletic, popular, hardworking, clever, pretty, thin, successful. Plus, they also created a number of words on their own. We were paying attention to the negative reactions that they would have to these words as an indicator of their personal standards and ways of viewing interactions. So let's go to the next slide. Okay. All righty. I can read with my glasses on, but I can't see the screen with them on. Okay. All right. So actually, let's go to the next slide as well. So again, essentially then what we're looking for is if trauma is really having an effect on these, our moms and our children's propensity to, I guess I would have to call it, to be in the right frame of mind to develop social capital, we're gonna see a difference between these dyads, the mother-child dyad, where trauma is consistently high over years for a time, over years, as compared to families in which trauma is not consistent, that it's low to low moderate as compared to families where it's high, high to extreme. So if the brain is lighting up in the areas that it should be, when we look at the MRI, it tells us something about how respondents are processing information. And in the long run, we want to know how that acquaints with behaviors that help or hurt them in securing social capital. So let's go to the first MRI. Well, as you can probably expect, and I'm not gonna read you all the details about the prefrontal cortex and the occipital cortex and so on and so forth, and height, and all of the measurement kinds of things. But as you can probably tell, when we're giving them the cues, and then we're reading their MRIs after we've given the cues. And actually the data point that we're most interested in is what the MRI is saying, because we have like over 1,000 readings on the MRI. So that tells us about the consistency and how they're responding to things. So as you might imagine, that when we look at the MRIs after we've given the moms the cues, as one would expect, those who have been traumatized, the part of their brain that lights up when one is open to relationships and is open to, positive experiences and the like, that part of their brain lights up for the ones that have the low trauma. For those who have lots of trauma, an entirely different side of their brain lights up. It's not the site or the place that their brain should be lighting up if they have potential to be open to these other kinds of relationships. For them, the issues, the side of their brain that lights up is the side that focuses on self-criticism and morality. So they're really fenced in and not as open as, I don't want to stretch this too far because I can't at this point say this is generalizable or anything like that. But from an exploratory point of view, again, the ones that have not experienced trauma at the, the intense level, the side of their brain that really is signaling that the positive effects and, the pursuit of opportunities is lighting up, and it's not doing that. Another totally different place is lighting up for the moms who have a lot of trauma. Next slide, please. The same thing is happening when we ask them about questions of vigilance and hypervigilance and error checking and the like. For the control moms, the side of their cortex that one should respond to in terms of actually taking risks, but still having some level of vigilance lights up. But for our moms that have a lot of trauma, we see that parts of their brain are lighting up in entirely different ways. So that there's almost a hypervigilance, a cautiousness, again, self-criticalness, and a morality issue that lights up whenever the cues are presented to them. Let's go to the next one, slide, please. Well, as you would expect, although it's earlier on in the process, because kids are much younger. In this instance, we were focusing on their adolescent kids. As you would expect, with both sets of cues, we see that the children's brains are at least starting to show signs of responding, having brain responses that are exactly similar to the ones that their mothers are engaged in. They're not as highly developed because their mothers are much further down the road and they have more trauma, but it's already on the pathway. And what's important for you to understand about this is not genetic, because we're not looking at the morphology, the structure of the brain. We're looking at how the brain responds, and that's learned behavior. So that has implications, again, for how we can intervene. All right, so let's move to next slide, please. The next slide as well. We're one slide behind. Okay, well, I'll just let you know. Essentially, the mothers and the children in the control sample, that's the highly traumatized sample, showed typical brain responses to personalized cues for making good things happen versus keeping bad things from happening. I'm sorry, that's the control group is the non-traumatic families, meaning that their potential for engaging in relational behaviors that will generate social capital is more promising, at least in this subsample, than the other mothers. The other mothers responded to the reward cues as if they were signals to be self-critical and to invoke moral principles like the Jesus factor, and to the threat cues as if they invoked moral principles, meaning the potential for engaging in relational behaviors that will generate social capital is less promising for this subgroup. And as I said earlier, we see in looking at it intergenerationally that the same patterns are starting to present themselves with respect to their children. So I'm not sure where we are on the slideshow, but I can just move ahead really, really quickly to say that what this kind of research is I know it's exploratory, but it allows us to take the considerations about the effect of trauma on the brain to even another level, that its health definitely is key here, and the experiences that our athletes, the physical experiences that our athletes have are key as well. But we also need to understand what other kinds of influences or other kinds of traumas they are exposed to, and whether those traumas make a difference in their propensity for developing relationships. And here I'm interested again in how those relationships lead to building social capital and social networks. But clearly we could discuss that in terms of other outcomes as well. So I will stop right there, and I thank you for your attentiveness with a presentation that had a lot of nuts and bolts to it, and I appreciate you listening.
Okay, what we're going to do is we're going to bring our next speaker up, and then after she speaks, we'll have a Q&A time for both of them together. And I am going to put this podium up here. Thank you. Now, I have the podium up here at the request of the next speaker. And just as you've seen with Dr. Burton, She's just a wealth of information. The next speaker, again, is very near and dear to me in many, many different ways, personally as well as professionally. Dr. Toni Antonucci at the University of Michigan. Again, I'm not going to go over her background, but it is vast. You'll see from reading her bio that she's just accomplished so many different things. But again, I will just say on a personal level, we've bonded over the fact that she was an NCAA athlete. And when you see her, you'll ask her what sport she played. As well as, you know, she just has, I've seen her mentor, again, myself, but so many students on so many different levels of their career. And the one thing that I will say that is consistent in all the people that she works with is that she really cares. I mean, I've had the opportunity over the last few years to, on a bi-weekly basis, bi-monthly basis, we're on a call together in the group that we're involved with when we're doing life course development. And I've seen many students come in throughout, but she makes sure that we are very, very well prepared with our science, but then she also makes sure that if you have anything going on in your life, that the phone is available, pick up and call, and she will share, you know, spend her time with you, of which she's done with me many, many different times. So with that being said, I'm just going to tell you how delighted I am to have her here, and I think that you're going to be in for a very good treat on all that she has to share. Dr. Toni Antonucci.
So, as you can see, I'm a short person, so I could hardly see. It's better if you're sitting over there, but when you're sitting over here, I couldn't see much. But anyway, now I have to put this up, and I'm going to be my computer's going to be in the way. But can you hear me well enough? Okay. Okay, so now I just need this one. Well, first I want to say thank you, Robert, Monica, and Maria. This has been a lot of fun for me, and I hope it has been for you. So my problem today is that I have a lot of things I want to say, and which Robert might tell you is always the case. But I'm going to try to minimize it and give you a lot of information, and I'm really very impressed with the degree to which the kinds of things that I find important and I've studied parallels the kinds of things you've heard from Linda, from April today, and some of the things even that you heard from the athletes yesterday. What, I guess, sort of some big picture things I'd like to say is things tend to fit together. And you'll see my title, which I actually changed from a life course perspective to a lifespan and a life course perspective, is meant to take that into account, that there are a lot of things that we need to think about, whether it's the social determinants of health or genetics or biology. A lot of things play into the person you are and the kinds of behaviors that you engage in. And this is a tricky thing I want to say, because I want to say there's a lot of things that play into it, but I don't want to lead us to think that life is predetermined. If anything, I'd like to go the other direction and say there's a lot of potential. But what I study is how to maximize that potential, and what are the things that have changed over the years in terms of what we understand as maximizing our potential. And the reason this is important is because that stage has changed a lot over the years. So I'm probably the oldest person in the room, 73 years old, and proud of it. And life has changed a lot since I began. I got my high school degree at 16, my college degree at 20, my PhD at 23, and I wasn't in a hurry. It just happened to be that way. It just sort of, I wasn't always a rule follower, but I followed the rules and then got done, and I was like surprised. It Didn't take as long as other people said it would take. But I say that only to say I spent a good part of my life being younger than everybody, and it was always a disadvantage, because especially if you want to be an academic, you want to be old and wise, not the young and dumb. Now I can be old and dumb. but it's an interesting feeling to go through life, spending a lot of time having been the youngest one in the room, and then transition to kind of the same age as everybody else, and now the oldest person in the room. But what I like about it is I love being around people of different ages. People my own age are fun because we have kind of a shared history. People who are a little bit younger, I knew them when I was kind of middle-aged myself, and they were the youngins, and now being around young people is informative. I mean, first of all, it's energy, that's very exciting, and it reinvigorates the way I think about things. But the reason I started with my early history, when I first started studying psychology, we knew everything. And the thoughts were so primitive. We would study drives. Well, there were 10 drives. Oh, well, here's another drive. Oh, there's 11, 12, 20, 30, and so, it's not really about drive. So there's the perfect theory. Oh, well, then there's this caveat. Oh, well, we had to change the theory a little bit like that. Then we finally figured out, well, maybe there's no one theory. We should take a lot of theories into account. And kind of that's what I want to sell to you. Take a lot of things into account. So I'm going to talk about, on this slide, when you don't have to look at me, I want to talk about lifespan and life course perspective, linking the micro to the macro, a convoy model, which is a heuristic framework for studying social relations, a little bit about empirical evidence, the stuff we thought we'd find and the stuff we didn't think we would find, and stuff we're thrilled to find, social relations and health and resilience, and I'll come around to the fact that one size does not fit all and give you some thoughts about how to move forward. So lifespan and life course are almost psychology and sociology perspectives, but I come from a multi-perspective background, and I work in multidisciplinary teams, and I believe that we are informed by the other disciplines we work with. I really firmly believe that. The same way I feel like I learn from multiple age groups, I learn from multiple disciplines. And I once wrote an article. Every once in a while I get a title of an article I really love. This one was called Teams Do It Better. And I really think so. You get a much better perspective. Even the stuff we've talked about in the last 2 days, you get a better perspective if you hear about it from different perspectives. And you're much better off if you're not looking for the right answer. If you're just understanding it as a difference in perspective. Gives you a fuller view. So that's my pitch about lifespan and life course. Some people like to dichotomize them and make like they're separate. I like to think of it as a contribution to a whole. So lifespan tends to be, and I want you to know, I'm kind of a social developmental psychologist, so the developmental psychologists think I'm a little weird, and the social psychologists think I'm a little weird too. So, and my sociology friends often think I'm a sociologist, which I find very complimentary. So I'm not traditional in any way in terms of their perspective, but I want to sell it to you anyway because I think it's the most productive in terms of really informing what we want to understand. So I will run through a lot of things quickly just to give you a flavor of it and to keep you awake because I realize it's been a long couple of days, and I congratulate you for still being here. But if there's anything that I go over once lightly and you'd like to hear about, I'd be happy to talk to you about it either afterwards today or via email or whatever. So lifespan takes the individual perspective and it examines how the individual grows. So the easiest way to think about it is the infant to the old person, that physical person, but also all the processes that happen. We've talked about cognitive functioning, the way in which a child functions cognitively through adulthood and old age. And we talk about the individual trajectories. So are you the top of the class or the bottom of the class? That's an example I would never like to use publicly, but to just give you an idea of what I mean by a trajectory. Are you on a success trajectory, a failure trajectory, a rural or urban, whatever it is, whatever the concept is that you're interested, but there's a pathway. Maybe that would have been a better term. And then the assumption is that the driving force is internal or endogenous, a micro level, internal, individual driving force. The life course takes the bigger perspective. It's that individual who's in a group, and it's the group that influences the of the development. And here in the last couple of days, we've talked about a lot of different groups. And, you know, you're listening to people talk at multiple levels, but you can tell the ways in which different groups influence them. And when Linda was talking about the groups her families, and I love that term, I know exactly how she feels, the groups, those families and how they influence who you are. That life course group aspect influence the individual aspects and how they develop over time. It defines a social pathway. East Coast, West Coast, rural, urban. That really sets a path for you. And then there's the role. Are you the youngest person in the class or the oldest person? Are you the teacher or are you the student? Are you the mother or the grandmother? Let's throw a few men in there. Are you the father or the grandfather? So, and those roles are important to you in terms of how you define yourself and the transitions from one to another. So I didn't expect to talk about this, but I talked about the transition from being the youngest person in the group forever to suddenly being the oldest person in the group. When did that happen? Sometimes you notice these transitions and sometimes they're just done before you notice. And then these kinds of things tend to be externally. So you don't define the group you're in. The group is exogenous to you, right? Unlike who you are as an individual, which is more endogenous. Okay. So I want to talk a little bit more about this and talk about major themes. Lifespan research versus life course research. I myself have always tried to do a little bit of both. Any study I do, but I'm kind of lucky because I can do studies that are broad. So my research tend to include individual differences, adaptivity and plasticity, that is, allocation of resources, who gets what, and self-regulation. Those are examples of lifespan research, and those concepts are important to the kinds of things I'm trying to understand. But so are the broader concepts of life course research, like age stratification, like the historical or cohort period effect within which you're living. I mean, the easy one on that one is our children are living are the pandemic cohort the same way there was the depression cohort. This is going to follow them throughout their lives. Then there's the accumulation of both equalities and inequalities. We talked a lot about inequalities, and they don't just happen. You know, it just doesn't happen when you're 50. It starts early and continues on, and there is continuity in areas that you would prefer there not to be continuity. And we're looking for ways, in those cases, to have discontinuity, and that can be done, not easy for some things and easier for others. But we need to recognize that these things accumulate over time. I'm a gerontologist. By the way, I forgot to say this. I am a gerontologist. I'm pretty well known as a gerontologist as opposed to a lifespan developmental psychologist. I started my gerontological career here at USC. When I came here to NIH, it was before there was NIA, funded 6-week course in gerontology. I knew nothing. There's some basic concepts for those of you who know gerontology, activity theory of aging, disengagement theory of aging. I didn't know anything. People would say, well, what do you think about this? You know, this versus that. And I'm like, I don't know, this or that. So, I mean, I knew nothing. And I started here, and the bigwigs were all here. Somebody who spoke to us talked about how this gerontology is big here. The bigwigs in the field were here, and they taught me in these little 2-week courses. So, an accumulation of knowledge that started right here. And then there are linked lives, which is something I believe about, and a lot of people talked about it in a different way here. But who you connected with that had an important influence in your life, and the way in which people who are important in your life, things that happen to them happen to you too, right? If your father loses a job and there are 5 kids in the family, he's not the only one who lost that job, right? He's not the only one who's affected by it. So I am strongly committed to thinking about things in terms of development and pathways and change, not static. And Linda talked about this, and April talked about life is dynamic. Things are not settled. You may be on a pathway, but I really like to believe that you have the opportunity to direct that path. Some people have more opportunities than others, and that's one of the things we want to understand. But there are lots of similarities in the lifespan and the life course perspective. And one is that both are lifelong, right? It's not a cross-sectional phenomenon. It happens over time. They're multi-level, they happen on a lot of dimensions. They are influenced by the context you're examining. They're dynamic. There are micro and macro influences, and there are gains and losses. People often talk about, you know, when you're young, it's all gains. When you're old, it's all losses. It's not like that. There are lots of things you lose when you're young, and there are some things you gain when you're old. And there are also issues of risk and resilience. I really resonated to what April said earlier about not liking the use of the term vulnerabilities. People do like to use that term. But I kind of hedge my bets by using the term risks. So it's not that you're vulnerable, it's you're at risk because something's out there. But also, and I think there's increasing attention to this, the issue of resilience. What we really want to do is help people be resilient. And I want to make sure that when you talk about risks and resilience, we don't talk about it in a way that blames the victim, right? I mean, some people have a lot of barriers in their progress, and they may not have an easy pathway forward. It doesn't do us any good to blame them for it, and it's not likely. I don't see it as anybody's fault. Well, I can talk about whose fault it might be, but I mean, it's not the individual's fault. We need to understand how come they're in that situation, and what can we do to make it better. So here I want to talk about linking the micro and the macro, the multi-levels of influence. And the reason I want to talk about that is because we go through, in science, but I think in society as well, we go through love affairs with different levels of understanding. So we're really big right now on genes and biology. Everything, if you want to get a grant, you got to put in some neuroscience, you got to put in some biology, you got to put in some genetics. I'm not against it, but it's one factor among many. And it influences, I would not deny that it influences how things play out for you. Similarly, there's the individual, there's that individual in the family or community, and there's the environment, culture, and society. So there's multiple levels. And I am not arguing that you should cover all these levels, that you should study them, you should be an expert in them. All I'm arguing is that you should recognize that all these levels have an influence. Okay, so this is just, for those of you who don't, this is my, plan A. For those of you who don't get the idea of development across the lifespan, this is a nice, simple pictorial. You start out as a kid, you become child, then adolescent, adult, blah, 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 up to being, and used to be we just say adolescent, adult. Now we say young adult, middle-aged adult, older adult, oldest old adult. So, because people are living a lot longer, so they have, they have a lot of different stages. So we used to think, when I first started doing surveys, they would just say something like 60 plus. That was the age group. And they would be much more interested in finer discriminations of young age, but they thought, once you get to be 60 or 65, it's done. You don't need any specifics. Then there's the family, and this is a very typical idealized family, the mother and the father and the child. I didn't even know how to make a triangle that had 2 kids or 3 kids or 5 kids. But the idea is all these points on that triangle influence how that child develops, right? It's an interacting family pattern. It's not just one trajectory, it's all of them interacting. And then there are all of them interacting over time. So there's a mother, father, and infant. And now I'm old enough that my colleagues are having babies. And we're waiting right now, we have a baby due Valentine's Day. And we all know the baby's name. My colleague, don't tell him, you know him, don't tell him. We all know the baby's name because his wife has already chosen it. She hasn't told him, and it's one of a list. So they pretend like it's still up in the air, but we all know this baby's name. But anyway, it's fun to watch, but it's also important developmentally. A family go through these stages, right? Who you are as a mother, father, and infant is way different than who you are as an adult with a spouse and as an oldest old adult with, you're not going to have a mother or child as an oldest old, but with a child who has a spouse who is then your triangle. So I just want to make here, not that everybody's family is like this, and increasingly families are very different. I'll show you that in a minute. But to understand the kinds of things that influence the individual, even at a pretty micro level, right? Because this is just that one little family with that one child. Maybe they have more, maybe they have one mother or two-member mothers, or maybe they have serial monogamy, marriages, et cetera. But this get the idea that this development doesn't happen in isolation. The other thing I want to say just briefly is the life course that you experience exists within your lifespan, but also it's historically placed. And this is a complicated, it's more complicated than worth going through, but this is even more complicated. This is one of my favorite, and I really should take it out because I know you can't see it. I can't even see it here. But the point is in these examples of historical placement, a world with or without communication, radio, TV, internet, email, SkyMail. I talk daily with people in other parts of the world. I mean, it used to be, I remember this, so I spent a lot of time in France, and one time back, God knows when, we were working on a grant, which is I've been doing for what feels like my whole life, and we were working on a grant. I literally had quarters. I had to put in a pay machine in order to talk to my co-PI about this grant. Now, I'm working on 2 grants right now, and here I am talking to you. And I will do, I'll work on it tonight, I'll work on it over email, we'll do Skype, et cetera. It's a very different world of communication. And one of the things that I always find amusing is like, when you used to go to the store and you made the decision yourself? Now, do you want pasta or rice? Should I buy this red shirt or this blue shirt? I mean, pick it out. But now everybody has to consult because we can. We can just have a phone call with our cell. Transportation, there was the horse and buggy, and then the boat and the train and the plane, and now we have rockets, and now we have crazy rich people who just want to go up and then come down. I mean, let's not go there. But it's a changing time, right? If you try to tell somebody in the 1800s that somebody was going to be able to do that, they think you were nuts. And then there's the politics. I'll just leave that there. But let's talk about historical placement in health, because it's also relevant. So we didn't used to talk about preventive health behaviors. God knows we didn't talk about social determinants of health, but now we know exercise, diet, smoking, drinking. And I grew up, you didn't say this when you introduced me, I grew up in Brooklyn. We were not rich. We were not dirt poor, but we were, I don't think we would classify as middle class, but we were never food insecure. Nobody ever talked about exercise. I mean, people didn't do exercise. I mean, you might be in a sport, but you didn't exercise to be healthy. Who does that? I mean, it was later as an adult that I used to wonder why people just go to the gym if they're not on a team. Why would you do that? And when I started working with people in Europe, they go for a walk after lunch. And I remember saying, well, where are you going? I mean, who would go for a walk just to take a walk? If I go for a walk in those days, now I'm much better, but in those days, if I went for a walk, I had to go someplace, right? Maybe to the candy store, maybe to the grocery store, who knows? But I didn't just walk to get exercise. Same thing with all of these things. Nobody I knew was on a diet. Everybody I knew smoked. There was variation on drinking. Some of the family did, some of the family didn't. Okay, historical placement. Now, if you're sitting at a table, imagine sitting at a table here if everybody was smoking. There was a time everybody could be smoking. There was a time when you could teach and smoke at the same time. I remember my husband one time when he quit smoking, or when he quit smoking before it became illegal to smoke in the classroom, but he said, how am I going to teach? It's part of my thing. Because we all did that very, very systematically. And then there's medications. In the old days, if you got sick, you died. Especially if it was a bad illness. Now we have infections, we talk about prevention and treatment, we talk about disease control, and now we have surgeries. We can do surgeries for diagnostic purposes. Could you imagine just cutting a person open to see what have they got in there? You didn't do that because people died from that kind of invasion. Now we do it to treat people, to cure people. I mean, we're just in a whole different place, and you really need to think about that because it really affects who we are, where we're going, how we get there. So those are examples of why we have to take those multi-levels. This is a slide that I love but should have taken out. It is a slide about cumulative effects, and these are studies of studies that identified how certain things influenced kids or children or adults that were not of their making. So the the one you might all know about is Elder's work on the children of the Great Depression, where he identified it wasn't just that you objectively grew up in the Depression, it was how old were you when the Depression hit. And you might know the same example of the Civil Rights Movement. How old were you when the Civil Rights Movement hit? If you were 60, it wasn't going to change your life trajectory. If you were 15, you had a whole new pathway open. So these are all examples. They're great examples, but they take another hour. And then I'd like you to think a little bit about life course epidemiology. There are several kinds of life course explanations for what influences and how your health is influenced. So the obvious one is immediate effects. Something happens and it influences your health. But there are several. There's a social trajectory, whereas you are exposed to certain kind of social advantages or disadvantages. That affects your health. There are cumulative biological models where you might have one early event and then it accumulates over time, which makes you either stronger or weaker in terms of your health projection. And there are sensitivity periods where this might only be important when you're 2. This might only be important when you're 20. And we need to recognize that we need to study those things. We need to understand those things during those critical periods. If you study a kid's ability to walk when they're 10, it's really not as useful as when you study it when they're a toddler. Now, you know, those are exaggerations, but I want to give you the idea. And then there's the whole idea of physiological effects of the trajectory. So is there a trajectory that might be social, but it translates to physiology and changes your trajectory? So there are things, all I want to say here is there are different pathways that influence your health model, your health trajectory. And they're not all the same. They just, and you need to study different things. Or you don't need to necessarily think about it as study different things, but as you try to explain your data, you need to think about these different ways, different health models that might work. Linda talked a little bit about genes before, and I really love that because it's something we need to address. Because in one of my lives, my side hustles of research, I studied people's beliefs about genetic predispositions. And the reason we did that was because it was just when we were beginning to be able to really manipulate genetic, well, it's a long another story, but we wanted to understand how people thought about genes and gene expression. And the reason that's important is because in the early days, if you said it was genetic, it's not your fault. You know, he's a criminal. It's his gene. He's a sex abuser. It's not his fault. He's a gene. Or he's an alcoholic. It's genetic. Now, you know, there are some genetic predispositions, but that doesn't let you off the hook. And I mean, you being each one of you, no, I mean you as a society, doesn't let us off the hook. And that's a message I think you've heard in a variety of different ways throughout the last 2 days. Yes, there are things that influence you, or influence an event, or influence how a person grows and develops, but it is not simple. It is not simple an explanation, it's because of this, it's because of that. It's a big combination. So this slide is just meant to show that genes and environment interact. So if you talk to genetic people, they talk gene-environment interplay. But it's the same thing for people like me who don't really go into the details of it. And the ways to think about it is, okay, you have a gene, how does it influence what's happening to you, what your behavior's like? One is it could trigger. There could be an event in the environment that triggers that gene expression. There could be a social environment that essentially compensates for the genetic, let's say a negative genetic predisposition. There could be social control. You have a genetic predisposition, but your environment is such it's not going to let this happen because the environment controls you. And then there's another situation where essentially you might have a genetic possibility, but it doesn't get expressed because there is no social enhancement. But in the opposite case, there could be a social enhancement which improves that potential. So now I'm going to give you a smattering of results. And it's once over lightly, but things that I just love, findings I really love. This one is about exercise. So I told you I did not grow up in a world of exercise, but I have studied social relations for a very long time. And this finding, which was one of the oldest findings about exercise and social interaction, what she found, Alexis Stranahan, is that people who live alone do not produce the same new neurons when they are exercising as people who live with other people do. Now, I said this in a mixed disciplinary meeting, and one guy just yelled at me, remember when Obama was giving his State of the Union, not that I'm Obama, and somebody said, liar, remember that? I was so traumatized by it. Well, this guy did that to me. He said, that's not true. So I was like, okay. But anyway, now other people have replicated it, and it is true. So, just saying. But what Stranahan finds is that social isolation delays the positive effects of running on adult neurogenesis. I mean, isn't that intriguing? Her research focuses on neurogenesis in the hippocampus, the part of the brain that produces new neurons throughout life. Remember when we thought that your neurons were dead, you were dead to new neurons by the time you were 16? So it's a good time to be old, because now we know there's a lot of change. Does anybody know what the PSID is? Linda, I bet you do. Panel Study for Income Dynamics. Panel Study for Income Dynamics. It's a long, multi-generational study that began, that's based at ISR. That's a whole nother long talk, but all and I'm not an expert on this, but all I want to show you is, see those light blue and dark blue? Those are bars that show mortality among people 45 to 64 by income. So you do not have to be a genius, and you do not have to study this carefully to say, now this is going to be news. It's good to be rich. It is bad to be poor. and here you see it in mortality rates, right? So the mortality rates go up by age as the income goes down. But a really interesting finding is, if you get to be old, you're pretty okay, right? So notice those bars are pretty even if you adjust for education and sex rates, family, a lot of the things that we think make a difference. So the cynic in me would say, that's because the vulnerable already died off, right? They're the ones who died in the 45 to 60 age group. But it is intriguing that there is much less of an age difference by income, by a mortality difference by income as you go to the over 60 group. Here's another finding I just love. These are comparing blacks in the US with blacks in Costa Rica. The first line is the median income. The median, this is old data, so it's probably higher now. But the median income was about $6,500 in Costa Rica, and the median income was about $2,700 in the US. But look at the life expectancy. In male life expectancy in Costa Rica, where they're a lot poorer, is at least 10 years, well, almost 10 years longer than in the US. So there's something there that it's about the gestalt, it's about the macro experience. It's not about income alone. I'm not saying it's better to be poor, but I'm just saying there's more things that work into it. Here's another slide, which would take a long time to go into, but the point I want to make is, again, the gene-environment interaction, because they had identified, Shanahan and Boardman had identified a gene that they said was the college attendance gene, which of course there's no such thing. But what it was, interestingly enough, and you can see how people make leaps, it was impulsivity. So kids who can't sit in a classroom, kids who can't pay attention, those are kids who are more impulsive. So they were less likely to end up in college because of the pathway. You can see what happens if you can't sit still. I was a couldn't sit still kid, so I'm very sympathetic. But so the DRD2 risk versus non-risk, and then it's across the top, and then along the side is low parental SES, high parental involvement, high quality schools, low parental SES, socioeconomic status, and low parental involvement, low quality school. The thing that I like about this is that you're better off, even if you have the gene, if you have a high quality school, good parental relations, good parental involvement, you can offset that gene. That's my bottom line. I mean, there's a lot of detail here, but that's, to me, it's so promising. Okay, so I told you before that I've spent a lot of time studying social relations, which are increasingly recognized as important link to health, an important link to well-being, an important link to cognitive functioning. What I like about saying this is why I couldn't take this slide out, is because when I first started, and Linda referred to this, they used to say it was soft stuff. Social relations wasn't real science. It's just soft. It's not real science. It's not like physics. I say physics is the easy part. Social relations are the hard part. But now, people are really beginning to recognize the link between social relations and a lot of other things that are important in life. So I'm going to go through this really quickly. What time should I stop? Okay, so this is an instantiation of this life course lifespan idea where the idea is to talk about social relations over the lifespan, and here we argue that it's the properties of the person, those lifespan characteristics, and the properties of the situation that produce or influence the social network that you need, that you have, the kind of support you get, the kind of your support satisfaction, and all of that will influence health and well-being. I argue that convoys are lifespan, they're longitudinal, they're hierarchical, they're both positive and negative, and that's another thing that it's a little tweak of this whole notion of social support. It shouldn't always be positive. I mean, there are times when negative is good, but it has to be the right kind of negative. So if you're going to jump off a cliff and there's no water down there and your mother says, great, have a good jump, not good at, or if you get the kind of feedback that is negative that says, in the sense of, you're not studying, do well, do better, start studying, you're not living up to your potential, that's maybe negative, but it's positive. It has a positive effect, right? And you don't want somebody saying, it's okay, just be dumb, flunk everything. That's not good support. It might be positive, but it's not good support. Anyway, so convoys are often multi-generational because we tend to live in families. They have ethnic, religious, cultural characteristics, and they have antecedents and consequences. They don't just happen from nowhere. People have multiple close relationships. They're hierarchical. Some are closer, some are less close. They're influenced by the individual and the situation, and they're dynamic. This is just an example of the same exact thing, only longitudinally, and arguing how social relations help you deal with stress. And this is another wave of, these were, as our studies got more involved, we have to have more intricate pictures. But one of the things we did at one point was look at the nature of the social relations and who and when it has a positive effect and when it doesn't. This is a quick slide on kind of the history of social relations and health, coming from the early infant failure to thrive literature, attachment and mother-child attachment and school competence and peer relations, mortality studies among adults, depression, experience of pain after surgery, adherence to medical regimen, even cardiovascular disease, cancer, and stroke. All of these are have been shown to be influenced by social relations. Now, I'm not saying it's everything. I'm just saying it accounts for some variables, some variance. We should pay attention. This is a study that I did in France, and the thing I like about this study is it showed that while quantity and quality of social relations are both important, quality is more important. So sometimes, not being a person to talk sports all the time, but I do talk about depth of the bench. So you're better off if you have more people in your network than just one. But if you're going to have all negative, you'd be better off with one positive than all negative. This is an intriguing finding. We showed that if you have stress, if you have high stress, you get support from both high and low quality relations. But if you have lower quality relationships, you only get support during the extreme part of this stress experience. It doesn't carry over. So it's like the people who are really close to you stick with you through thick and thin, long and short, if you will. This is another finding I really love because there's a standing finding, it's one in the social determinants of health literature, which showed that low SES, there's a link between low SES and health. That is, if you're poor socioeconomic status, your health stinks. That's a technical term. And I showed you that with the PSID data. But we showed that among middle-aged men, who I must tell you are the hardest people to study, among middle-aged men, those who report close social relations, especially with a child, that erases the relationship between SES and health. They are as healthy as rich people. This is a longer version of this. This is a longer version of this. I just want you to go away with the understanding that even among less educated people, which was our measure of SES, if they had larger social network, more close relationships, better financial support from a child, children they feel they confide in, children they feel they can get sick care, they were as healthy as high SES people. So what do we know? We know that sociodemographics influence social relations. There are age, gender, race, and SES differences. We know that quantity and quality are important differences in social relations. We know that there's an interesting difference between perceived and actual support, and positive and negative support, and support from family versus friends. I keep going to say I'm going to skip the next one, and then I see the next one. I can't skip this. This is a nice slide because it talks about genes and health and culture. So in Japan, the #1 cause of death is stroke among Japanese. But among Japanese in the US, the #1 cause of death is cardiovascular disease. Among African Americans in the US, there is a high rate of hypertension. We all know that. But hypertension is rare in Africa. Menopause in American women is associated with many more symptoms than among women almost anywhere else in the world, especially that we have good data for Japan. So the point here is that culture makes a difference to health. There's a longstanding finding about the healthy immigrants, right? People who come, I actually think this is changing, but cultural health differences among immigrants to the US are significantly reduced, if not erased, by the third generation. So not this wave of immigrants, but previously, immigrants who came to the US were very healthy. But and that compared to native born. But by the time they're third generation, they're just as sick as the Americans, native born. Okay, this is more of the same. I hope you got this by now. So what do we want to do in terms of future directions? I would say, it's sort of like, you know the quote from the Bible, render unto Caesar the things that are Caesar. That's how I feel about social relations. Social relations are important. It's what I study. I really think it's fundamental, but I don't think it's all there is. However, I would argue in terms of future generations, we want to maximize the positive impact of social relations, minimize the negative impact of social relations, and understand these processes so that we can develop strategies for achieving them. So if you talk about kids, you want to talk about the ways in which you can maximize the positive aspects of their social relations. If we talk about a team, if you talk about football players, you want to maximize the positive and minimize the negative, and you know there's a lot of both, and we got to figure out how to maximize. And some people clearly have done it, and they do it by the way they select who they have relations with. Okay, implications and applications. So understand the interaction among the many levels, including gene, biology, individual, family, culture, and environment. So I recently watched the new West Side Story, and I love that song. They use the same songs. So there's this song, do you remember the song, Dear kindly Sergeant Kumke, you gotta understand, it's just by bringing up key that gets me out of hand. I'm obviously not a singer, good thing you don't have to listen to that. But anyway, it's a whole sociological study about why these kids are all messed up. They only talk about their environment. I'll argue that you got to talk about all of these things, and all of them contribute, which means we can't get off easy. We can't say, oh, they come from this, or they come from that, or they have this problem, or they have it. So we're done. It's a gene. Oh, nothing I can do. Oh, they come from this neighborhood. Nothing I can do. It's clearly not. It's clearly an interaction of a lot of things. So we need to understand how social factors contribute to health and well-being, And we need to develop appropriate programs to optimize social relations and positively influence health and well-being. So, conclusions, benefits of thinking about convoys of resilience, because that's another way to think about social relations. How can they help you be resilient within a lifespan and life course perspective? We need to understand the complexity of social relations. It's not all simple. It's not a one-size-fits-all. We need to understand how we can maximize resilience and taken together uncover important understanding of aging processes and outcomes. And so, some closing thoughts. What does lifespan and life course got to do with it? I'd argue a lot, and hopefully I've convinced you. We can't delude ourselves into believing context doesn't matter. It clearly matters. We need to have faith that people are resilient, so there is potential. We all don't have to do everything. So you don't have to be a geneticist and a biologist and a sociologist and a psychologist. You just need to understand what each contributes. And then I like to say human science is the toughest science of all. The problems are complex, the causes are complex, and the solutions are complex. And then this is my very last slide, which is to think about it in terms of Black male brain health. We need to be mindful of the lifespan and life course perspectives as they relate to Black male life lived experiences. We are in a time where it's both an exciting and challenging time to study the interrelationships of lived experiences of the brain and overall health of Black men, and the challenge is to apply our knowledge to enhancing our understanding of health, especially Black male brain health. And what I love is that we are paying attention to this very important topic. Thank you.
Linda, take the stage. Both of you take the stage.
Ask Linda all the hard questions.
All right. Well, first of all, I would just say, can we give them both a hand, please? Got about 15 minutes, and I want to cherish all of these 15 minutes because there's so many. I know just so sitting over there with so many questions, but we're going to just make sure that we open them up. But you know, we do have an emerging scholars program that you both know very well. We've talked about this a great deal, and much of this whole conference is about preparing people who want to do this kind of work to be able to be out there in the community. I'm fortunate because you both serve as my mentor, and you have for years. So I just would like each one of you to take a few minutes. Could you share what is your philosophy on mentoring, particularly the next generation of scholars?
That's a hard one. Well, probably, Robert, if you had asked me that question before COVID, my answer would have been slightly different. I definitely think where we are right. I definitely think where we are right now in the context of having experienced the double pandemics of COVID and racial reckoning, that the way we mentor may be slightly different. I think that among the students, postdocs, and faculty that we mentor, we're going to have to be more mindful of what the landscape looks like for them going forward. And that, by that I mean, it's going to be dominated by uncertainty. A lot less certainty about what pathways you should follow in being successful in your career. I don't think a pathway that takes the ordinary route will be as effective, because the kinds of social issues, the kinds of research questions we will be addressing moving forward, people are not going to get off easy by taking a variable, for example, on race, a dichotomous variable, and sticking it in an equation or asking a question like that. We need answers to questions that are relevant for the now and the future, and that are much more, I think, interdisciplinary in many respects, which may be a challenge for those who are more just disciplinary minded in terms of their career trajectories, and who choose to go to institutions that reward the disciplinary perspective, rather than also adding to that profile, giving our students credit for taking a more collaborative, interdisciplinary approach. I think in addition to that, we are going to have to counsel our mentees for those going through the academic trajectory, and not only academic trajectory, I think in jobs in the private sector, that they are going to have to get really smart and up to speed on research partnerships. Communities are not going to put up with the crap anymore about researchers walking into their environments and saying, we're going to, this is what you need to know, this is what you need to do. The ones that we develop now, the students that we develop now are going to have much better social and cultural intelligence than that. So those are just a few of the things I think.
Thank you so very much. And Toni, go ahead, give it to her. How do you approach that question, Toni?
So I mostly deal with students who are heading for an academic career, but not completely, not only. And in fact, there's been a change over the years where if you didn't, in the olden days, if you didn't go into academia, you were like, that you were a failure. And I always argued that there's a lot of psychology people need out there. Why aren't we? And this is not clinical work. This is just helping people understand psychological influences. So things have changed. I would say, a couple of bullets. Get feedback from people you don't like and who don't like your work. I don't mean exactly don't like, but don't go for the feedback from, the people going to say, that kind of pat you on the back and say, great job. That's not helpful. You need somebody who will give you criticism, but don't expose yourself to destructive criticism. And what I used to do is get somebody who will give me the kind pat on the back, say a few nice things to help me through, and then go to somebody who would slam everything I was doing. Because I didn't agree with all of that stuff, but it's good to hear a little bit of what the other side is saying, if you will. The other thing I would say is it's a marathon, not a sprint, your whole career. No matter what you're going to do, if you're in this room, your career is a marathon, not a sprint. Stick by what you really want to study, but be flexible too. So I always wanted to be a lifespan developmental psychologist, and actually nobody was studying lifespan developmental psychology. Now you can't find a department that doesn't say they're not lifespan. So, it's not that I converted them, Lord knows, but I didn't give it up. But I did work within the boundaries of what I could be successful in. Not because I could be successful, but what their criteria for success. So I can't help people who say, well, I hold higher goals and I'm not gonna play by those rules. Well, I can't help you because that's the rules we're in. That's the game we're in. If you don't want to play by those rules, that's fine, but you're not going to make it in this game. But I like to do a little bit of both. So do what you think I have to do and then do what I want to do. Sometimes it takes a long time to do that. Now, having confessed to you that I'm no longer a young person, now I get away with a lot. Because what are they going to do? Fire me? It's going to ruin my career? I don't think so. But get there first, because the good thing about being there is that you can then be much more supportive to the next round, right? The next generation. And that's very satisfying.
Well, thank you so very much. Yes. Kelvin, I know there's questions out there.
Hello again.
Stand up.
Hey.
Tell us who you are.
Oh, yeah, sure. My name's Daniel Okobi. I'm a behavioral neurologist.
Speak up.
Sorry, I'm a behavioral neurologist at UCLA. I also do research on mice with dementia. So I see patients with dementia. And I think one question that I have that maybe brings the two of you together is when you were talking about the framework for the ought, I don't think you really explained it that well, but when I was thinking about it, I was like, that sounds like a lot of societal expectations, and societal expectations might be things that you see with the life cycle and the social support. So is that kind of, am I on the right kind of mindset or the right track? And is that something that Toni can also talk to?
Yes. Actually, just, to address your question specifically, I really went over theoretical perspectives very fast. I didn't, I gave you very baseline distinctions on what it meant to be, to look at those kinds of discrepancies. Actually, the whole model I presented comes primarily from a social psychology background. So that's where the discrepancy perspective comes from. In terms of the relational side of things, where interaction is the unit of analysis and what happens in that unit of analysis. That's where the terms like, othering, boundary expectations and so on, it's all in the wheelhouse of social psychology. And social psychology, I would have to say in everything I do too, because I do intergenerational work, and because by the nature of the way I even collect data, it's always longitudinal and it's always life course oriented. I was trained under the same kinds of perspectives that Toni talked about today, like work with Glenn Elder and the like. So the conceptual perspective is really a mix of life course, little lifespan, a lot of social psychology, a lot of symbolic interactionism, where the bottom line is the relationship, if this makes sense, as a unit of analysis. And I thought, if I go down that road, this is going to take me a whole semester to explain to everyone. So I decided not to, but thank you for asking the question. And if you give me your card with an address, I'll email you all the theoretical articles if you're interested in reading more about it on some of the territory that I covered.
I don't think I can add to it. I mean, I worked within the convoy model of social relations, and the big point we've made over the years is that you need to take into account the kind of individual characteristics of the person and the social characteristics of the situation, and they are going to influence what kind of social relations you need, what works best for you, what you're likely to get, and how satisfied you are with it. And it's really fundamentally a psychological thing, because you could have the same exact, say, quantity of social relations, but this person says, it's great, I have all I need, and this person says, I have nothing. There was a great Woody Allen, I'm not a big fan of Woody Allen, even though he's a New Yorker, but there was a great one, some movie, I don't remember which it was, where they have Woody Allen is talking to a male friend, and his girlfriend or wife is talking to a female friend, and he says, we never have sex 3 times a week, it's hardly ever. And she says, we have sex all the time, 3 times a week, it's killing me. So it's the same idea. Well, it's not exactly the same idea, but you get what I mean. It's the individual interpretation of exactly the same behaviors. Well, maybe the same behaviors. Leave that one out. I haven't used that example in a long time. I hope I haven't offended anyone.
Dr. Burton, because we have a PhD program, we're always thinking about the success of our students and their ability to accept a teaching position. You were recently listed as a faculty member in the top 2% of your scholarship, which means that you produced a lot of publications. I know I'm not explaining that to others, but because of the emerging scholars. your citation count is highly regarded across multiple disciplines. But when you described what you think is going to be the trajectory for these existing scholars, and how COVID is going to change some of what they might expect, and also that if they're going to present themselves for studies, that they're going to have to do maybe more qualitative than quantitative. How is that, in your opinion, going to change some of the ways they might find themselves being able to satisfy some of the ladder track requirements, and perhaps that might be extended in ways that you didn't have to experience because you were able to focus on publications?
Well, Assistant Dean of Development and External Relations, Veronica Alexander at UC Berkeley. That is definite. That's an excellent question, because what you're getting at is something that has been raised a lot in this context, and really it's the issue of how context matters, and more importantly, how systemic factors in the institutions that we move through the academy in, how they are either going to change or not going to change through this process. Now, we have seen, for example, at UC Berkeley already that there is some internal change in the promotion and review process, where research practice partnerships now are going to count toward people's evaluation toward tenure and promotion in ways they have never been counted before. And they won't be counted in only the context of service, but how it's played out in the research realm. So, I'm sure we're going to have lots of variability in how different universities respond to these issues, but I highly expect that in the long run, universities are going to have to move, they're going to have to move in directions where they think about science in ways and assign even more valuable to collaborative research than they have in the past for probably as long as Toni and I have been at this. Many of the things that you all talked about here about collaborative research, interdisciplinary science, multiple ways of thinking. This is how you're going to do research practice partnerships. We've been hearing that for 40 years, and the needle hasn't budged a whole lot. I think the world is going to demand that the needle gets budged. So it's going to be a matter of timing, like when people go into the academy and when they enter a particular track. But my sense is that no university is going to want to be left behind in terms of being relevant at this point in historical time, because it's too important.
I agree. I would add a couple of things. One is that, in a way, the bad times have really led to some good times in terms of our science. Starting with the bad first, I'm horrified by the ease with which a distrust of science has been communicated and adapted by so many people. I mean, I grew up, scientists were the good guys, right? What they said it was going to be true. I mean, not necessarily a true. If they said it was a fact, it was a fact. If they said it was a theory, it's a theory. But it wasn't that they were the bad guys. Now we're the bad guys. I mean, something's gone wrong, terribly, terribly wrong. So that, and I'm now thinking about I'm talking to emerging scholars about a different way of looking at their career, where like you could assume that you were the good guys. Now you can't assume you're the good guys, and you got to convince everybody you're the good guys. Now, there's a longer version of that, but you get what I mean. The other thing that's good coming of bad is now everybody's talking about social isolation and loneliness, and how the pandemic has really had a very negative effect on people, and we have to be mindful of social relations. I mean, yay, everybody's talking about social relations. What did they used to say? That's not real science. That's just soft stuff. it's almost like that's girly stuff, you know, hugs and kisses. But now everybody thinks it's important. You know, that's really a big breakthrough, and I'm very pleased about that. But, you know, it's an uphill battle. So and I firmly believe in multidisciplinarity. I have been, my career, I'm a psychologist, my teaching career is in psychology. My teaching appointment is in psychology, but my research is at the Institute for Social Research, which is a multidisciplinary unit. And I have always had a multidisciplinary team in the life course development program. And I feel like we learn from each other. But also, I think the academy has changed in that they aren't such purists. Like if you're not an academic, you're not a successful PhD or whatever. Now I think more and more people are recognizing we need everybody. I mean, I guess all those people with PhDs were at the ivory tower. They weren't talking to anybody and tell them what they were doing is important. We need the people on the ground who are dealing, I mean, it sounds crazy, even as I'm saying it, but we need people who are doing applied work who can make the point that what we have to contribute is important and will help them. I think we're moving there at a snail's pace.
Yeah. Okay. Unfortunately, I can't pass the mic. I've been told that we're out, but I'm going to share 2 quick stories just because I got the mic. Real quickly, just, you know, doing great science, really good science is really, really important. And being trained by people, you know, to be competent is really important. But I've had the real pleasure of having been mentored and continue to be mentored by people who really have proven that they care about me. And so when I think about the mentors and the scholars program that we have, I want you to know that, you know, they've really imparted a whole bunch to all of us, people like this, and that's what we're here for. And so 2 quick stories. When I was at my postdoc at UNC, I was shortlisted for a job at Columbia and all, but thought I had the job and everything. At the very last moment, they pulled the rug up underneath me, and it hurt. It hurt to the core. And Dr. Burton allowed me to call and talk, and I was about ready to be tears, and she just stood through that whole process and held my hand through it and let me know that I'm still valuable and I still do great science, and that it was their loss, and that you just keep on plugging on it and it's going to happen for you. And so this was 10 years ago, and here I am, right, because she invested in me. And yeah, exactly, I'm trying. And Dr. Antonucci, she's been in my life for quite a while, and she's known that my family has had some real challenges, both my mom's health and my dad's health. And, you know, she's, you know, picked up the phone and called me and helped me work through some things. And one of the times, just very recently, she said, you know, Robert, it's very difficult because you're in the middle of a crisis and you don't even recognize it's a crisis. So here's how to think about it and move yourself through that. And so I'm just greatly appreciative because they've invested in me as a scholar, but as part of that, they said, hey, you need to be healthy, and we are here for you. And so I just thank you very much for that, for showing the example, allowing me to be able to share that and let the other scholars know that these are the types of things that we are here for you for as well. Thank you. Okay, oh, so we have a 15-minute break now, right? And so I think, as you can see, we have some beautiful weather outside that I'm not responsible for, but we do have some treats for you to enjoy. Oh yes, Iris is responsible, the School of Social Work here at USC. For the beautiful weather. Thank you so much. Thank you both so much. Oh yeah, I guess we have a break, and then I guess we do our panel discussion on why research participation is important. Yeah, why is it important to participate in research? All right. Good. make sure after we finish this last thing, we never took a picture with the scholars. We need to get the faculty and the scholars. Yeah, after we finish the last one, right before the social meeting. We can tell them. Yeah, take a picture. Is he here?
very serious condition. I suffered from it for many years and experienced some of the common symptoms, including things like snoring, fatigue, irritability, and weight gain. Sleep apnea is
Are you aware that
Hello? Okay, here we go. Hello, folks. We're just about ready to get started. Our last panel is going to get started, but before we do, my good friends at Global Sport Institute in Arizona have created this video regarding sleep apnea for black men, so we just want to share this with you, and then after that, we'll get started with the panel. Please, gentlemen.
Are you aware that 90% of sleep apnea sufferers go undiagnosed? And you know what? It disproportionately affects us, black men.
Sleep apnea is a very serious condition. I suffered from it for many years and experienced some of the common symptoms, including things like snoring, fatigue, irritability, and weight gain.
For more than a decade, I've had sleep apnea. I remember being asleep on the couch and waking up choking because the saliva had coagulated in the bottom of my throat because I had stopped breathing, and then I started to breathe again and started to choke. It can make you moody, and it can also result in high blood pressure.
Sleep apnea is very dangerous and very serious, so I'm encouraging everyone to get tested. If you have sleep apnea, you're 6 times more likely to die in a car crash due to the sleepiness. Both me and my mom got tested, and we both found out that we actually are sufferers from sleep apnea, and right now we're able to get the treatment that we need.
Visiting a sleep doctor or different types of sleep therapists considerably changed my life. I now can go to sleep and rest in my bed with the full knowledge that I have the support both through cognitive behavioral therapy as well as through the CPAP machine. I think in the culture today, typically individuals think of like not sleeping as a sign or a badge of honor, when in reality, it's something that can lead to a number of health problems in life.
Listen, as much as you may not like it, I want you to understand, if you're having headaches, you're having a hard time sleeping, you're moody, you stop breathing in your sleep, you have high blood pressure, these are checklist concerns, so I need you to get with it. As much as you may not like to go to the doctors, it's important that you do, and you do it ASAP.
And it's easy to get help. What I did is I went into a sleep center and I got a sleep test. They determined how many times a night that I stopped breathing, and they made recommendations.
I use CPAP to treat my sleep apnea, and it's a total game changer. There are no side effects, and I feel 10 years younger. If you have symptoms of sleep apnea, I encourage you to speak with your doctor and consider using a CPAP. You have nothing to lose and everything to gain, including better sleep, more energy, and a healthier and longer life. You owe it to yourself and to your family.
It can save your life, it can improve the quality of your life, and you'll be around to hug your grandkids or your kids or your nieces and nephews because they love you. And I think it's important for each of us to pay attention to this challenge.
Go to the doctors, because in order for you to live your best life, it's important from here on out that you get checked out.
So that video was, as you can see, was made in a PSA format, and it was a result of several focus groups. I think we did about 4 or 5 focus groups because we wanted to understand Black men's health literacy around sleep apnea. And we wanted to develop messaging that would impact the community to affect them to make some kind of change, reach out, get more information, and maybe hopefully ultimately, if they had these symptoms, go and get a sleep test. So we're just launching it publicly for the first time for you, because we wanted you to see the type of work that we're doing around men's brain health and all these other issues that affect their lives altogether. So thank you on behalf of the Global Sport Institute and on behalf of us at the conference. Thank you for just taking a few minutes to watch that. Okay? And now I would ask the panelists to come up to the stage. Okay. Well, it's yourself. You're one. It's who's on the panel? Oh, okay. Well, then we got another one after that. Okay, well, then let me ask you to come on. Yes, Dr. Aranda, Dr. Burton, and Dr. Williams. Okay, great. And who's going to be the moderator? It's you. I'm moderating? Okay. All right. Can we have the screen up, please? I thought you were on it. Right, exactly. I thought you were on it as well. Okay. Where's Dr. Williams? Is he here? He stepped away? Okay. Okay. Can we check and make sure your microphones are on too? Dr. Aranda.
Testing.
Okay.
Testing.
Testing. All right, well, thank you. So in this session, we're going to discuss why it's important, or why we believe it's important to participate in research. And both of you have done a great deal of community-based participatory research. And you've worked with different communities of color, and so you've seen some of the some of the challenges involved with it, some of the successes and those type of things. As a matter of fact, another quick story, Dr. Burton, when I told her about my work way back when, she said, you know, you want to do community-based participatory research. And I was like, I do? Because I'd never heard of it before. But she was obviously very right about that. So I'm going to start off by just saying, or just asking, can you, both of you, can you share a little bit about your history and kind of your evolution and how your research has evolved over time to do community-based participatory research and your approaches to it or your philosophies behind it?
All righty.
That's how we exchange.
Okay, let me see. Well, this message, I think, will be important, particularly for the emerging scholars, because really it is about developing a program of research and being able to execute it in a way in ways that will allow you to build upon each subsequent study that you do, while at the same time advancing your career and putting yourself in a position to actually be able to do the kind of participatory research that is often very expensive, to be in a place where you can compete for grants to be able to support your research. So when you ask me about how did I get to that point, well, I would have to say that in my program of research, and I pointed out to all of you all that I'm an ethnographer, so primarily, even though I was also trained in demography here at USC, this is where I got my PhD. But in the kind of work that I do, I started my career in involving very particular, smaller sample sizes, usually somewhere between 50, 60 families, multi-generation families, which oftentimes resulted in more than 125 people that you would interview. But I started off small, asking fundamental basic questions that I was interested in, and in each subsequent study that I did, I made sure that I built upon the previous study, in the next study expanding the question more deeply and adding larger sample sizes and so on and so forth. So the first grant I got to do my research was when I was in graduate school. And I got a whopping $5,000, which I thought was like gold at that time, to be able to do a study of 40 multi-generation families in South Central Los Angeles. Now, what I want to say about that is that I started off small at $5,000 and really looking at a particular subsample. But the most important thing was, in order for me to go to the next stage where I had the credibility and accountability to deliver on something that was more complicated, with that $5,000, I, had to make sure that I completed the study, but not only completed the study, that I published from the study in peer-reviewed journals, that I presented findings from the study at learned societies like the American Sociological Association, and that I always had a requirement in each bit of work that I did, a personal requirement, that I also went back to the communities I worked in and reported the findings that I had. So what I'm saying to you as emerging scholars, that as you build toward doing community participatory kinds of research, make sure that those early studies that you're involved in are doable, that you're not proposing that you're going to do a study that actually costs $50 million when the grant is only worth, the grant amount they're giving is only $50,000, and that you make sure that you complete the study, that you publish work from that study, and you present it at national conferences. So I would say within a 2 to 3 year period of when I started getting grants and being able to do these kinds of studies, I went from $5,000 to $10,000 the next grant, $25,000 the next grant, then a whopping $300,000 the next grant, and on and on and on. And at each stage in my career, I made sure I did the exact same thing. I did the study, I published the study, I presented the study, I shared the findings from the study with the population that I worked in, and that this is the key factor, that in subsequent studies, I didn't just change one variable in the research question, but I got more deeply into the issues, and also went on to do more comparative studies, which ended in me like moving into the higher capacity to apply for much larger grants. So by the time that I really got into the community participation part, which can be extremely expensive, and you also have to make sure that you have the infrastructure to support it. Because if you are at a school where there's not the infrastructure to support that particular activity, you can be dead in the water and getting a grant like that. So just quickly, I moved from doing studies primarily myself to having teams of 4 or 5. And when I moved into the community participation part, I had a team of 215 people that are on my team across 3 different cities involved in community participatory research, and the work itself was much more interdisciplinary, and the grants went from, $300,000 to $1 million, then to $50 million. So my point is, you have to be smart, you have to be sequential, and you have to know when you're ready and you have the capacity to do that kind of research, because it involves two sides of your brain in some respects. You got to do the science part, but you also got to be really tight on relationships. You have to have that savviness. You have to have that maturity to make those kinds of things work, and it takes a little time to do that. And you don't want to jump into those kinds of projects as a principal investigator until you know you have the capacity to do it.
$50 million, wow. Dr. Aranda.
Dr. Robert Turner, can I take a little bit of a license to answer the question?
Please. This is your home institution, so. Yeah.
Thank you, I appreciate that. I've done a lot of different types of research, qualitative research, survey research, and intervention research as well. And that's really the type of research that I like to do, is intervention research. So when I did survey, in a bit I'll talk about that. When I did survey research, that was easy for me because it typically was one-off, maybe 2, maybe another follow-up after the baseline survey. That was pretty easy because you didn't have to change anything, right? Except, meeting with the person afterwards, debriefing, et cetera. But intervention research is different, right? First of all, the IRB application is longer. The informed consent is longer and more complex. But also, you can't promise anything. So what's the benefit of research? I'm very, very careful. I use a lot of caution because I don't promise very much. You really can't. Because I do depression research as well and caregiver research. And when you're saying that you're going to test an intervention, it's because you don't know if the intervention is going to work. So you're not saying that the intervention is showing efficacy or a benefit, that's why you're doing the research. You don't know if it's going to have a benefit. So really, the benefit of participating in the type of research, intervention research that I do, is really just a sense of altruism and helping, and legacy, as you used that word previously. Really the legacy and altruism of being part of something big, and maybe that'll change the course of a community dealing with a particular condition or disease or the state of caregiving. So I'm very careful about that. Getting back to the IRB, the Institutional Review Board, you got to have grit. You have to have a lot of grit. And I know the IRB is there for a reason, because of international laws, laws in the US regarding how to protect the rights and well-being of human subjects. That's extremely important, and we can't underestimate that. But you know, when you start looking at an informed consent for an intervention study, it's a long testament, right? It has pages and pages long, and people really don't have that much time to read it. And many times you are there and asking, you know, and you engage in a discussion about the research and the informed consent form, and you want them to read it, and you want them to take it home and speak with family members or close others about what they think about it as well. So those are all precautions and safeguards that you have to abide to, and you want to. But at the same time, for example, I work a lot with Spanish language individuals and family members. When you start translating the content from English into Spanish, you've actually done something real interesting. You've actually increased the literacy rate. And that's something you don't want to do, because you want people to understand and not use the big, you know, $10,000 words in the consent form. So even when you work with Spanish language populations, you see that the literacy rate starts going up when you do the translations. And you have to be real careful about that. The other thing is that when you engage in the consent process for intervention research, people have to know that, you know, there's an expectation that they're going to be in the research a certain amount of time, you know, the duration of time. You have to let them know that, you know, what they can expect will happen, you know, all the activities and research procedures that you're asking them to take part of. But you also tell them that this is voluntary. You don't have to participate in this research. You don't have to answer all the questions. You could say no to some of the questions and say no to some of the activities. And so that's a process of engagement, just talking about the informed consent. And then there's the issue of remuneration. I've been asked, and when I give these talks, is how much do you give people? And you have to think that through, right? What is it? You know, when you only have a $15,000 grant, like some of our graduate students, even that is an issue, right? But you want to compensate people for their time, for their, you know, what they share with you, that sanctity of the knowledge that they have and that you want. So those are issues that you have to grapple with as a scholar, as a scientist. And I can tell you, you know, engaging in that informed consent form is really a process that enlightens people. And it should enlighten you to at least give feedback to the IRB when you see that things aren't working, where some of the laws and regulations don't apply to your group, your community, or the people that you're targeting, or that some phrases are maybe off-putting or insensitive. So really that's a discussion that you have to have not only with the people that are considered, quote, human subjects in your research, but also the IRB, where they may see things or be blind to some of the things that may be off-putting in the process.
Thank you. And I'm going to channel my best Roland Thorpe over here, and who says that gerontology is sexy, right? So is cognitive aging and research and stuff like that, brain aging or brain imaging and injury and all this other work that we're doing is sexy. But any do-overs in your career? Either one of you, both of you, anything that you say, yeah, I'd love to do that one over.
I would have to say, not a one.
Ooh, I love it.
Not one.
I love it. How about yourself, Dr. Aranda?
I'm racking my brain right now to think about a do-over. Maybe be a little bit more bold and ask for more money for a project, right? Now that I know. That's probably, yeah, asking for more money. And, I always say that there's a kind of a tax when you work with populations that are kind of looking at you and trying to make sense of who you are and the type of work you do in the research. And it takes a little bit longer, right? And I can say that there's a little bit of a tax that, the type of researchers that we are, the type of work that we do. And we have to be able to translate that into dollars because we want to do good science. And we're probably the best people to do this science, but at the same time, the funders need to, I'll say it, need to pony up and provide more resources so that the good science is done well.
Thank you for that. Real quick, if we had 100, 200 black men in the audience here, we're talking about the benefits of being part of research. What would you tell the black men in the audience? What are the benefits of being in the research? What would you say to them?
Well, when I go out into the community, I'm going to talk about working with our Latino brothers. They get a kick out of being associated with USC. So I'm taking the football that I won in the raffle today with me, because remember, I'm not an athlete. But honestly, the Latino brothers that I work with, they get a kick out of the fact that I represent USC. I didn't know that at the beginning, to tell you the truth, but it was made known to me, and then I said, "Wow." But that comes with some responsibility, right? And we have to acknowledge that. But they also wanted to be part of something bigger, and they also wanted to help me because they said, "Hey, you made it. So, I'm doing this because I want to help you." So, that's something that I'll always take with me, something that I hold very dear. Because that, to say that is a little bit of vulnerability, but they felt comfortable enough to tell me that. And that's something that I really cherish.
Thank you, that's a great answer. How about yourself, Dr. Burton?
I would have to say that to my African American brothers that you know more than you think you know, that you are wise. And the time that I have spent with the brothers that are not in the room, and that have been involved in my research, I walk away from that research 100% smarter than how I entered. And I'll give you just an example of that. That in many of the early intergenerational studies that I did, because I was open to being a whole lot more flexible in like what times of the day that I would go and meet with the young men that were involved in the study. And I'm saying that because some of them were involved in things like, not all, but some were involved in underground economies, I'll say that. Okay. So, it would make my children extremely nervous, but I didn't have any trepidation in going out and hanging out with them at 1 o'clock in the morning, 2 o'clock in the morning. That's when you learn what you're missing. And while some of these same gentlemen were involved in underground economies, they were hell of excellent caregivers to their grandmothers and their grandfathers who they were doing night duty with and taking care of them. And if I would not have had the opportunity to see that, I wouldn't have been able to know as well as I do now the capacity for Black men to lead, to give, to make a difference in ways that they never say. You just have to watch.
That's an awesome answer. Thank you. Thank you. We have a question here. What would you tell your younger self? Your younger self as a scholar. What would you tell your younger self, Dr. Burton?
Gosh, what would I tell my younger self? Well, this is something that you might not expect, but one of the things I would have said to my younger self was to make sure, and this is important because I think young scholars should know this in particular, is to make sure you balance your life between your families if you're choosing to have them and your work. Especially if you're going to do the hard, the tough work, the work that you leave the field from. And I'm just saying this as an explicit example. I'm thinking about some time that I spent in Chicago. And on this one particular day, I interviewed a family that just got me to the core. And I went home and I laid in the bed for 3 days. And you just want to make sure, and I wasn't anticipating that in my younger years because I just had all this vibrancy and energy. I got this. I'm from Compton, you know. I'm not a slacker. Hey, you know, what's up? Seriously, you know. And when you start out that way, sometimes you don't take care of that emotional side of what's going to happen with you in the kind of work that I did, the ethnographic work that you need to keep track of. And in keeping track of that, you have to also make sure that home is as healthy as everything is in the field. So I think that's what I would have told my younger self.
Thank you so much for that honesty. Really appreciate that. How about yourself, Dr. Aranda?
I really have to think about this one. Maybe the only thing I could think of is maybe earlier in my life, understanding that when people say things to you, like what you were saying earlier about interactions and how people do and say things that other you, that put you kind of out. Maybe if I had understood that earlier, right? Because when people tell you you're a fool in different ways, and sometimes in a nice way, smiling, and you figure, am I a fool? Am I a fool for getting into this type of work? And you second guess yourself because, you know, I know a lot of my friends who graduated around the same time I do, you know, they went into corporate America, making a whole lot of money, much more than I am. And I thought to myself, you know, did I think too much about what people were going to think about me? And I remember my mother, and one time I said, Mom, this thing in academia is, you know, this is hard. This is hard work. And I told her, this was before I became tenured, and I said, you know, this is really hard. You know, I'm thinking about leaving, and I think about that every day, right? And she says, she looks at me, and she said it in Spanish, but I'll say it in English. She said, Mija, you don't leave there until they pull you out from your hair, right? Meaning, no, you don't leave. And I had a student from, I think it was the School of Education here at USC, do an interview, a qualitative interview, right? And, you know, what do you think made it? And, you know, your social network theory and all that. And she kept on trying to drive me, and it's because of whom you knew in academia, right? You know, the people with the funded research and all that. And I kept on telling her, no, it was my mom, it was my aunt. You know, what they told me, that was supreme. That's what got me through. I'm not poo-pooing everybody else and their ability to connect me, you know, with other people, but honestly, it was that belief in me and the belief that, hey, you could do it just as well as anybody else. And my sister, she says things a little bit more frank. You know, she says, hey, they don't pay your bills, so go forward, go forward. And I think if I would have learned that just a tad earlier in my life, maybe some things would be a little bit smoother, maybe.
Thank you. You know, we all have issues that we face in our career. I remember, you know, again, when I started, I didn't start graduate school until it was like my third career. I had been in football for a while, and then I wound up going into advertising and technology. And then at about 40 years old, I decided, okay, I'm going to go back and I'm going to pursue a PhD. It was a good thing ignorance is bliss, because I had no idea what I was doing, but then it pushed me through. But, you know, there's these issues around imposter syndrome. It's too hard. There's no money. Where am I going to live? All these different things, right? But somehow or another, we persevere. But what have been some of the greatest, one of the greatest barriers for you as you know, we shared earlier, Dr. Aranda, that, you know, it took you a while to go from associate professor to full professor. Could you share with us what are any of the barriers that, you know, you have really had to stare and overcome?
Okay, that's easy. One of the big barriers is the issue of service. You know, academics are supposed to do scholarship, teaching, service to the profession, service to the school, service to the university. And maybe because I'm a social worker, number one, you know, I believe in service. I think it's important. But number two is you get asked to do a lot of service work, right? Especially if you're the only A, the only B, the only C in the school, is you get asked to do a lot of service, and I did. So was that good? Was that bad? Well, it depends on how you look at it. You know, I'm a more rounded person because I've done the service, but it's also another tax, right? When you're doing service, you could be writing a publication, right? You could be doing another, you know, writing another grant, etc. But I've always been service-minded, so this was something that was very close to my soul. And I think at the end, it made me a better person overall. Took me a little bit longer, but it's something that I wouldn't give up at all.
Wonderful, thank you. How about yourself, Dr. Burton?
Well, you know, that's an interesting question because I would have to say because of personal circumstances, my trajectory was a little bit different than most people in my cohort and, you know, that I moved through the academy with. As some of you here may know, I got married when I was 18 years old. And so by the time I'm finishing my PhD at 27, I have 4 kids. And I know that I'm about to be a single mother pretty soon. So when you're in that context and you know you're going to take a position in the academy, you got to get real creative about how you're going to work it out. And for me, thinking about moving forward in terms of barriers and, you know, sitting with them, just sitting with those barriers, I want to be honest with you, I didn't have time to worry about that. Because I had babies to take care of. So when you walk into these positions in that way, you move through them very differently, and things that others may see as barriers, you say, well, which way am I going to go up? How am I going to get up this mountain? Am I going to go this way, or dig a tunnel underneath? And I'll give you a perfect example of what I mean. When I first got to Penn State, probably the latter part of my first year, I started thinking about tenure, and I started thinking about truly about the fact of, so how am I going to travel with all these young kids and do all these, give all these presentations and write all of these papers? Linda, how are you going to manage that? And in asking myself that question, I said, you better get real creative real fast. So just two things are an example of how I started thinking about things in a very different way. First and foremost, I never do one thing for the sake of one thing. Everything that I do has to count for 2 or 3 things. So I don't do that. Also, I'll give you another example. In thinking about, well, how am I going to get my work out there and meet other senior people who are likely to evaluate me? So I was sitting around one day and I said, you know what? Why don't you organize a national conference on Black families and bring all the scholars to you? So I didn't know any of the scholars, but I didn't know any of the scholars, but I had senior faculty member around me who knew those scholars. So that's how I met Toni, Antonucci, and James Jackson. Because as I was looking at people who were likely to review me for tenure, I said, I got to get to know James Jackson, so he's on the list for being on this conference. And this person is on the list for being, at this conference. And I said, well, okay, you can't let that only count for one thing. What else are you going to do to it? Walked myself up to the provost office at Penn State, and I said, if you want to be able to keep me here, I need money for a conference to bring these senior scholars here. He said, well, okay, if you're bold enough to ask for it, I'm bold enough to give it to you. So, for me, I will just say that because I think there was an element of who I was at the time that was very much in survival mode, I couldn't invest energy in worrying about what the stumbling blocks were. I always had to keep my eyes looking forward and say, you are solution-oriented sister, so you better figure this out.
Amen. How are we doing on time here? Because I tell you what, I've been sitting up here a couple times, and this panel is the one that I see more heads nodding than any other time. So people are connecting to what's going on here. How are we doing on time? We're done.
Well, can I just say one thing? I mean, there's some nice things about this job, right? I've been all over the world. Edie Aguilar and I, we went to Cuba, Mexico. I've been to the Caribbean, China. Italy, I've been to several places. Oh, and of course the U.S. But so that I value that. That's something good, and I get to meet new people. I get to collaborate and really meet people that are scholars and icons in the field, Linda. And I get to hear about new ideas and new ways of looking at old things. So for me, that really keeps me going.
Well, on that note, I guess we are up time, but I really want to give you both a hand, please. It's just been wonderful. Thank you so very much.
Hello? Can you hear me now? Okay, very good. Well, my friends, this wonderful inaugural conference, the first of its kind on Black men's brain health, is drawing to a close. And now we're going to have final comments by Dr. Percy Griffin and from the Alzheimer's Association, who has been an incredible leader in the association and goes all over the country representing the association so well to keep this work moving forward. So we'd like to have some words from Dr. Griffin, and then I'll give you some parting last words. Thank you. Please join me in welcoming him.
So, first of all, I want to thank all of you for, oh, yeah, hi, I'm tall. I want to thank all of you for sticking through the entire conference with us and being here today. Give yourself a round of applause for doing that little bit. So, when I got on a plane and I was coming to this conference, I thought I was just coming to another conference. But I came to be at the forefront of change. Change that is long overdue in Black men's brain health research. We need change in recruitment, retention, and representation. But this change is not going to happen overnight. This conference is a step in the right direction. We need to build strong, lasting community partnerships because the science of inclusion cannot be built by only scientists. Partnerships that value the input of the community. And when I look in the room today, yesterday, I see something that I'm not used to seeing at science conferences. The community is here with us, speaking with the scientists. This has been a golden opportunity to build these relationships and partnerships so that we can accelerate the science and make discoveries that benefit everyone. We need to start breaking down these silos of scientist versus community to work together to drive the science forward. Now, this conference is breaking the mold and changing the status quo. So I'd like to thank you, Dr. Rivera-Mindt, Dr. Turner, and Dr. Carrillo, for your visionary leadership in organizing this incredible conference and your unwavering dedication to the cause. Now, a critical component of this conference is the Emerging Scholars Program. 9 extraordinary scholars who will help drive the field forward through their work in the community. I want to thank Dr. Tam Perry and Dr. Desiree and Michael Molesky for their leadership on the Scholars Program. And our scholars come in with a range of experiences, from the molecular all the way up to the legal considerations. Because representation matters, community engagement matters, and these scholars will do work that exemplifies these values. The relationships that you will build and the discoveries you will make will serve as a shining example of how to do work in the community. So look around you today. These scholars are your colleagues, and they're eager and ready to work with you. They represent our commitment to plugging this leaky pipeline that has excluded Black men from brain health research. Representation matters to the people in the community. We need to see people that look like us doing research about us. And when we increase representation, we enhance recruitment and retention. Now, I'll share a quick story that happened to me just last night. So I was coming back to the social mixer at the Galen Center, and I got to the COVID checkpoint. I still had my name tag on, and an older Black gentleman stopped me and asked me, "You have a PhD?" And I was like, "Yeah." And he gave me a fist bump and congratulated me. And that reminded me that I wasn't used to seeing Black men with PhDs, and reinforced how important what we're doing here today is. Now, the Black men's Brain Health Conference is just another example of the Alzheimer's Association's commitment to diversity, equity, and inclusion in everything that we do. You've heard from Dr. Hill, you heard from Edie and Tia Delaney on all the amazing work that they're doing in building these amazing community partnerships. The Medical and Scientific Relations team at the Alzheimer's Association is working with the DE&I team to put on the Addressing Health Disparities Conference, which is happening June 21st and 22nd in Washington, D.C. as a hybrid event. At this meeting, we will promote dialogue and provide practical considerations for doing research in the community. Also, we're going to identify gaps today that can be addressed to make sure that Alzheimer's and related dementia research benefits everyone. Now, one of the key priorities to promote better health is early detection and diagnosis. And in Alzheimer's, brain imaging is one of the tools that we use for early detection and diagnosis. This is why the Alzheimer's Association is also leading the New Idea Study, which will recruit, as part of the participants, a majority of underrepresented people from underrepresented backgrounds in this study to provide the evidence for coverage of imaging. Now, you've heard about the importance of lifestyle interventions, be it sleep, be it diet, be it exercise, but we need to understand how much of what kind benefits what communities. Through the U.S. Pointer Study that the Alzheimer's Association is leading, we're going to recruit a representative cohort of individuals to evaluate lifestyle interventions to provide an accessible, sustainable, community-based lifestyle intervention recipe to reduce the risk of developing cognitive impairment. Now, our commitment is also reflected in our funding. For every grant that we have through our International Research Grants Program, we have a diversity version. And I believe Dr. Rivera-Mindt received one of these grants as well. Now, in closing, I'm going to leave you with something small from back home. I'm originally from Ghana, and I'm going to leave you with a proverb that says, Tikoro Inkwejina, which translates to one head does not go against the council. It takes a village. Robert, Monica, thank you for the Black Men's Brain Health Village. Monica, I'll pass it to you.
Wow. Whew. Please remind me never to follow Dr. Percy Griffin. I'm going to switch microphones here, so just give me one moment to resettle myself. Can you hear me? Okay. So I want to be here so I can see you all better, since we're about to end this conference, and I want to see all of your shining, beautiful faces one more time, and send our love and energy to everybody who's also joining us on Zoom right now. So first, let me just reflect on the mission. As Dr. Percy Griffin already beautifully spoke about, this is the first conference of its kind that we're aware of, where we bring together our sistren, our brethren, and our non-binary friends to think about and figure out ways that we can advance brain health for Black men through research, through community building, emerging scholars program, a research registry. These are disruptive ideas, what we're talking about here today. This is transformative science that we want to do together with communities so that we can reduce Alzheimer's disease and related dementias. We can reduce the impact that this has on our communities, and we can move forward together in linked arms. So with that, I'm so grateful to all of you on behalf of Dr. Turner, Dr. Maria Carrillo, of our entire team. We are just so grateful that you came here with us to share in this mission, this very important mission today. So a couple of housekeeping items, and then we're going to start doing roll call. So for housekeeping items, I'd like to see the slide on the survey, please, Jose. There it is. So if we are to keep projects like this, conferences like this going, we need your feedback. This is the way that you provide material support for us. You scanning that QR code and providing a survey, giving us all your survey, items, letting us know what you thought. It means a lot so that we can provide these data to learn how we can do better, to inform us for the next conference, and also to show the National Institute of Aging, who supported this conference, who we are very grateful to, what people thought, what went right, and how we can do better. So it's really important. So please, everybody, while you're wrapping up and during the mixer, please make sure to complete the survey today. And if you didn't complete the one yesterday, I have, thanks to our fearless coordinator, the QR code for yesterday's conference as well. So if you need that, I'll leave it here on the podium and you can fill it out. So please fill that out. Okay, so that's one important piece of housekeeping. Next important piece of housekeeping is food. So if you see, we have some leftover food on both sides and some waters. Please take them, eat them, enjoy them during the mixer. I'm not sure if we have more food coming, but it's a sin to waste food, and I hate to do that. So please, I grew up food insecure, and so to me, to see food go to waste just hurts my heart very deeply. So please make sure to take food, and especially for our emerging scholars, do not be hungry. And so please eat. And finally, we are going to have the social mixer after this, and it is cash bar, but you are welcome to stay and talk with us. Let's keep mixing and creating new bridges, new ways to collaborate and work together. We would love to see you during that mixer, which is centered on the Alzheimer's Association today. We are so glad to have the Alzheimer's Association as our partner. And with that, it's time for roll call. So roll call. I'd like to thank everybody in the Black Men's Brain Health team who has been such an unbelievable part of this. Many of you are here, many of you are joining us remotely, but I'd like to see, are there any oversight board members here today who have helped guide us and help us get through this process? Oversight board members, like Dr. Burton, Dr. Pugh, Ms. Pugh, stand up, please stand up. Toni Antonucci, stand up, stand up. Thank you so much for being here. We are so grateful to you and your guidance for helping us make this happen. Thank you. Next, I want to also thank our planning committee, who has done such an unbelievable job of bringing this all together and guiding the specifics of the content of this conference. Are there any planning committee folks here? Let's see. So Dr. Maria Aranda, Edie, yes, Aguilar, others? Do we have others here? Oh, well, thank you very much, planning committee. Thank you. Our speakers, whoever has spoken today, could you please stand up? Speakers. Yeah, yesterday and today. Thank you so much for your amazing words and sharing so generously with us. Our faculty mentors. I see Dr. Roland Thorpe is here. Other faculty mentors, if you could stand up. Susanna, where's Susanna? Thank you. We are so grateful to our faculty mentors who are taking the charge with our Emerging Scholars program, so thank you so much for their support. And I want to have take another bow, Emerging Scholars. If you could please stand up and feel the love from the community. We are so excited to have the next generation of leaders here with us, so we can say we knew you when. Thank you so much. Wonderful. And last but not least, for the Black Men's Brain Health Initiative, I'd like to have all of our team members, especially Dr. Stroman, who has been such a fierce leader, coordinator, through thick and thin. You have made this happen. We are so grateful to you. Thank you so much. So to you, Dr. Stroman, take a bow, please. Thank you. And all of our team members, Kalpena, all of our volunteers, Kayla in the back, Michael, Yasir, everybody, thank you so much for making this happen. We are so grateful to you. So that's our team. I also want to acknowledge USC. Thank you so much to USC. Wow, what a dream to be here. This beautiful Founders Club at the Galen Center. We are so grateful to the Roybal Institute. We're so grateful to President Folt for joining us here. That means a lot. That shows a lot of institutional commitment for how important this initiative is. We also want to thank Drs. Aranda and Aguilar for their incredible support as well and for being here. And I want to give some love to tech. So Elijah and Taylor, USC, holding it down tech-wise. Thank you. Elijah's in the back. And Jose, thank you. And Jose from the association on the slides. Thank you very much. And finally, I want to just remind folks, that this would not have happened without the generous support of our funders and our supporters, including NIH, National Institute of Aging, the Alzheimer's Association, both nationally, the DEI office, and as well as the Northern and Southern California chapters who've been so incredible. Want to give a big shout out to UC Berkeley, School of Social Welfare as well. Amazing academic partners. Yeah, absolutely. We want to thank the NFL Alumni Association, AARP, yes, the association. The players yesterday were just incredible. We're so grateful to every single one of them. AARP, I hope I don't mess this up, the American Association of Male Nurses. Close. Thank you so much for being here and representing. It means so much. And all of our other supporters, Sports Management Agency, all the study coordinators and project managers here who are on the ground, community liaisons, every single community-based organization. We see you, we appreciate you. We don't have many opportunities to have conferences like this, and we are showing that si se puede, yes, we can do this. If we do it together, we will do it well. So last and not least, thanks to each of you just for being here this whole time. Give yourselves a round of applause. We're so grateful to you. Thank you so much. Thank you. So as we wrap up, I also want to point you to the screens because we have our email address, so please stay in touch. If you have any questions, anything else that you want to talk with us about, please reach out. We want to hear from you, and we will be here as well for the social hour. Dr. Stroman. Oh yeah, so I'm going to officially close this conference now, which I can't believe it's gone so fast and it's been a really full 2 days, but thank you so much for closing. And I'm going to ask everybody who's part of the Black Men's Brain Health program, including our emerging scholars, to come up for pictures. Thank you so much, everybody. Enjoy, have a good night. Be safe and well.
Big group? I think so. Can we get the scholars to come on up? Please do. And then you guys.
Wow, I've never followed you again. You slayed it. Thank you. That's the way. That's the way to close it out. That's the way to close it out.
I couldn't say for 5 o'clock, so I wrote a speech.
Oh, it was fantastic. It was fantastic.
I just want to start with the scholars first. You guys, come on up.
Let's go. Black Men's Brain Health folks, please come to the stage.
We've got it.